Bakshi is from AIMS Mangalagiri, and Dr. Sadat Qureshi is also professor from People's Medical College, Bhopal. Sir, just can you just brief the about the case? You are
Yeah,
live here.
Dr. Dhaval is there, so he is going to tell about the history part. So over to Dr. Dhaval. सुनो माइक है? ये वाला दे दो माइक, सुनो ये वाला माइक दे दो सर को. हाँ, रुक जाओ एक मिनट. ऐसा करा मेरे माइक मत लगाना क्योंकि आई विल बी आंसरिंग लाइक दैट.
Good morning, sir. Dr. Sadat Qureshi here. Actually, we are not able to hear, I think.
Yes.
Picture is very clear.
जाएगा सर स्क्रीन.
Sir, can we get the endoscopic view?
हाँ ये भेज लो. Yeah. Hello.
Yeah, hello.
Am I audible?
Yeah, sure.
Yeah. So good morning all faculty members.
Good morning.
So first case is, this patient is presented with the hoarseness of voice since last 3 months, and he is a owner of hotel. So Alam is 47-year-old male, and here is a flexible laryngoscopy finding. Okay, so this is all about first case. Over to Dr. Rakesh sir.
Good morning, all. At the outset, I would like to thank Dr. Vikas Gupta and the LVA Association for giving me this opportunity to operate from here. Though I registered myself for the physical meeting, but due to NABH inspection, I am not able to attend it. Lot of preparation is going on in the hospital. So we are at the inception of 1 year of our hospital. So we are going for NABH inspection. That is why I am suddenly have to cancel my attendance in Lva Summit. So coming back to the case, he is a young patient with a professional voice user, and he presented with a vocal fold mass on white light endoscopy. You must have seen it is arising near the anterior commissure. We don't know whether it's right side or left side. So patient is induced now, and the position of patient is in a Boyce-Jackson's position. The laryngoscope you can see in the PIP, it is didolaryngoscope. And if you see the position of the OT table also, just tilt it. So it is flexion of neck over the chest, and there is an extension of atlanto-occipital joint. And the suspension system which I am using is something like a gallows system. Just show this suspension system. This is angled one. Hello?
Yes, sir.
Yes, sir.
Can you see that? So this is a gallows system of chest suspension. Normally in most of the places we use Levy chest support, but here I am using is a gallows. So I am very happy with this suspension system, and this I am using it for more than 6-7 years, pre-COVID times. So I am very happy with it because there is nothing which comes over the chest of the patient and nothing over it, and the force is directed mostly at the mandibular level as compared to the maxilla. So this is the advantage of gallows chest support. So I'm using is a monitor which I'm using is Olympus 4K. Olympus 4K, and this is in 1.2 magnification. I'll change it to 1.8. 2 is the maximum. And here we see the mass there, but if we reflect this mass, it is arising from the right cord.
Good morning, sir. Sir, Dr. Kavita Sachdeva. Sir, can you
Good morning.
explain the position of the patient and what angulation you require? Proper
So this is
position
a Boyce-Jackson position. Flexion
okay, the extension
of flexion of neck over the chest,
right.
and there is a extension at atlanto-occipital joint.
So do
And if you see the position of the table also, this is, if you see this from the horizontal plane, it is almost 15 centimeter above.
okay, above.
So,
right.
above. So this is ideally described by Jackson's position.
And
So
the
we can
laryngoscopy
make it
is
more. We can make it more. And here my assistant is just putting a finger there. So we don't use any strapping if it is a simple straightforward case. If it is a malignant case, then we use a strap covering from one side and it is going to the other side. Like we do it for either with a bandage or something which is cloth type, and we can fix it over the cricoid. So, and the position of didolaryngoscope is very important. You should be able to see the anterior commissure. And now you can see the anterior commissure there very clearly. So,
yes.
sometimes you require an adjustment of the suspension system. Use a telescope so that you can glide it like few millimeters up and down like that. So you adjust it accordingly because this is a benign, it looks like a benign disease, but sometimes you are doing a malignancy, you have to readjust the laryngoscope very often and removing the false cord like that, and you have to go to the root of the growth. So what I'll do is I'll proceed straight away with the hydro-dissection, and I will first try to locate it where is the base of the polyp. It's a good big polyp.
Good morning, sir. I
Good
am
morning.
Dr. Anil Kumar Jain.
Good morning.
Sir, what radiological evaluations were done preoperatively?
Since in NBI it doesn't look like a malignant lesion, so we don't get any specific test for it. NBI itself is a confirmatory test. Even if it is turned out to be malignant, it doesn't look like. Even if it comes out to be malignant, there is no problem into it if anterior commissure is free and posterior commissure is free. So now I'm changing it to NBI mode. So now you can appreciate it. Suction band kar do. So I'm again focusing it. And now with the magnification, you can see.
There's not much of feeding vessels also, sir.
The feeding vessel will be there. There's a slough is also there. So I'm not ruling out the malignancy, but even if it comes out to be malignant, I am taking care of margins. Because post dissection, NBI has got no role. But classically, it doesn't show any feature which is suggestive of malignancy. It looks like an inflammatory because of the size of this mass. There's a lot of slough covered over it. Not classically like, and there is a blood supply also there, but with my experience, I can say that I am not ruling out malignancy in this case. So we have to wait for the histopathology. But since I can see the root on the right cord, in the anterior 1/3 of the cord, so I am doing it as a hydro-dissection, and I will do it en bloc removal. So now I am injecting it. So preparation is, I put a patty down below it.
Yes.
So that I am protecting the bulb of the tube. Though it is a laser safe tube, but still because the bulb is can catch fire, so just to keep it.
So what size tube you're using, sir?
It is 6 number Mellingrod tube, now being supplied by Medtronic. So initially other companies were there, but I am very comfortable
That's a
with.
larger cup, sir.
They have got two cuff.
2 cups. Okay.
So proximal I fill with the methylene blue, distal one with the saline.
Saline. Okay.
So I'm shifting to the microscope.
Yes. And sir, infiltration, you used saline adrenaline?
Yeah, we use is a aldine in saline. They made it for I think it's a 1 in 10,000.
Okay, sir.
Setting वही है same है. So I'll show you the setting of the laser. So he can focus it. थोड़ा move कर दो उधर.
Zoom.
So now you can see there are 3 mode are there. One is continuous, super pulse, and repeat.
Yes.
And sorry, pulse. And if you see the modes, repeat, single, and continuous. Normally for the benign disease, we use the super pulse mode. And sorry, super pulse wave and repeat mode. ये लेजर पे लैरिंक्स पे है ना? हाँ लैरिंक्स पे लग रहेगा. हाँ ये आया. No, this is there. Okay, not so. So the setting is, if you see it, there is I think a lot of instructional course are there, so people will be knowing about CO2 laser. So this is a straight blade I am using. Shape is 2 mm. Depth is 1. 1 is indicative of not the 1 millimeter. It is indicative of time off. That is how long the laser is going to fire. So the laser is going to fire for 0.05 seconds. So this is mentioned 0.05 seconds. Is the time duration in which the laser will fire. And super pulse indicative of high energy. So it goes very high energy and it is in repeat mode. Then time off is very important for a benign disease. If we are doing it, we keep it at a setting like 0.45 or 0.35 like that. For malignancy, we are doing it very fast and we'll be doing it, we need a shorter pulse. So for shorter pulse, we change it to like this. For malignancy, we do it 0.10 or 0.05. So once you know about the machine, how the settings are there, because this is a live surgical demonstration. We are doing it and demonstrating it. So I want youngsters to learn that what should be the and how, because there's a learning curve with laser. It is not like you buy it and because if you see it is almost
Sir,
take
you told 0.05 for malignancy and 0.45 for benign lesions.
it is not like you have to evolve yourself. Whoever is your mentor, like my mentor is Professor Paretti, so I was trained like that. But in Tata, they use is for malignancy, they use a continuous mode and spot. They use a spot because most of their work sometimes they are doing supraglottic big dissection. So you need a high energy plus continuous wave. But for a benign disease, superpulse is the best waveform, and the mode we use is a repeat mode. So because benign means you have to give a very good voice to the patient. But voice is a secondary in case of malignancy.
Yes, sir.
Though it is important for type 1 and type 2 cordotomies, but it is not the important. If you are doing a transmuscular or extended cordotomy, the voice is secondary. Removal of tumor is important. So, because this patient, I want a complete cure also. If it comes out to be malignant, then I should have a 2 mm of safe margin with it. So that I can
One
reassure
thing,
the patient that nothing will happen. You come for a follow-up, regular follow-up if it is malignant. But if it is benign, go slowly. And my technique is slightly different from others because I use a continuous irrigation of saline, even in for benign condition, so as to have a very good heat sink effect and it will not cause charring.
sir,
And
one
since
thing I want to know at this point, what is the
yes,
suction mechanism you're using and
this
how do
is
you fix the suction
this is a
when you're using the,
didolaryngoscope. Yeah,
okay,
this is a didolaryngoscope. If you see from external picture, and it has
that is
got two
missing.
port.
It is missing
So
here.
it has got two port from the side, one
Okay.
here, one here. So
Right.
initially I used to do is I use a two port here. So two port here and there is a T connector here.
Okay.
So with a single machine of suction machine, I can manage it in that way.
Irri-
But
irrigation
for a
design.
benign disease, like if I'm firing it very slowly, I don't need that much of
Suction.
plume sucking. So plume sucker is this. There is another section which is I kept it like this for sucking out any saline which my assistant will be putting it inside the airway. And
Okay.
otherwise, I use only
Sir,
those.
one more important question. With a microscope, it is very difficult to maneuver such a long instrument. So what is the
No,
trick
you have to have a varioscope. So varioscope, you can go from very distance also.
Varioscope. What is
So you cannot manage with without a
400
varioscope.
mm lens?
You should have a very good varioscope. Focus हुआ? नहीं हुआ. चलो. थोड़ा सा उसका वो कम करो. हाँ, अब हो जाएगा. ये रुको. So now, other important thing with the microscope is your the size of the light illumination should not be too big. Otherwise, and अभी देखने दो. Let me see first. Comfortable. So, if the size of the light beam is big, then you will have a reflection. And now you can see lot of reflection is there. But if I focus it like this, small. Now you can see it better. And if I zoom in, then you can still see better.
Yes, sir.
So optics is very important. One should have a very good microscope to do this type of surgeries. Less tiring, more precise, and less time consuming. पानी दो. रुक जाना. Just a minute. Can you are getting the image?
Yes, you are getting it.
I am doing it in high magnification. चलो रेडी करो. रेडी करो. हाँ थोड़ा ब्लेड साइज छोटा कर देते हैं. चलो हाँ रेडी करो.
So you have using dot or just linear line?
Yeah, line.
Line.
I have reduced the size also to 1.5. थोड़ा सा उनको करो. Like so now because of the reflection I was not able to see it. हाँ बस ठीक है. Yes. पानी डालते रहो.
So by suction, you are retracting and dissecting the same thing.
Yeah, the same. Like malignancy we do it.
सर ये suction अलग type का है? Special
हाँ
one?
ये वही है black finish.
Okay.
We use this for
Regular
cautery also. हाँ yes.
Regular one, right. Insulated one.
Next patient ready रखना है ना. We have 3 cases. So if you see, this is a very old laser actually. This is Boston luminous laser, but it still almost like a new laser.
What I appreciate, there is no
No
smoke.
charring, nothing will be there. Because of continuous irrigation.
You are
The same,
continuously
the same
irrigating.
principle we follow in papilloma surgery also.
Okay.
So papilloma, lot of papillomas are there. So now I'll shift to this side. थोड़ा सा प्रेशर कम करो आगे से. भाई मत डालो. फॉरसेप कफ. दो पैटी थी ना, एक है. दो है एक. वो फॉगिंग हो रही है एसी से. लेंस की एसी बंद करो जरा. पानी. बस. कीप सेकंड पेशेंट रेडी है ना. डॉक्टर धवल, हाँ वो उनका वो लगा लेना, IV लाइन लगवा देना. एवरीथिंग यू कीप इट रेडी, है ना? So it is a enucleated like en bloc removal. Stand by. So
Sir,
after that, after the dissection, we do is cleaning with the patty. If there is some charring is there, because if you leave some charring there, then there is chances patient will develop granuloma formation.
Sir, very nice and clean dissection and wonderful demonstration, sir.
good.
Everyone
So
is very
thank
happy over
you,
here, sir.
thank you,
Sir,
thank you.
One
And the
thing,
house is full.
How
sir,
this for?
steroid pre-op देते हैं कि post-op देते हैं?
No, we don't give any steroids, madam. And
अच्छा.
we just give analgesic and 3 to 5 days of antibiotic. PPI we give it for 1 month.
Okay.
So in this type of like submucosal injury, it will take around almost 10 to 14 days for the complete healing. So we call the patient after 3 to 4 weeks. If we
Okay.
and
So this is
depending
a
on
day
the
care. You'll discharge the case evening,
same day,
same day.
same day. And
Live dissection, sir.
so this is the first case. And second case is Dr. Dhaval is going to tell about the second case. इसको ऑफ करो, जल्दी से निकालो, इसको शिफ्ट करो, है ना? So I'll just show you the trolley that normally in microlaryngoscopy, what instrument we keep it. ये हटाओ. So these are the for the benign, for any benign disease I'm using is this. निकालो धीमे धीमे, सस्पेंशन हटाओ, सस्पेंशन हटाओ, सब हटाते जाओ जल्दी. So this is I'm using is this cystoscope, 0 degree for all my tracheal work, and even if for vocal fold I use this 4 mm cystoscope. So this I got it from Olympus. Other scope I'm using high definition 0 degree and 30 degree, and sometimes I use is a 70 degree telescope for if I am doing a dissection in the below the cord or infracommissural growth. Infracommissural growth, then sometimes we use is a 70 degree telescope. So, and as far as forceps are concerned, these are the basic forceps for benign. These are the Bushire forceps from Indian company, I think either Kalilkar or Kalilkar Surgicals, and various types of cuff forceps we use. And nothing very special about it. I normally use this infiltration needle and use this insulin syringe, 1 ml syringe for infiltration, because sometime with 3 ml, it is 3 ml syringe, it is difficult to go through the laryngoscope.
Yes, sir.
So as far as instrumentation is concerned, we have got Dido as a workhorse. This is a workhorse for all laryngeal cases. This is made from Callistos, and this one should have it because it can go anywhere, means for a very difficult, and this is Indian make Klein saucer laryngoscope, which I modified it for my high flow cases. So this has got 2 holes on either side and 6 holes on the back. So when I'm using a high flow, like for if I'm doing a dissection on the posterior larynx, so I don't use any tube. So take out the tube, and in apnea I use this laryngoscope so that I can operate for longer period of time without needing any apneic technique like tube in tube out technique for airway surgery, especially in posterior larynx, or if the disease is somewhere close to the endotracheal tube on either side. So this is a very useful tool because we have observed that once you block the glottis, the high flow effect will not be there. But with the hole, you can continue to operate because oxygen is continue to go into the airway. So maybe if I'll get a time between the case, reversal बोलो reversal करें, है ना, जल्दी से reversal करें. So in between, I'll just show you what are the anesthesia for the airway surgery, which we normally keep for any airway cases. So, and regarding the laser surgery, there are few forceps which are important. One should have it once you start a laser surgeries. और forceps थी वो दिखा दो, laser की forceps. So this one is from Callistos, right and left, but now Indian companies also manufacture this type of forceps. So they are also very fine and very good. Even
Can you focus the tips of these instruments?
yeah, focus tip ko. So this I use it for. I'll show you. I have one case of posterior cordotomy also. So how to control a bleeding? We use this type of forceps, bipolar forceps. Touch it with the unipolar and this acts like a bipolar forceps. So right and left and straight. So these type of forceps, this is also manufactured by Indian company, very stout, very nice forceps. This is from Callistos, but this is from Kalilkar Surgicals. So this is light and this is left. So you can use it for controlling the bleeding, especially in cases of malignancies. And there's another one which we use it for supraglottic work is clip applicator. So clip applicator, we use it for if we have to tie the pharyngoepiglottic fold, we have to control the bleeding, then we use a clip applicator. So I'll show you the clip applicator also. So with 100 and 200, we can use a clip to control a bleeding from PE fold. Regarding the Lindom vocal fold spreader, this is one of it. And there's a one more which is, this is bayonet shape. If you see the shape of this, it is bayonet shape. There's another one which is straight spreader. So straight with, there's no bayonet, this angulation is not there. So you can use that straight spreader for doing a dissection in the interretinoid area. If there is a type 1 posterior glottic stenosis is there, that straight one is very effective, or you can use this one in a reverse way. So this one will go like this in the posterior larynx and it will spread the posterior glottis like this.
Yes, sir.
So one can appreciate that, one can use it like this. But otherwise, another one which we have designed is a straight one without a bayonet. So if we are doing a posterior cartilage grafting like English procedure, so that straight one is quite good to do a submucosal dissection, even with the held end laser also. One can give a posterior incision in the cricoid and do the dissection there also. So that is a variation of classical vocal fold spreader, Lindom vocal fold spreader, which we use it.
So just now you told the vessel, for controlling vessel, you use 100 and 200 mm. So are we talking about harmonic scalpel or just a cautery or something like that? To control the bleeding, you just...
No, I use normally if, like I was doing one this 10 days back, one paraganglioma, supraglottic.
Right.
So in that, we place 2 clips on the PE fold because that is the main
So
supply.
these are
Which
the Liga clips which we use for vessels.
yeah, Liga clips.
And same Liga
So
clips, no?
है तो आपस clip applicator दिखाओ.
100 to 200.
So it's the same like
Smaller one. 100 and 200, right?
200. Yes.
Right.
So, but unfortunately, that patient in my career, that was the first secondary bleed in my career. So patient came with after 5 days with bleeding. So then we have to again take the patient for to control that bleeding. That was the first case in my career for secondary hemorrhage. And it was actually my miscommunication with the patient that the BP was not controlled properly because of some reason. The doses were skipped, and patient was diabetic also. And fifth day, she bled. So these are the actually clip applicators. So
when they are exposed, they don't irritate the larynx. Like we apply the clip since they are exposed there in the airway.
no, it was not malignant actually.
Like patient is not irritated by cupping or something like that since we are putting a foreign body there.
Then no problem, madam. Because even if for this thing post-glottic stenosis, for a flap surgery, we use clips to fix the flap.
Acha,
So,
that is a good idea, sir. Excellent
even if it
idea.
is there, patient will cough
So
out.
difficult, yeah.
So you can use it. So this is by Carlistos only. So I use it very often. Few other armamentarium I am having it. Maybe I'll show you during the time of second case. These are the various types of balloon and balloon and this one.
The one case, if do you
High
plan to
flow.
show by a fiber also? One fiber can you use for larynx? So we will learn what is the right technique to use a laser fiber.
Actually,
also.
this machine which I am using is a very old machine. This year I am going to buy the new one because unfortunately Boston has stopped manufacturing this laser from 1st of January. So it will not be available for sale. It is a very sad news for all the laryngologists that Luminous will not manufacture any more laser. But for next 10 years, they are going to provide the services. So, and very few limited units are available only. इसको हटा दो. So I'll just show you one of my PPT so that we'll utilize the time. And just give me 4 or 5 minutes. I'll come back again and take the lecture on anesthesia and airway surgery, so that you will have certain idea how the anesthesia is moving ahead. Regarding the high flow also, high flow I am using it very often in airway surgery. So that also I'll cover up. If the organizer allow me, if the moderator allow me, I will just take 2-3 minutes. I will come up with the.
Yes, sir. We would like to listen to that lecture, sir.
Yes. Just give me 2-3. What?
Audience, do you have any questions?
नहीं नहीं ऑन करा देंगे ना सर. हाँ
लैपटॉप कनेक्टेड है.
आपका जा रहा है ये सर.
बस इधर कैसे बैठेंगे?
नहीं ये रहा सर.
ये वाला क्या है? मेडिटेशन है क्या सर? हाँ. कैमरा बाहर. सर कैमरा बाहर होगा?
नहीं, जरूरत नहीं है इसकी साइड से.
प्रेजेंटेशन का रिकॉर्डिंग तो नहीं करना था सर.
हेलो. हेलो. थोड़ा शांत रहना. हेलो.
Yes, sir.
Hello.
Yes, sir. We are with you.
मैं कह रहा था जो मॉडरेटर का नंबर दे दो. हेलो.
Sir, we can hear you, sir.
मैं shall I start?
Yes, sir. Yes, sir.
Okay. Hello. Yeah, so I'm going to talk about anesthesia and airway surgery.
Sir, we are not able to see you. The display is
But
not
you are
there.
able to see the slides, na?
Yeah, yes.
Yeah,
Anesthesia
you are
and
able
airway
to see the
surgery.
slides. Okay, then I'll
Yes.
continue with it.
Okay, sir.
So
Okay.
anything is there, then you just interrupt me because this is I don't want it should be a one-sided lecture. You can interrupt me anytime and ask me any question.
Sure, sir.
If I'm not able to answer it, I will say no. Otherwise, I will pass on to the anesthetist. Okay.
Sure, sir. Thank you.
So whenever we are starting any airway clinic or any airway center, so we assess the patient in office, discuss with the attendants. Lot of time is spent in consent taking, and not we concentrate only on stenosis. We see the patient as a whole. So it is not like that you have seen the stenosis and suddenly you plan it for surgery. Suddenly plan it for surgery. So lot of preparation goes out into it. So every stenosis is unique and every patient is unique. So whenever we plan it, we discuss it, and then we execute it and take action. So for a airway surgeon should be at the driving seat, and anesthetist is controlling the other end of that is the parameters and the drug dosing. So drug dosing also has to be discussed with the anesthetist before adventuring into the field of airway. So one should have a very good knowledge of all the drugs which anesthetist is going to give and what are the limitation of it. So regarding the most important part of airway surgery is that is what medication he has to give, and for that the depth of anesthesia is the most important part. So depth of anesthesia, the airway anesthetist should know it beforehand, that you should not land up in a uncomfortable position, that you are not able to ventilate and you are not able to intubate the patient. So giving a relaxant in any patient of airway, one should have been very careful while giving it. So how narrow is the tunnel? One should know it, and doors of the tunnel are mobile or fixed. One should have that knowledge that whether one will be able to intubate that patient or one has to manage it with a high flow. So depth of the deep of the tunnel, the length of the stenosis is important, and depth of anesthesia is the most important part. So if you look at this algorithm, that is surgery, general anesthesia, arousals, awareness, memory, and recall. So I made it this relaxant and movement as a secondary because you can tolerate the movement of the patient, but if you give a relaxant and airway is highly compromised, then you will land up in a problem. So assessment, planning, risk stratification, communication, maintaining the airway, surgical access, continuous communication, and post-operative also is very important for all such patients who are coming out, considering patient is breathing through that narrow airway for a prolonged time, chances of pulmonary edema, the pain management and sedation, monitoring and follow-ups. So I'll just show you one or two clips like this. Severe respiratory distress in a baby. And this is a grade 3 respiratory distress where the patient is almost going to the work of breathing, the work of respiration is almost going off, and this patient has a airway which is filled with papillomas. So pre-oxygenation for any airway surgery is very important. Pre-oxygenation, like whatever way you can give pre-oxygenation, by bag mask or by high flow. So both takeoff and landing are important. We have seen it recently in Ahmedabad. So takeoff is very important and landing is again a very important part in airway surgery. And you should not land up with CVCI, that is cannot ventilate, cannot intubate series. So healthy pre-oxygenated patient, the safe apnea time is 8 to 9 minutes compared to 1 minute if you are breathing the room air. So how to improve the apnea time? That is by giving pre-oxygenation. So 88 to 90% marks the upper inflection point for oxygen hemoglobin dissociation curve, and that is the most important part of it. Knowing about high flow, one should have that knowledge that oxygen consumption during apnea is approximately 200 to 250 ml per minute. When the person breathes 100% oxygen, this washes out the nitrogen, increasing the oxygen in the lungs is 3 liters. So factors that decrease the safe apnea time are various. So we have to see these factors before taking the patient for apneic surgery, like doing it without tube anesthesia or doing it under HFJV, high frequency jet ventilation. So physiology of apneic oxygenation, one should know it. In a healthy apneic patient, as I have told you, that 200 to 250 ml of per minute oxygen will move from alveoli into the bloodstream, and in reverse way, 8 to 20 ml of per minute of carbon dioxide moves from alveoli into the during the apneic phase. So what this high flow does? So there is a mass flow of gas from pharynx to alveoli. And what does high flow does? It fills the airway with 100% oxygen, and that is how it replaces the nitrogen. And if you see the picture here, 250 ml per minute is going into the alveoli and 10 to 15 ml is coming out as a CO2 from alveoli, from the bloodstream to the alveoli. So what high flow does? It flows exceedingly expiratory flows, flush the upper airway, lowering concentration of CO2. So it improves that the dead space that is in nose, nasopharynx, pharynx, larynx, trachea, everything get filled up with 100% oxygen. So I'll just show you few of the important videos where high flow can be used. So this was an article which I remember it. I read it in 2017, which was when it was published, and then I discussed with my anesthetist. So that is how we purchased this machine. It was not very costly that time. Still, it is not that costly. So this was an article by Dr. Anil Patel, and it studied the patient in apneic phase. That is, what he used is a relaxant there, and he used a high flow without tube anesthesia, and all patients were around 30 BMI, and he was able to achieve apnea for a prolonged period. So I am still in constant touch with Anil Patel. So whenever I have a problem, so I discuss with him regarding the. So Thrive was basically transnasal humidified rapid insufflation ventilatory exchange. It was used in patient with high flow machine used with a relaxant. So even in patient under relaxant, you can use a high flow and it will give a prolonged apnea time. But normally in airway surgery, like grade 3, I don't use a relaxant. If I get a good airway, like grade 2 stenosis, then I use his relaxant also sometime, but it is not the rule. So I usually go in a spontaneous breathing patient using total intravenous anesthesia. That technique also I'll show you just now. So mechanism of high flow is wash out the nasopharyngeal pharyngeal dead space, reduces the airway resistance and work of breathing, improve lung compliance, and providing and distending end pressure to the lung. And this is what I was talking about, spontaneous respiration using intravenous anesthesia and high flow oxygen. That is stive HI. That is when the patient is breathing normally. And what we usually do, we prepare the patient properly, like elevating the head and of the patient to 30 degree and start high flow at least 10 to 15 minutes before the surgery. Then give various types of blocks like superior laryngeal block, transtracheal block, then block in the oropharynx at the near the tonsillar pillar, then use 10% spray and start with the total intravenous anesthesia using either dexmedetomidine with propofol, and then we bring down the patient after 10 to 15 minutes and start with the airway procedure. Then discuss with the anesthetist because the depth of anesthesia is very important. So this is a machine which I am still using it. It has got a high flow. So normally what we have in vaults and other places we have 15 liter, but this high flow has got a manometer of, it can deliver 70 liters per minute. 70. So the dose of delivery of this high flow is basically for 1 year we normally give 2 liter per kg per minute, and for more than 10 kg weight we reduce it to less. So maximum flow we give is 60 liter per minute in adult patient and set the FiO2 from 21 to 100%. And there is another addition in high flow which is known as tracheostomy connection with the high flow. So this was recently shared by Dr. Anil Patel that this also you can use it for your patient in ICU. So they have found instead of TPs, patient is more comfortable with the high flow with this type of cannula, which can be fixed with the tracheostomy cannula, and then patient has a better wean of time as compared to the TPs. So this gives a humidified oxygen and patient recovery is faster with this cannula. As such, there is no big complication with high flow. In my series, almost 300, 400 cases, we never encountered any problem as related to our series. Initially, we have published 3 articles. So first was on airway series, 16 cases. Then we published 2 more publication. Upper airway cyst, we have used it. So I'm not going into the detail. I'll just show you the, I think, modification. I have already shared it. So this is a case of contact granuloma of the posterior glottis. And there is no tube as such here. And this patient is under relaxant.
So ये high flow वाले cases हैं आपके?
So granuloma was removed. After the granuloma removal, we injected steroid at the base of the granuloma. And normally, what I usually give is 3 unit of Botox also in such patients. So, so all the all the 3 things we do it. We remove the granuloma. We give local steroid at the base of the granuloma, and then we give 3 units of Botox to weaken the one cord so that chances of recurrence will not be there because of the friction. This is the second case of base of tongue cyst, difficult intubation using a high flow. And if you see that now you can see the airway very clearly after doing the aspiration. So high flow gives extra time and it improves the safety of the airway. This is a case of laryngomalacia. It's a very initial, almost 10 years old video. When we not using any relaxant there, now we use relaxant. So little bit movement is there. This is the anterior surface of epiglottis. Regarding the safety of CO2 laser or any laser with a high flow, though NHS has stopped using, not recommending use of laser with the high flow, but still in US, it's still been used as a in airway surgery, and even in papilloma surgery also it has been used. This is again a case of a web. One more case like subglottic stenosis. Assessment. Non-tracheostomized patient using a high flow. Releasing the subglottic stenosis. And now you can balloon also. Give local canacot at the edges. One of the most fascinating indication of high flow is I am using it, which has really changed the management of foreign body bronchus. That is using high flow in foreign body bronchus. So I don't use any ventilating bronchoscope. I just use a Macintosh laryngoscope. The whole series I publish is almost more than 40 cases where we don't use any ventilating bronchoscope. Just take out the foreign body with the optical forceps. So check bronchoscopy also you can do with it, high flow. So this is a total paradigm shift in management of foreign body bronchus using high flow, because many times we struggle with the, and if you see the response of the patient is very comfortable post surgery, no irritation in throat because of the endotracheal tube, and reversal is for a benign disease also you can use it for.
So would you like to know what is your guiding principle that these patients can be taken for high flow?
Can you repeat it, madam?
These patients. आप
Hello.
जो क्राइटेरिया क्या है सर जिसमें आप डिसाइड करते हैं कि इनको हाई फ्लो में हम ले लें तो सेफ है या व्हाट इज द क्राइटेरिया यू यूज
For foreign bodies.
नहीं nothing. This is this old person or very young children with subglottic. So we have to take a decision. Yes, these candidates can be taken under high flow. So do you have some criteria or you follow some guidelines? Yeah, you just take for every case.
No, not like that, madam. Actually, any case with grade 3 with a good lung compliance, a grade 3 stenosis or grade 2 stenosis, like that, with a good lung compliance, we take it for high flow. It is not like that every patient we take it for high flow.
Right. So
But
that's what I want to know.
not like that. So
And
when not to do, pardon.
in neonate with the subglottic stenosis also you use this?
Yeah, same. But we keep all the plan A, plan B, plan C ready. Like
Right.
we have cricothyroidomy set, low frequency jet ventilation. Low frequency jet ventilation. We have this thing, tube exchanger, sorry, not ventilating bougie. So even if the airway is 3 mm, we'll be able to maintain it. But regarding the most important point which I mentioned is the depth of anesthesia is the most important part. So I am at the driving seat, but the gear and the clutch and everything is under control of anesthetist.
Right.
That how much speed,
So it is a
with
teamwork.
what speed he has to give the drugs. So even if I am doing a balloon is a painful procedure. So I tell the anesthetist that be prepared, and as soon as we put the balloon, we don't inflate it, we wait it, and then we make a sign to the anesthetist, give a bolus of propofol. So once he made a bolus of propofol, then I can do a ballooning very easily. So depth coordination between you and anesthetist is very important because balloon itself is a painful, and once the patient moves, your whole suspension system, everything will will go on a toss. So suspension is fixed, nothing is moving, only the patient is breathing in and out. But if you create a painful stimuli, then patient is going to move. So depth is most important point, and that control will come only if you have a good anesthetist and good team with you. So that is, I think the next patient is ready. I'll go and take up that. So Dr. Dhaval is going to give that detail about the. Dr. Dhaval.
ये हमारे पास ये लोग तो होगा ये
Good morning, everyone. In the meantime, I would like to make an announcement. We have few slots available for the instructional courses and cadaveric dissection to be held today. The interested delegates can please register at the counter outside. Thank you.
Hello.
Yeah.
Actually,
Hello.
yeah, Rakesh.
Hello. Hello. Am I audible?
Yes.
Yes. Okay.
Dhaval.
Oh, yeah, sir.
Yeah. I'm Dr. Sachin Gandhi.
Ji, sir.
Just for a second.
Yeah, sir.
Just give my compliments to Rakesh.
Okay, sir.
Wonderful surgery, and
Okay, sir.
and just explain regarding the high flow nasal oxygenation.
Okay, sir.
The question being asked.
Sure, sir. Sure.
Yeah. Actually, high flow nasal oxygenation, high frequency jet ventilation, and intubation. So these are three different ways you can anesthetize your case of stenosis. I think broadly speaking, if patient is fit for anesthesia, means no comorbidities, the surgeries maybe you can finish within 25 to 30 minutes. Then high flow nasal oxygenation is a better choice. If surgery is going to extend, I mean, benign means polyp and all other things, whatever Rakesh has shown. If it's going to extend for more than 45 minutes, like laser cordotomy, malignancies, then you'll have to go in for jet ventilation. And if patient is, let's say, more than 65 years old with cardiac, pulmonary comorbidities, then intubation with tube out technique or continuous ventilation with protection of the tube would be a better method. Yeah, Dr. Dhaval, you can go
Yeah,
ahead,
sir.
please.
Yeah, sir. Sure, sure. So our anesthesia team ready with the second case. I will give you a short, brief history of second case. No, this one. Short. Okay. So this patient Sanjay Saxena, he is a 55-year-old male with the known case of type 2 diabetes mellitus with hypertension on oral medicines last 20 years. He was he was a history of CVA on 20th May at presented with unconscious state in some other hospital. After that, some neurological references and radiological investigation done. Diagnosis was made is hypertensive pontine hemorrhage and acute pulmonary edema. So tracheostomy was done on 22nd May. So till date, it is like more than 2 months. The tube is in C2. Patient came to our hospital for the decanulation. So on 8th May, 8th July, we did a flexible laryngoscopy. Here is the finding of flexible laryngoscopy. Okay, sir. So reactive granulation is there due to tube inside for the long time. Okay, after that, we advise the fees test for the assessing the swallowing part of the patient, but attender refused for that. So we ask attender to send a video while taking a semi-solid and water. There is a 7.5 number tube, cuff tube in situ. So in this video, patient taking a semi-solid food, but there is no coughing. So in this video, patient taking clear fluid. So patient able to take clear fluid. So planning was first we assess the airway. After that, we addressing the granulation tissue with coagulation or debrider, followed by balloon tracheoplasty plus injection Canacort injected locally. So over to Dr. Rakesh sir.
सक्सेना जी सुनेंगे देखेंगे क्या किया कोई बात नहीं ठीक है
एक आया नहीं है
कोई बात नहीं So, as Dr. Dhaval has told you about the history of the patient, so this is a very common problem. This patient, she got the scopy also from outside, and unfortunately, they have refused for scopy also here. Then they were showing the video. First, they came with a still image. So, still image, I said, I'm not going to assess. Means this looks like a grade 4 stenosis. So, dynamic assessment of the airway is very important. Without assessing the airway, how you can go ahead it. Another thing, fees test. Then said I asked the patient whether he can take the solo or not, solid and liquids both. So then they sent the video. So we thought that okay, might be the everything is normal. Because the planning is to decalculate the patient. Once we don't know the swallowing status, how we are going to decalculate the patient. So normally in such cases where the neurological deficit is there, fees is a very important test for decannulation, because if the patient is aspirating, then you will end up with other complications. Patient will go to the ICU and management will be done by the pulmonologist. So then she came with a video. So then I saw the video. Then again they said, we don't want to get the scopy again done. So then we have to reassure the patient that during the time of surgery, we are going to assess it somehow. So we assess it, the vocal fold movement looks normal, patient swallowing looks normal. So then we thought maybe we'll go ahead and plan it accordingly. On table, we plan it. So after looking at the video, it looks like a suprastomal granulation, which is one of the most common problem, especially encountered neurological patients who are dependent on it, who don't know the tracheostomy tube care. And lower airway, I was not able to assess it properly because for the simple scopy also, they were not willing to take it. So the most important part of taking this patient is looking at the proximal airway, then looking at the distal airway, then looking at the dynamic assessment that how this segment looks like, because many times patient on long-term tracheostomy might having a segmental tracheomalacia also. So segmental tracheomalacia or a collapse is there, because again patient will have a failed decanulation. So what I'm going to do is I put a high flow in the nose. High flow in the nose, I'm not using suction so often. And I remove the tracheostomy, I place a flexometry tube here. And now what I'm going to do, I'll assess the lower airway also to have a good look at the lower airway. So tube निकालेंगे आप deccuff करके और इसको बिल्कुल edge पे रखना है ना. So high flow is continuing at 30 liters, 40 liters. 40 liters.
Sir,
So we are giving a high flow there. Pardon. Yes.
Sir, regarding the aspiration part, without doing a fees, is it reliable that what we have seen that externally he's swallowing well? Sometimes they have these reservoirs in the upper part and
yeah, but it was a long video. Nikalo. It was a long video, so there are less chances that patient will have a something like a पूरा मत निकालो ना, इसको टिप पे रखो बिल्कुल. हाँ, टिप पे रखो बस, थोड़ा सा पीछे. Very reactive airway. If you see the rings, look, wait a minute. कोई problem नहीं. So what I do is, अरे यार ब्लड आ रहा है, सेक्शन दो. अब यही नहीं चाहते थे, इसका मतलब रिएक्टिव है ये. कोई बात नहीं, very good. So this is a very reactive because patient was on cuff tube, and if you see low down also.
So which scope is using, sir?
Posterior tracheal wall doesn't look good.
So
on the right side.
From audience about the scope which you're using.
This is the cystoscope I'm using, 4 mm.
Length, sir?
Length is 25 centimeter, yes.
And diameter, sir?
4 mm.
Okay.
So this wall also doesn't look good because they have kept the balloon inflated for a long period. Tracheal wall also doesn't look good. So this also a reactive type of mucosa. So my planning is to remove this simple suprastomal granulation and immediately I will downsize it. बस बस बहुत है चलो लो बस. So I will do one thing, I will remove it with there are various techniques of removing suprastomal granulation. Dr. Gandhi is there. So he might be having a different technique, I am having a different technique, someone is. So there are various school of thoughts on how to remove the suprastomal granulation. Professor Retter, Dr. Retter used to say he is using a giraffe forceps, upturned forceps, 45 degree to remove suprastomal granulation. One can use micro divider through the stoma through the stoma from the tracheostomy stoma. Use a divider there. Someone use a divider from above. But I found this cordotomy also is very effective in, especially if there is a soft stenosis like this. Like this one. So has to be very careful that how much has to be removed, because this is the maximum you have to remove it. Otherwise, you will going to damage that cartilage wall of the trachea and then will back again with the other thing which I follow is I immediately downsize the tracheostomy tube to 6 number, because it has been mentioned that the cause of this suprastomal granulation are multifold. There are 4 or 5 causes for these patients to develop these type of granulation. One is the old technique of using a fenestrated tracheostomy tube is one factor where many times senior people, even I've been taught like that, you make a hole in the tracheostomy and then patient is able to can talk. So that fenestration sometimes cause irritation of the tracheal wall that causes granulation tissue formation. Second is because the cuff is inflated for a prolonged period of time, this will cause lot of secretions which will be there, leading into secondary infection leading into the granulation tissue formation. And biofilm formation for a prolonged this thing. And if the angulation is not proper or not a properly sized tube is there, then there will always be irritation to the tracheal wall will be there. So there are many factors are there which are other environmental factors. Like in India, we have a hot, humid environment that also causes these type of reactionary changes. So what I'll do is I'll use a cobbler there. There are two points which are available here, MW and LW. So I think Dr. Ramalingam is there. Hello?
No, sir, not yet, sir.
Not yet. Okay, Dr. Ramalingam is very fond of, I think, cobbler. So I don't know how many of you are using it there. So I have both the tools there. I have this one is there, and then I have a Medtronic M4 with the skimmer blade is also there. So I can use both the instrument, but I'm using this cobbler because this is one of the instruments, but most of the ENT is having it. I was not a very good proponent of cobbler, but once I have seen results of Dr. Ramandeep, then I have become very fond of cobbler for soft stenosis, especially where my laser cannot go. तो कितने सेटिंग है 7 है ना ठीक है.
Also, it has an advantage of better hemostasis over microdebrider, sir.
Yeah, but only thing is the flow of water has to be controlled.
Yes, sir.
Because water will go below in the airway, but there is no harm. Saline has got no as such problem in the airway, because what they say for bronchoalveolar lavage also they use 10 ml of saline. So that is not a problem as far as airway, but you have a secure airway, you can suck it out through the endotracheal tube also. Excess saline is there.
Consider packing between the lesion and the tube in this
That
case.
is not possible because I have to take out this endotracheal tube. I'm not going to fire it over here only.
Okay.
तो आप ट्यूब निकाल दीजिए. So this is very small actually, what this thing, and this one थोड़ा सा ट्रैकिया को ऊपर की तरफ खींचना, दबाना है साइड से दबाओ ट्रैकिया को. हाँ बस very good. So he is pulling in the trachea up so that I will have exact how much. And the same thing can be done even with the cuff forceps also. There is no problem in using a cuff forceps. If you don't have anything, you can use a cuff forceps. The only important thing is you should not damage the cartilage. And other thing is try to downsize the tube as early as possible and use a uncuffed tube rather than cuffed tube. I think I have reached to my limit. Because I am also follower of Silsi, that is, I give lot of airway injections, steroid injections. So this patient, I am going to call him after 10 days. And if I found some granulation there, then I will give a Canacort in office.
From outside, from external approach, Canacort injection or from endoscopic?
Keep a flexible scope from the nose.
Yes, sir.
I go inside and then I use a Canacort. So I use in office only, but under guidance. So I use 1.5-inch needle and sometimes normal size needle also. ट्यूब डाल दीजिए.
Yeah. By transcutaneous or endoscopic, sir?
अरे फोर्स मत करो, नहीं गई है ट्यूब, नहीं गई है. हाँ अब गई. So now again you will see that there's some small, this thing is there. So थोड़ा सा पैटी देना एक मिनट.
Sir, is there a particular reason why we are removing the tube every time with the cobblator in place?
Can you speak loudly bit?
Why do we need to remove the tube with the coblation device? Is there any risk of
any powered instrument? It is always better, because if it gets stuck there or some, I don't know the fire safety, but you will have an exact excess of it, that how much you want to remove it. That is what because now I know that how much is still left. So this is basically a cartilage. So this cartilage is also collapsing here. Part of it, not cartilage actually, this is fibrous, more like a fibrous thing. So what I will do is, I will again try with the cobblator. And I will request my assistant to put a finger there, so that I will have a certain idea that this portion also has to go. This is not a cartilage actually. So अब आप ट्यूब निकालिए और फिंगर रखे रहिएगा.
Sir, how many times you have to revise these procedures? What is your experience?
No, actually, you after this serial injection of Canacort, you hardly require it.
Are you going
But
to
only thing you have to follow it for at least for 3 weeks. At least 3 weeks to 6 weeks.
Okay, sir. Are we going to, sir, dilate?
And in airway, we say that time is the biggest healer. So give some time, but follow these patients. So most of these patients are poor patients. So most of the subsequent upturn forces. So subsequent endoscopy you might have to do free of cost also. So you have to be prepared for it.
True,
Rakesh,
So yes, sir.
Rakesh,
Yes.
you just said about the possibility of a collapse of the
Yes.
tracheal wall there when you are removing the thing. So
Yeah,
I mean, any comments how to manage this?
Because what I'm saying is, time is the biggest healer. So whatever segmental tracheomalacia will be there. Segmental means collapse of the airway. So rigidification, we call it rigidification of the trachea, will come with time. So sometimes you may have to wait for 3 months also. But every time you have to take out the tube and assess it whether that segment is collapsing or not. देखो तुम्हारा curvature ठीक नहीं है और तुम्हें छोटी ट्यूब डालनी चाहिए.
This is a very important point because
So-
these patients, you just remove the granulation and the airway is fantastic. But see, this patient is under general anesthesia. When the patient comes out, then again he starts having suprasternal collapse. And why? Because of what Rakesh has said. There is a laxity because already you have cut the cartilage there. It has lost its support. So it's going to collapse. And these patients would require tracheoplasty, small tracheoplasty. I mean, it's not a big surgery, but then you have to think about a possible tracheoplasty.
Patty.
Excuse me, sir.
So rigidification takes a lot of time. Means
Can we keep any suprastomal stent?
no need.
Because the tracheostomy
Nothing
is
is going to
there.
stay there. Nothing is going to stay there. It will cause more harm than any foreign body in the airway will cause more harm than helping the, especially in this area.
But I have had the experience
So
with my three cases, they did
T-tube,
well.
T-tube is only the option, otherwise.
No, not the T-tube, because we have the tracheostomy here, like a part of the launch, the T-tube you cut and put there, and then also the tracheal wall, you suture it laterally so that the rigidification
Yeah,
of the trachea will happen and opens up.
there are two options, madam. One option is this, what you are saying, that you do it and then you suture it. Put an endoluminal stent, but Dr. Kishore Sandhu used to do it for all such patients. Other is what Dr. Ramalingam sir used to do it. He uses basically a tracheostomy tube inside a T-tube. Inside a T-tube, he put the T, he removed it and put the tracheostomy tube inside the T-tube so that it remains there. So it will work like it helps in the strengthening of the tracheal wall, also preventing the reformation of the granulation in that area. So I saw one of this presentation that he used a T-tube, that he removed the horizontal part of T-tube and put a tracheostomy tube inside the T-tube. And that is how the recurrence chances of that thing is not there. अब हम करेंगे बैलून. अभी ऑक्सीजनेशन होने दो, बैलून ले लो, फॉर्सेप दो. But I think downsizing a tube and corking it from day one, that is, start partial or full corking from day one, gives a lot of patient this thing, and very strict nebulization with Cipro and Dexa. And now I started combining with tobramycin also. So one tobramycin and twice by निकाल लो हाँ कितना है 14 कितना 16 स्ट्रेट अवे 16 अच्छा हाथ रखो उस पर उंगली रखो.
So what important point he has said about staged decanulation. So don't remove the tube in one stage.
क्या वो फट गया?
Lower the size, block it for 1 month, and then remove it.
So what happened is the manometer stopped working now. So suddenly some leakage was there. So this is a balloon from Merrill. This is 16 size balloon. So this problem is there. So I think twice or thrice you can use it. So sometimes I get it from the cardiology friends. So cardiology people, they use these type of manometer. So normally we keep it around 5 atmospheric. Maximum is they mentioned the breast pressure of around 10 mm. So this manometer is not working, but just by our assessment. So one of my assistant is putting a finger over that stoma so that the pressure, radial pressure should be transmitted evenly. There is also various types of airway balloons also. So one is a controlled radial expansion. There is another balloon which is a dumbbell shaped balloon. कितना हो गया 15 है 115 टेक आउट निकाल लो अभी रुक जाना अभी मत डालना ट्यूब. So now we see this expansion is quite okay, but I don't know how this right upper part will behave after. So trachea is also not looking good. Here also there's some, this thing is there, right side, posterior tracheal wall. But overall, I think if patient is able to डाल दो ट्यूब. यार रहने दो, अभी ठीक है ना? Assess करेंगे, ठीक है, चलो. We'll keep that Kenacort ready. So after Kenacort, again we do the ballooning so that the Kenacort get spread all over the. And normally for all such patients, we follow these patients every 10th day. ये है थोड़ा सा, this is a small cuff faucet. नहीं अब नहीं चाहिए, वो दो local Kenacort. So giving a Kenacort is also an art, like you don't inject at the exactly at the inflamed area where you have operated. So you just remain slightly away from it and just try to go some mucosa. It is difficult, but it is possible. Because otherwise what will happen, everything will come out. And Kenacort itself is a very thick fluid. So sometimes you might have to dilute it also. See, this happens. So half of the already split out. Right side. Just a second, just a second. So from the normal to the, see, it's still leaking from there. So again coming out. So I'll go a little bit more above it. Law. Suction. एक और है. पकड़ो ये.
Hi, Rakesh.
Hello, sir.
Brigadier Ramlingam.
We were remembering you, sir.
Yeah. I've been watching on YouTube while coming, and I heard you talking about T-tube with tracheostomy and all that.
Yes, I was telling about your modification of. You are always innovator, sir.
No.
Now you have come with some new technique for adductor spasmodic dysphonia.
Yeah.
Modification of type 2 thyroplasty.
Yeah, that I'll be showing tomorrow. And what I was watching was the suprastomal after granulations are cleared, as Sachin told. What I do is I take a thioproline, go through the skin outside superiorly, and
Can you speak loudly, sir?
Into the trachea, and lift the anterior portion of cartilaginous portion to hitch it to skin so that it won't fall.
Proline suture.
Only proline suture. It will stay permanently. It doesn't matter.
Achha,
over it, the stoma will close. Like you have cleared nicely. That time after dilatation, you take
but proline will cause more irritation, more granulation tissue, no?
See, I never encountered, because only one stitch, I don't think it will cause. and you are widening the suprastomal area. This is what I have done in including pediatric cases. It really works well. It won't cause much granulations, believe me.
But sir, whatever it is there, it is only because of the biofilm and infection. That is the main cause of it. If we take care of those things, reactionary will always be there if you are cutting or touching cartilage, granulation tissue, but that also can be taken care by serial injection of steroids.
Actually, Rakesh, in small children, when you do, there is some amount of tracheomalacia in suprastomal area.
Yes.
So
That's
because of
why-
that, in such cases, you take a suture and it will be very nice. I'm not talking about adults. Adults also have done, but in case of children, it is definitely tracheomalacia, suprastomal tracheomalacia.
The point, the essence of is you should be keep in mind about the possible tracheomalacia and stridor after removing the tube. The important point, how much to inflate the balloon. So when you get a balloon, just see on the package of the balloon, the company has written how much of the pressure you can go maximum up to. Don't exceed that pressure, because there are two things which can happen. Number one, in a pediatric age group, there would be tracheal cartilage fractures. Number two,
Second patient.
the balloon itself can rupture. Okay. And these things you have to keep in mind. So just read on the packet when you use the balloon how much maximum pressure you can generate.
Very important. Hello, hold on. लो बैलून दे दो. So we normally downsize it immediately. हटाओ ट्यूब हटाओ यार. सिक्स नंबर की ट्यूब डाल देना आज. 6 handcuff. So regarding the medication for airway surgery, so for open reconstruction, normally 1 week prior to the surgery, we give 5 minutes. 5 minutes finishing. So I don't know the protocol what Dr. Gandhi is following, what Dr. Ramalingam sir is following. So normally what we have discussed with so many people, that we give azithromycin on alternate day 1 week prior to the surgery, and just on the day of surgery, that is 1 day prior to the surgery, we start giving vancomycin for open reconstruction, and give vancomycin continuously for 5 days for any open reconstruction. And for endoscopic procedures, the medication, the antibiotics what we follow, like for these patients, for preventing pericarditis, we give usually either fluoroquinolones, levofloxacin combination with, to prevent MRSA, we give a sulfamethoxazole with trimethoprim, that is Septron DS, for such patients. I don't know the opinion of other in the house, Dr. Ramalingam and sir, and
I don't follow this antibiotic policy much, because once you have dilated and inject Kenacort all around and then apply mitomycin, mitomycin C for about 2 minutes, that should be okay. I don't emphasize much on immunomodulators, what you are talking about.
Hey, not immunomodulator. I am talking of giving a levofloxacin group of drug and PPI, of course, alginate, of course, then 10-day follow-up, then again 10-day follow-up, then 3 weeks follow-up, like that, depending on the distance from which the patient is coming. And we normally give a spirometer to the patient and continue to take a spirometry video from the patient. Nikal do, bol do. Spirometry is a good indicator, very simple way to do it. To do the assessment. Now I started using is a Aerofit. Aerofit is a spirometer which is Bluetooth enabled. So that spirometer immediately on the next day we take a spirometric baseline measurements, and then when patient comes for follow-up, we again do the spirometry for such patients. So if the patient is affording, they can buy it also. It is 8,500 US FDA approved. There is a company known as Aerofit. I'm not promoting it. The gentleman is from Bhopal only, now settled in US. So he is a pulmonologist who developed that device. 6.5 कोई भी दे दो.
Frankly speaking, I don't use this
spirometry
or anything for follow-up. Visual impression is more important. I call him after 1 month.
No, this actually, sir, is a warning signal. Warning signal means patient coming from Bihar or Jharkhand, someplace, and suddenly if they come in emergency with respiratory distress, then my heart rate will also go up.
Yeah, absolutely.
So this is airway is a very stressful situation. So if you get a, like डॉक्टर साहब पहले तो 3 बॉल उठते आती थी, अब खींचने में 2 बॉल उठ रही है, इसका मतलब कुछ वार्निंग सिग्नल है. Something which the patient is not able to tell. Or many times these patients are neurological patients, so they are just sitting in their house. So at rest they don't have any respiratory distress. And suddenly they develop a thing because physical activity is zero. So once physical activity is zero, now you see this mucosa. This is not good. Not at all. Very reactive tracheal mucosa, but he is not a diabetic, no? Diabetic. Oh. Okay. Iron, hemoglobin कितना है?
10.6.
So he will require iron and sleep. So we have downsized the tube.
I think the tracheal mucosa will settle down with Budecort duolin nebulization for about 2 weeks.
Normally, I give the nebulization from mouth, closing this tube, and use a Ciplox D, 1.5 ml of Ciplox D with 3.5 ml of normal saline. So ciprofloxacin, dexamethasone nebulization with 3.5 ml of normal saline mixed through mouth. And
your new thought process for me.
And then tobramycin also. Tobramycin is, I have seen in pediatric age group, is very effective as a nebulizer, but it is costly. It is 500 rupees as compared to Ciplox D eardrop, which is very cheap. But since Cincinnati people, they are using it very often for more than 10 years. Professor Ratter, he used it for all pediatric patients. So we follow the same thing like in these patients. So it is 11 o'clock.
Yeah.
And we have one more case. If the time permits, then we'll take that case. That is a bilateral cord palsy, posterior cordotomy with partial retinoidectomy for that patient. इसको suspension हटाओ.
Yes, sir. We'll see that case as well.
जल्दी करना. But that will not take much of time. I think that will do it very fast. 15-20 minutes maximum will take.
So how many times you will inject in this particular case now, like in the
It
follow-up?
depends on the response. Otherwise, what the literature says, normally there should be a gap of 3 weeks. There is a very interesting article by Roman Franco, who was a big proponent of serial intralesional injection of steroid. So initial reports, initial reports were that initial report that these intralesional steroid were not very effective in idiopathic subglottic stenosis. But now there are supportive evidence that this is very effective. There are one article which says there is a review study which says that this is effective in idiopathic progressive subglottic stenosis. IPSS normally in India we don't see so often. I don't know about maximum cases which I see in my practice is 3 to maximum 6 cases in a year. So not so often we see these cases, and we don't know exactly that where in which category we have to keep these patients. We get all the investigation done. So Dr. Dr. Guri Sandhu used to call this GPA. That is polyangiitis, granuloma polyangiitis. That is all the category in which like Regeners also comes into that category of lesions. So how much it is effective? In idiopathic progressive stenosis, I also don't know but there are evidence in, especially because IPSS is seen in UK and US only, Europe also, but in India we hardly see such cases.
Sir, is there any role of antifungals in these patients because they are diabetic and that kind of a granulation which we saw all around the tracheal wall?
The other thing which I missed out in this patient, I should have taken a culture swab for the culture and sensitivity for this patient. I should have done it at the time of start of the procedure. 2 cultures, one from the tracheostomy, other is from the wall of the stoma. So biofilm formation, antifungal, very important role into it. As far as the application of mupirocin ointment around the stoma is very important to prevent biofilm formation. So care of the stoma is very important in such patients. As empirically you are asking it that start antifungal, I don't think there is any proof for it. I have not read it anywhere that you start antifungal also with this medication.
So what about mitomycin C?
Yeah, I put that mitomycin. I have used, actually I don't mention it. One of the petty was having a mitomycin C also. So after the injection, I put a mitomycin C, then again I ballooned it. So it was there actually. 2 milligram.
For all the cases, sir?
Almost all the cases. But there is, review literature says that it has got, as such, there is no foolproof evidence that mitomycin is. I have one presentation also, if the time allows, and I'll give in just 5 minutes that what are the evidence for, because because there is no standard dose for it. When to give it, how to give it. So there is no standard for using a mitomycin C in airway surgery. And Dr. Guri Sandhu, Dr. Giru Sandhu, he doesn't like using a mitomycin C in his practice. So
how will your follow-up be for this patient now?
I'll call this patient, this is from my place, this Lucknow place. So I'll call him after 7 to 10 days, again see in office and see how the reaction around the stoma is there and whether patient is able to tolerate the corking, the daytime corking, so that I will have certain idea. So I don't use corking for a full whole day, intermittent corking, like when he is taking nebulization, like that. When he is talking to the family members, he want to talk to the family members, then he should use it that way. But not like continuously corking it, because then again it will cause retention of secretion and those things will be there. So gradually, because we are not going to decannulate him not before 3 weeks, because that is a time when, that is, we call it for airway, we call it window period for any airway case. If patient is coming out from ventilator also, so patient say ki, Doctor Sahab, I was out of ventilator for 10 days, and after 10 days I developed difficulty in breathing. After 14 days I was having severe, the distress was increased, and third week I am coming with this condition. So this is a window period for anything. No hurry, no urgency to take out the tube. So we will see how his trachea reacts, how the rigidification happens, how the wall is collapsing, how much he is able to take off that, how the reflexes is there, how the cuff is there. So everything depending on it.
I fully agree. Good old teaching. Be in a hurry to do tracheostomy, but be very, very lazy in taking out the tracheostomy tube. Very, very lazy, I means give enough time for the patient to warrant for removal of tracheostomy tube. Thank you.
Thank you very much, sir. Thank you for that wonderful case which you demonstrated. We usually don't get to see those kind of cases in live surgeries. Thank you very much, sir.
Thank you to my anesthesia team also. Dr. Ankur Saxena is there.
Wonderful, wonderful, Rakesh. Just for mitomycin C, easiest formula to remember, 2 milligram per cc, 2 cc for 2 minutes. Okay, so this is the dosage what we apply, but there are multiple authors who say it's useful, not useful, but definitely it does not create any problems. So if you have it, then you can go ahead with the neuropathy. Yeah, either a roller gauze strip or a neuropathy is the safest because it has a string.
Now, Sachin, I fully agree with you. This is the dose we follow. But as we said, there is a controversy. I was the examiner for Dr. Prasanna's PhD thesis on triamcinolone versus mitomycin at Sri Ramchandra Medical College, Chennai. He carried out study on rabbits, and he found that triamcinolone is better than mitomycin. I mean, in his study, and that thesis has been, I mean, that PhD has been awarded to him after accepting the thesis. That is why I said it is always a controversy. Yeah. So better to use both. Yeah. To be on the safer side.
I think that one question he has brought about the antifungal, whether there is a fungus infection. See, especially in a pediatric age group, when a child is on ventilator for more than 7 days, 1, 2, 3 weeks, then please take a bronchoscopy lavage or just start antifungal agents. Because these children actually die because first they can't pay for their antibiotics and then the antifungals on it. So I think rightly said. Antifungal. Yeah. And then again, you're taking the swab and everything. But you have to keep in mind, I mean, he has rightly played the professor about the antifungal, especially in pediatric use. See, because I have lost one child. I mean, I know all these stories because very, very important. 3 weeks of ventilator, more than 2-3 weeks of ventilator. Tracheostomy is in a way safe. Okay. But ventilator, more than 1 or 2 weeks, and a child, then a problem. Yeah, tracheoplasty is the final answer. There is a surgery which Brigadier Ramlingam has already told us to take a stitch from the trachea and this one. But actually, I am very lucky. My fellows of last 6-7 years have come here for paper presentation, and they know how we have done struggle with these patients. So tracheoplasty is the final answer. Yes, exercise is a small surgery. Just have a maybe 1 or 2 this one, freshen it and then suture it. end to end. Yes, it's a tracheoplasty. Number two, about the
Hello.
stent. So I think T-tube if required. Otherwise, just go along with tracheostomy tube. Try all your different methods. But if you want to put in a stent, then T-tube. But I am against T-tube also.
In small children.
Hello. Am I audible?
Because you are
Hello.
going, when you are removing the granulation, you are going to the perichondrium again. So you have to keep a watch, like 1 week flexible endoscopy. And these OPD based steroid injections may work for a smaller granulations which are coming over there. If they are causing obstruction, then again you have to take them under G and remove them. But for small granulations which come over, you can do this OPD based steroid injections.
Hello.
Transcutaneous.
Sir, third case will ready soon, sir. I will give a brief history of third case. So, she's a post of case of total thyroidectomy was done in May 2024. After that, she was feeling of shortness of breath within 3-4 days, and in August 2024, some other ENT surgeon diagnosed as a bilateral vocal cord palsy and did a tracheostomy in August 24. So patient came to us in January 2025 for the decanulation. So we did a first surgery, left-sided cordotomy with partial retinoidectomy. Patient was able to tolerate intermittent corking well for around 3-4 months. After that, patient was presented with shortness of breath and stridor last 1 month. So recent flexible laryngoscopy was done, and here is the finding of flexible laryngoscopy. Only 3-4 mm airway is there. आपका ही. Okay, so the planning was revision partial cordotomy with partial arytenoidectomy. Over to sir. Sir.
This is mine.
आपका ही है.
Okay. Hello. So one thing we have missed out in the airway. ये आएगा ना अल्लाह कम करेगा तो where is it? Not this one. Where is it? Airway.
The previous presentation.
Hello. So one of the thing which has come up recently which has come up recently in airway surgery, which is going to replace or not exactly the replace it, but it is safer than the high flow jet ventilation. This is known as ये क्या लगा दिया? ये नहीं है, ये है ना, ये है. क्या कर रहे हो तुम? Which is going to replace the HFJV or as a complementary tool for airway surgery with HFJV. This is known as flow controlled ventilation. So the advantage of using EVON, this is a EVON basically. EVON is a flow controlled ventilation system that uses a tube with the 3 lumens. This is also known as tri-tube. So tri-tube has got one for the inflation and deflation of the cuff, one for the measurement of the pressure of the trachea, and one for the patient ventilation. So this has got a three lumens into it in a single tube. And the best part of the tube is, the tri-tube is, it is 4 and 4.5. 4.5 is the diameter of this tube. So this advantage of this tube is, and with this machine, this is EVON, manufactured by one of the company from Netherlands. So it gives a ventilator parameters. You can measure the FiO2. It has a conventional capnograph. So capnography is difficult with HFNC. So HFNC, the actual values of capnographic values, you will not get it. End tidal CO2, you will not get it with HFNC. But with this machine, you will get the EtCO2 also. Other measurements are same like any other workstation, like minute volume, respiratory rate, inspiratory tidal volume, and peripheral blood oxygen. So this is a tube basically. For an obstruction of the tube due to secretion affecting the ventilation. So because this is a very small size tube with 3 tubes inside it. So one should give an anticholinergic agent 1 hour before the procedure so that tube doesn't get blocked because of the secretions. Though it is not laser safe, but it doesn't catch fire. The best part is it doesn't catch fire, though it is not laser safe. But if burst, then the same tube can be used as a HFJV, high frequency jet ventilation, and tube material is not inflammable, so no risk of fire in the airway. So this I wanted to highlight it because this is a very important contribution into it. Though it is in practice for more than 4 years, and there are many publications which compare the results of EVON with HFJV. So this tube itself can be used as a HFJV. With the good part is it can give a EtCO2. It doesn't cause atelectasis or the problem issues which are related to the high frequency jet ventilation. हाँ भाई, उसको ऑडियो भी दो. Patient is ready. Hello? Hello? Hello?
Yes, sir, please. You are audible.
Yeah. Just show you what is the protocol and how, what are the medication we use it for airway surgery. Because this is an airway session. This is our hospital. So next session will be by Dr. Manjunath and Dr. Sachin Gandhi, and Dr. Ramalingam sir is there. So that will be on office-based procedures.
Yes, sir.
Office-based procedure. So you will have lot of discussion about the how to prepare a patient for office-based procedure and what drug agents you will be using for anesthetizing the airway.
Yes, sir.
So the maximum topical dose what we use for airway surgery as far as adrenaline is concerned, this is the formula for it. You can take a picture of this. This will be quite helpful for all the youngsters that how much maximum you can use for airway surgery or for office-based procedure. So if you see the dosing here, 4% of lidocaine means 4 grams. That is 4000 milligram of lidocaine in 100 ml of solution. So 30 ml, because normally the vial comes in 30 ml. So how much it will be? It will be 1200 milligram of lidocaine in that vial. And 1 ml will contain about 40 milligram of lidocaine. So the dose of it is 3 to 4 milligram per kg body weight. So a normal young adult with 50 kg weight, you can use is up to 4 to 5 ml of lidocaine easily, 4% in such patients. So either you can use it as a through the working channel of bronchoscope, or you can use as a laryngeal gargle. This is a safety limit, though there is no harm if you go 1 or 2 ml above or below it. These are few of the articles which are used for, which are supportive of this, how much has to be used. These are the various blocks we use for airway surgery, that is superior laryngeal block, transtracheal block, and glossopharyngeal block. Different sides of it. So nebulization also you can give either by 2% or 4% xalocaine. Anti-inflammatory doses, the groups are different, like adrenaline, you can use a steroid and mitomycin C. Delivery may be orally or intralesionally. So regarding the most important part of it, that is how much adrenaline nebulization one should use it. So most of the endoscopic procedure, what we do is, for first 2 nebulization, we give is adrenaline nebulization. For all airway surgery, even for pediatric airway, if we are doing an endoscopic procedure, we give adrenaline nebulization because this is a very good mode to reduce the mucosal edema, and it is also a beta adrenergic, so it causes relaxes the smooth muscles of the airway. So patient will have a smooth breathing in the post-op recovery. So how much is the safe dose of adrenaline? So in adult, normally we give is 1 milligram of adrenaline, 5 ml of normal saline. We dilute it with normal saline. So one ampule will have a 1 milligram per ml of adrenaline, and maximum dose which can be given is 5 milligram. So in an adult patient, you can use up to the 5 ampule of adrenaline safely. And regarding the pediatric use, we can give, normally the dose is slightly different. I'll just share it. For pediatric, it is 0.1 milligram per kg. So 1/3 or less than 1/3, the maximum is 1 milligram. So 1 ampule of adrenaline, we can use it for pediatric age group also. So if the baby is 3 kg at the time of birth, so 0.3 ml, that is 1/3 of the ampule you can give easily for nebulization, mixing it with normal saline. And it has been observed that even in pediatric age group, if you give a 3 ampule of adaline nebulization, patient will not have any tachycardia with it. Patient induced. Okay. So I'm shifting to the surgery. Ready?
Yes, yes.
So I'm just shifting it to surgery. Okay. इसको लगा दो कुछ हम शीट डालो चलेगा वो कह रहा है रेडी है पेशेंट So this patient was operated by me, and I think this is in my career, this is second case which required it almost in, I have not yet published it, but I can say around more than 60 cases of bilateral cord palsy. The second case where I have to do the revision of cordotomy. So there are different procedures for managing bilateral cord palsy. One is the safest way is you do the tracheostomy for the bilateral cord palsy patient. Then how to decannulate these patients. So simpler technique is, which is known as suture technique. That is, you suture the one vocal fold and fix it laterally. The other technique is, one is known as Dennis-Kashima procedure. Kashima procedure, which was described in 1982 by Dennis and Kashima. Other, that is known as posterior cordotomy. What they have used is a CO2 laser for bilateral cord palsy. Then there are various modifications which has come up in this technique of managing this, and there are various tools which are now being used for such patients. One can use laser, one is using cordotomy also for bilateral cord palsy, flap technique. There is one more technique which proposed by my mentor, Professor Pariti, that is posterior ventricular cordotomy with partial arytenoidectomy. There is another technique which is known as subtotal arytenoidectomy by Professor Mark Remickle, in which he leave a shell of arytenoid, posterior shell of arytenoid, while doing a posterior cordotomy. So whatever is good in your hand, you should do it. But Kashima itself, I have found there are more revisions in Kashima itself, but if you combine it with partial arytenoidectomy, then it is the chances of revision are less. Quick. Dr. Vikas, Dr. Jain. Hello.
Yes, yes, sir.
Any time is there, or?
Yes, sir. We can start with the surgery, sir.
Because they said 11:30. You have to. I'm just thinking about
We are able to see the picture, so we can continue with the surgery, sir.
Yeah, just go ahead with the very fast, so that your session should not get delayed.
Sir, Dr. Vikas, sir.
So which?
Okay. Posterior cordotomy.
Lagao.
So this is posterior cordotomy for bilateral cord palsy right now.
Yes, yes. So सुनो air leak कर रहा है.
हाँ, yes sir. You can show. I think it will take hardly 15.
मेरे मुंह पे आ रहा है. पूरा मुंह पे आ रहा है. इन्फ्लेट है. हाँ, पैक दे दो यहाँ पे. हल्का पड़ी है. नहीं तो इसमें डालना चाहिए ना. बोला था. Told you flexometallic you put. डालो फ्लेक्सिमीटर डालो जल्दी से लाओ दो
Okay,
I'll
sir.
fix it. Yes, sir. I'm going very fast now.
हाँ
I'll
sir,
take
you are going to do
15
the
minutes.
symmetrical procedures on both the cords, so it would be better that if you show on one cord and
हाँ
explain the these all the things that what care should be taken, where should we start, where should we
even
end.
for
So and then once
so
you
what
show on one side, then maybe we can switch to the next session.
so what they say is the incidence of bilateral cord palsy in total thyroidectomy patient is less than 1%. So 0.3, 0.4% is the incidence of in total thyroidectomy surgeries, the incidence is that much. And unilateral is higher. Unilateral is around 7%. So focus karo. So how long to wait? When to operate? When to plan it? Like you have tried NIV after surgery, after total thyroidectomy, you notice patient is having distress. Still you can wait because sometimes it is transient. It recovers also. One side recovers. Lot of synchiasis there is there in especially Reconstruction. So how long to wait for these patient to when you will do the airway procedure for this patient? That is very important. थोड़ा सा हाइट ऊपर करोगे हेड एंड ऊपर करो और डाउन है हल्का सा हाइट ऊपर करो फिर हेड एंड ऊपर करो हेड एंड ऊपर करो बस बहुत ज्यादा हो गया देखे यस यस नाउ आई गेटिंग द गुड ठीक नहीं ठीक है आई थिंक का माउथ ओपनिंग कम है ना ये दिस इज डिफिकल्ट एयर में सो गिव मी because this we know the cause of this palsy otherwise if it is a fixed cord then you have to see the cord without the relaxant palpate the cord. I think in next 2 days you are going to see all such cases in discussion and so many senior faculty are there who are going to guide you for to help you out to discuss how they are going to manage. So this patient was operated. ये क्या लगाया है तुमने? 0.05 करो. So spreader दो spreader. So this was operated on the left side. Now you can see that. Yes, as compared to the right side, if you see, this is straight and there is a small deep crater here. So it is the left side which was operated before. I don't know whether you're getting the picture or not. Are you getting the picture?
Yes, we are getting, sir. Little more.
I'll just magnify it.
Yes.
Now you can see it.
Yeah, now it's better. Sir. Yeah.
So now you see this. Excuse me.
Now we can see the previous.
Previous thing, Now I put a patty there so that I am protecting the tube because. And now you see the true cord is also has regrown it. So new cord formation is always be there. So other thing you have to do is again use the same suction which I was using in the first case. So palpate the arytenoid. Now you can see the vocal process is there, white shiny area.
Yes.
So this is. So I will start it. I will first remove the false cord. Give me a small patty. So first I open that area by removing the false cord. And then I will remove the true cord and then I'll go laterally. Because this will be, I am not going to do another one because I don't want, this time the patient should be decannulated well. Forceps left. Blade size छोटा करो. बंद कर दो, बस इसको छोटा करो. So first I'll remove the false cord so that pottery check कर लेना.
Sir, is there a limitation on how much to remove the false vestibular folds?
How much to remove? There is no landmark as such, because this what will happen is two important things you have to remember it in this procedure. One is you should not damage the interretinoid area. Interretinoid area you should not touch it. Other is the depth of the your dissection. Laterally also, sorry, 3 points. The lateral part is important because you have to leave a little bit of mucosa there over the retinoid. यहाँ पे bleeder है ये दो. So I can see the bleeder there. बस. So देखो मिल गया. So you have to leave a little bit mucosa over the thyroid cartilage. Don't leave a bare cartilage there. So that is how you will do it. That will come with the experience that once you start palpating it, you palpate it, you will know that you have reached up to the ठीक से देखो. अरे ये मत करो, ये मत करो, ये मत करो.
Sir, anteriorly up to
हाँ, I'll just show you because अभी तो मैं false cord निकाल रहा हूँ. I'm just removing the false cord. Go.
false cord anteriorly पूरा निकाल रहे sir वो आगे तक.
Not entirely, not whole, but partly of. So superior laryngeal artery has got two branches. So they go, one goes posteriorly, one goes anteriorly. And I think Dr. Sachin Gandhi is going to cover up this thyroid myoneurectomy. So once he will show you that easily in high magnification, you can see the nerve also entering the larynx. So that will come once you start doing a dissection, cadaveric dissection. You will know the location of nerve, location of artery. And there was a very interesting article in Frontiers in Oncology by Professor Peretti and Piazza that they have done it on cadaver dissection, that how much deep is the nerve, how much deep is the artery, and what are the blood supply of. शक्कर तुम्हारा ठीक से काम नहीं कर रहा भैया. हाँ, so I was telling you about the limits. You are asking about the limits. So one is this part. You should not damage the interretinoid area. Fat आ गया ना. Other is the lateral edge, and the third most important part is the depth. So depth is decided by, because the cricoid is there below it, because cricoid curves up and it comes close to the relation of arytenoid. So you should not damage the cricoid. So in between you have to palpate it also. ये तुम्हारा भैया काम नहीं कर रहा शक्कर. ये ब्लीडर है, देखो ब्लीडर है. चलो करो, मत छोड़ो. So I'm removing the false cord only, not touching the true cord now. So I've removed the false cord now. So now I will again reassess it, how much, and palpate it again, है ना? So दबाओ जरा थायराइड काट ले, हाँ ये है arytenoid, है ना? So this is the arytenoid, you can see it, this yellow one. So I will take a cut from here. Little bit more extra because patient might have not a good voice, but for 3 weeks, 4 weeks, but I don't want to get her decannulate as early as possible. So थोड़ा डेप्थ बढ़ानी पड़ेगी. एक मिनट रुको, अच्छा रुको. दिस इज अ लिगामेंट ना? हाँ ठीक है, अभी 1 पे ही रखो. अभी ये क्या किया यार, ये सब हमेशा चेंज हो जाता है. हाँ सो नहीं ठीक है, ब्लेड साइज बड़ा है, छोटा करो. व्हेन यू चेंज द ब्लेड सो सेकंड्स विल चेंज, है ना? आप पानी डाल सकते हो. So here again, if you see that the leader is छोटा सा, now the cricoid comes somewhere close by now. So you have to know the exactly 3-dimensionally that how much you have to remove it. Okay. So in between it, you have to change the magnification also. And now I'm going a little bit more deeper so that you will have certain idea that where is the cricoid. So this is the limit. With the suction, I can feel there. So now the 3-dimensionally, I have to be little bit more superficial rather than going deep into it, digging it. So छोड़ दो, रुक जाओ, WhatsApp दो. So 3 important points. One is the depth, other is how much laterally you have to go, another is interadenoid area. I have seen complication that bilateral cordotomy was done and patient came with posterior glottic stenosis. So never try to attempt on both the sides, always do it on one side. So अभी इसमें स्पेस है काफी है. So keep palpating it so that you will have certain idea that So bleeder जो है usually it comes from here, just lateral to the vocal process, between the muscular and the vocal process. Sometime along the muscle also you will encounter it. So this is my limit actually. I'm now saying the posterior limit of it. Huh?
Yes, sir.
Now you will appreciate the vocal process of a retinoid also. I can remove up to here also, like this. Professor Ramekel technique of using, this is subtotal retinoidectomy. Subtotal retinoidectomy, you can remove up to here. And all patients should undergo fees test before undertaking this type of procedure, so that you have certain idea that how the patient is swallowing, how the sensation is there. Now I am going into the dangerous area, that is, this area bleeds. So I keep my magnification, everything very clear, so that I am able to control it. And whenever you are doing a dissection, always try to use as a paint and brush. Don't try to dig it at one place. Yeah. ये पकड़ा, पकड़ो, छोटा सा छोटा सा छोटा सा, हटा 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 हटा, हाँ बस बस. लाओ सेक्शन को. Now you will see the fiber there. So this muscle also is supplied by the same vessel. So yes, बस वो करेगा, थोड़ा सा ब्लीड करेगा. So now I'm reaching to the cartilage. So I have to palpate it again. Good. So use a low setting instead of high setting. Use a low setting so that less of charring. पानी भी डालते जाओ थोड़ा सा. पानी डालो बस. Actually, we are using saline. I am calling it pani, so don't think we are using water. We are using saline in the airway.
Yes, sir. We know that, sir.
Pardon?
Yeah, we are aware of that, sir. That it's saline.
हाँ, इन लोगों को बोलना पड़ता है ओटी स्टाफ को, पानी डालो. अभी नहीं डालना. So now you have to palpate the cricoid also. Be careful about cricoid because cricoid comes a little bit more medially. So it is not exactly of the same because अरे मर गया, ये क्या हुआ? हैंग कर गया था. So I called. I'm thankful to the Boston also because the service engineer is here, so I don't have any problem regarding if any issue in the machine, because this machine is almost 12 years old. It was the first machine. I was the first personal buyer in India. So first personal buyer in India. So this is a very old machine now. So I'm always be scared of, especially in live surgery. So now the final touch is how much more. So now I will do one thing. I will just assess it by palpation. So अभी सीधा कर दो, छोड़ दो. Now bring it. हाँ, फिर से दिखाओ, सीधा करके. हाँ. So now अभी इधर दिखाओ, ये क्या है? रुक जाओ एक मिनट. So other thing we do is we use a scanner there. We call this polishing the cavity. So we polish the cavity, पानी मारना है. Like mastectomy we do. Like mastectomy we do. Same technique.
Change the depth, sir. Laser depth in this. It's
Pardon?
same. Depth is same, sir, for this polishing part.
Yeah. Same. This is actually they call it 0.03 seconds. Okay, but 0.30 second means 250 micron. The depth is 250 micron. 1/4 of a millimeter.
Yes, sir.
ये थोड़ा कार्टिलेज पे टच हो गया तो लग रहा है फोकस नहीं है. रुको एक मिनट, इसका सर्कल ठीक से नहीं बन रहा है. रुको एक मिनट, लिटिल बिट मोर क्लोजर. इसका ये फोकस पूरा सर्कल नहीं बन रहा है. राजपाल अब बना. हाँ, now it is doing it. Yes. Otherwise वो चारिंग हो रहा था ना. So now I am palpating it. So this is a cricoid actually. The superior border of cricoid which is coming. Now I can feel it. I cannot push it now. This one. And this is a part of the muscle, little bit of muscle which was left there. Now you can see thyroid muscle, part of it was left here. अब push करो इधर से. ये इसमें gap, there's a small gap there, which is always be there between the thyroid and the cricoid. And again, you will see the thyroid cartilage again here. So, but sometimes it bleeds also. डालते जाओ पानी, है ना. So now we can see the whitish thing there. So this is a part which is you're touching the thyroid cartilage. So what I'll do, I will join it. Forceps though. So sometimes this between this area cricoid and thyroid, because thyroid cartilage is outside, cricoid is inside. So sometimes there is a capillary which comes on the way. So I'll keep this ready. If I encounter any bleeder, then I will do it. So जोर से मत दबाओ. Now you see this. A little bit more small capillary they come. छोटा सा दबाओ. बहुत थोड़ा सा बस.
Sir, shall we start with the next session over here? Sir?
Yeah, we have almost. I have finished it. So just wanted to show you that this is also an important tool. You can use it. Yeah, finishing. Thank you, Dr. Jain, sir, Dr. Vikas Gupta, and all the moderators, Dr. Kavita, madam.
Just before you finish, if you can just show us this final endoscopic picture and just brief that.
Yeah, endoscope लगा दो. Endoscope लगाओ. अभी बंद मत करना, अभी रुक जाना. छोटा वाला दे दो. लो व्हाट्सएप दो, दिखाओ सब. रीडर है क्या? दिखाओ अपन. टच कर दो, इसी से टच कर दो. Maybe I have to do it and ठीक है, कोई बात नहीं. I'll do it. This is actually the final picture.
Yes, sir.
टच करो, टच करो. So sometimes this flex section also work, but I will do it with bipolar. हटा लो, patty दे दो एक. So patient will have a very bad voice for first 3 weeks. Then she will improve. WhatsApp दे दो. एक
So,
patty
thank
और
you very
दो.
much, sir. We'll be moving
Okay,
to the
thank you,
next
thank you.
session, sir. Thank you, sir.
Thank you, thank you, thank you, thank you.
Thank you for a wonderful presentation. Sir. Thank you.
I would now like to invite Dr. Anjan Sahu sir
बंद कर दो.
to please present
अच्छा.
memento to our
नहीं,
esteemed
नहीं.
chairpersons.
वहाँ
Dr.
से
Anil
transmission.
Kumar Jain sir, Dr. Yashveer sir, Dr. Satwinder Bakshi sir, and Dr. Sadat Qureshi sir.
लाओ प्लेडो दिखाओ. लो जल्दी से दो यार. पॉटी ले लेना. और ज्यादा दबा दिया है. हाँ बस करो. छोड़ो. चलो साफ करो. स्ट्रेट फॉर सर.
We will now proceed to our next session on office-based procedures to be chaired by Dr. R.D. Nanoria sir, Dr. Sachin Gandhi sir. The speakers for the session are Dr. Manjunath M.K. sir,
जो
Dr. Ruman Ahmed sir,
लो फॉर्सेप दो. वाली देना दूसरी. ठीक है.
Good morning. At the outset, I would like to thank Dr. Vikas and his team for putting up a great show and inviting us here. And yeah, I'll be showing some videos on office-based laryngeal surgery. Because due to some technical reasons, we were not able to do it live. So, but nevertheless, I mean, if it was a live procedure, it would
पैटी
have been
दो
one
फ्लोर के.
procedure, but now you get to see
और
many
पैटी दो.
different types of procedures. So obviously, why do we want to do office-based procedures? And one is it's economical, it is safe.
अरे ऐसा नहीं होता. कोई दिया बना रहे हो क्या? लगाया नहीं सर्वर ने. मनी क्या कर रहे हैं?
Thank you, ma'am. We now move on to cadaveric dissection demonstration in short while.
तो वो कैटेगरी वाला भी नहीं होगा।
हाँ
कितने सेकंड पीछे
The demonstration will be relayed here.
अच्छा यहाँ इसलिए नहीं दिख रहा है
मैं यूट्यूब में देख रहा था कोई वो बोल रहे थे और यहाँ पर अंदर मैडम जी भी बोल रहे थे।
कहाँ जा रहा है भाई साहब?
मैं बोली वो लाइव
Delegates who have registered for the cadaveric dissection, mediation thyroplasty, kindly reach anatomy dissection hall ground floor.
नाम नहीं शो कर रहा है। ओके एक मिनट को मैं देखता हूँ। हो गया, कनेक्ट है। ये देखो ये कैमरा कर ये देखना व्यू देखना।
तो क्या आप उसको वो कर रहे हो? ये दो हॉल है प्लास्टिक की ना समझ में नहीं है। पंख नहीं है ना फिर होंगे इसके कितने का? 1000 का तो होगा नहीं।
इधर ज़्यादा कोई ध्यान नहीं देता क्योंकि सब वैसे नहीं रहते ना, कपड़े वैसे नहीं पहनते रहते ना, तो किसी को
सर ये 2 हॉल का क्या लफड़ा? यहाँ पे रहती जो
दो लोगों का वो भी पूछना जा रहा है। ठीक है अभी रखो। हाँ तो वो राहुल सर को बोला क्या बोले? अच्छा अरे सर उनको बोला बैग का क्या वो डेलीगेट के बैग का था उधर ही जाके बोल दो।
हेलो हेलो
अरे रिंकू
I'm Dr. Sanil Sir.
Okay, Dr. Gandhi. Are you able to see the image clearly?
Yes, sir.
There is
Part of it is hazy. The distal part is hazy, but the proximal part is okay.
अरे केशव वो डेलीगेट के 50 आईडी बैच निकाल देना और पैक कर देना है ना। मैं अभी उसको भेज निकाल दिए क्या?
Light is not required, but the focus could be a bit better.
36 चलो ठीक है 36 मैं उससे भेज दूँगा। काम करो क्यों कितने चाहिए
चाहिए एक ही बचा डेलीगेट का
तो 30-40 में हो जाएगा। 36 मंगा रहा हूँ और मंगाओ
क्या नहीं तो मेरे को पड़ेगा।
ठीक है चलो रैपिडो से भेज दोगे कि मैं करूँगा? अच्छा ठीक मैं बुक कर
क्या चाहिए
36 का बैच
मेरे को
नहीं
ये वाला
क्या
है
ये वाला
डेलीगेट का बैच
change
ये
कर दो।
ज़्यादा नहीं
एक मिनट 1
अच्छा तुमने
सेकंड
उसमें कर दिया क्या OBS पे
OBS से हो रहा है
क्या नाउ क्वालिटी इज गुड हमने
हेलो
देखा
दोपहर तक
I request the registered delegates for cadaveric dissection to please
वो अपन
proceed
3-4
to
बजे
section
करेंगे
hall.
सर अभी तो क्या
We
ये
are begin with typhoon,
खाना
hydro-dissection
ना
and
होने के बाद
tracheostomy anastomosis by Dr. Ramalingam sir and Dr. Rakesh Kumar sir.
नहीं अपन करते हैं 3-4 बजे
अदरक जैसा लग रहा है पहले
Can you see now?
Yes sir.
Acha, I am going to orient this specimen to you first. Okay. This is the tongue portion. Tongue.
दो टंग
Can you see?
Yes, sir.
This is the tongue. Okay.
Yes, sir.
Hello.
Yes, sir.
जो ज़्यादा चलते
I must get constant feedback from the auditorium, please.
Can you hear me, sir?
Dr. Sandeep.
Sir, I'm Dr. Samir. Can you hear me?
Yeah, Dr. Sandeep. Can you hear me?
Yes, sir. We can hear you. Can you hear me back?
Okay. Now 1 second. This is the tongue. Okay. And this is the higher bone.
Yes.
Okay. And this is the thyroid cartilage.
ये कैमरा ठीक
Right, sir.
And this is the cricoid cartilage. Okay.
Yes, sir.
And this is the thyroid gland. You can see very nicely. Thyroid gland and trachea and bronchial tree. Okay.
Yes, sir.
So now we'll go with type 1 thyroplasty.
अरे बैठ जाओ हाँ नहीं सुनो मैं ये बोल रही हूँ लंच के लिए थोड़े ज़्यादा लोग लगेंगे
So type 1 thyroplasty is for oxygenation thyroplasty is for unilateral buccal cord therapy. Okay. The rest of the things tomorrow I think I'll be showing you during my lecture on type 1 thyroplasty and electrodilation. The operative videos using silicon block, using PVFMI as well as using cortex. All the three varieties will be showing. Now, firstly, let me orient this specimen. This is the thyroid cartilage and this is the upper border of ala and this is the posterior border of ala and this is the lower border and this is the thyroid tubercle. Tubercle, the importance I'll tell you tomorrow. Right now I'll tell you that you must know that this is thyroid tubercle. It is very, very important when you are marking the lower border. Because if you follow this, like this, you see it is going obliquely downwards and then coming upwards. If you go with your thyroid window, thyroplastic window, it should be parallel to the lower border. But if you are going along like this and if you make your window like this, then what will happen? It will be slanting. So, first of all, these are the very important things. Then this is the oblique line. What is oblique line? Where the stomatoes are inserted. Now, what is the importance of this? Your posterior-inferior portion of the window, it should not cross the thyroid, this oblique line. Why? Because the moment it crosses, when you insert your the implant, then it may push or dislocate the arachna. So that is why the posterior inferior corner should not cross the oblique line of the thyroid ala. Now, where is your upper border? The entire thing is upper border, but you have to take measurement from V of the thyroid notch. Don't take from here. If you take from here, your window will be very hard, and then instead of medializing the vocal cord, you are actually medializing the false cord. We don't want that. So this is the one you must know. This is the V of thyroid notch. I am marking it. Can you see the marking?
Yes, sir.
Here, here, here. See, with this, actually, what I do in live patients when we are operating, I mark it with cautery. Because with this marking pen, usually it doesn't work that way. And then I am going for lower border. This is the lower border.
Dr. Dubai has also joined us, sir.
When?
Dr. SP Dubai has joined us.
Okay, now this is the one. Now what I do, to find out the lower border, I have already identified, and then I take a scale, this paper scale, marking scale, what we get, I put it like this and put like this so that the lower border can be marked easily on the patient. Now this is the lower border. See, it is not going down. This is the thyroid tubercle. This is the lower border actually. This is my way of description that you make like this.
So your hand is coming in the way, sir. The image is
okay.
blocked by your hand.
Sorry. Now can you see? Yeah, but, 1 second. Now both the zoom karke, can you see the marking in the upper border and lower border?
Yes, sir, we can
Yes,
see.
sir, Brigadier, can you show it with
Yes.
your left hand? Just show the markings of the incision. Because the camera is from the camera is from the right side. Can you show it with your left hand? Just the marking of the incisions.
No, I am doing left hand only. But right hand, I am not a lefty.
No.
Sorry.
Okay, this is okay. Your finger
No,
should not
no,
come.
no, 1 second, 1 second, I am just showing 1 second.
Yeah.
Or you can see what I do in practice, practically, when I am operating on a human being, on a patient, to delineate the lower border, I use the paper, this scale, which is available with the marking pen. And I put like this and I have to draw a line here. Now I am going to draw the line, hand will come. Please don't trip. Now, can you see
Yes,
the
sir.
lower border has
Yes,
been
sir.
marked?
Yes.
Whereas if you go like this, these are practical tips I am giving you. If you go like this is the thyroid tubercle. I have marked your thyroid tubercle as well.
Can you use
Right.
your left hand? The pen on the left hand.
Yeah. That's what I'm telling. I am not a lefty. But besides that, jokes apart, we will measure the upper border and lower border. And this is about, can you see,
Focus, please.
is about, no. It is about 18 millimeter. 18 millimeter. Can you see?
Yes,
Yes,
sir.
yes.
Is it clear now? My hand is not coming.
Yeah,
Yes,
it's clear
yes,
now.
yes.
Okay.
Yes, sir. Yes.
Okay. Now I have to find out 18 means the midpoint is at 9 millimeter. So again measure from here 9 millimeter. I have to make.
आपने भेजा था क्या?
हाँ भेजा था ना उसको स्क्रीनशॉट लेके
भेजा सर
जी हाँ
This is the midpoint.
Right.
Can you see?
Yes.
करवा दूँगा
Huh? And from above also it is
9 millimeters.
9 millimeter. Okay? I hope all the participants are noticing. Now, This is a male larynx, that is why it is a little bigger. And what I am going to do is, I am going to make the window. Now, the dictum of the window is, in case of male, it should be about 5 to 6 millimeter away from midline. Why? Because if it is closer to midline, when you put your implant, it will medialize the anterocumpular area, which will cause strain in the voice. So that's why your window should be about 5 to 6 millimeter away. So in this case, lady says 6, so I must honor her. So 4 millimeters, so your window height should be 4 millimeters by maybe 10 or 12 millimeters. Because this particular
Naturally, you have to respect the decline.
dilation also light gone.
And below you have to.
This portion also will be small. Okay. So now I have given a cut and use a fine pierce elevator and try to elevate. Usually start elevating from behind, from posterior end, so that, or you can do from anterior end also. There is no hard and fast rule, whichever you are comfortable. I usually do ways depending on the circumstances. And believe me, in this case, the strap muscles are not there, but when we are doing in live, we don't cut the strap muscles. So strap muscles are behind. So it is very difficult to go from behind. You have to go from front. Only when you are doing Reconstruction, then initially you cut the strap muscles and then you do the thyroid window. So that I'm sorry, I have to, my hands will come again, but however I am trying to live
It is better.
Hello.
We are able to see, sir.
बोलिए.
Now, if you see, I hope you are appreciating.
Yes. Very nice.
And gradually go taking care to injure the inner pericardium. When Dr. Rishiki published in 78, he said that never injure the inner pericardium. If you injure the inner pericardium, abandon the surgery and go back again. Which nowadays doesn't hold truth. If you remember, from Austria, a gentleman he came and he gave a nice presentation and he cut deliberately.
The inner pericardium is injured, then what you do?
The inner pericardium, no. Nowadays thinking has changed. Inner pericardium. Earlier when we were not cutting the inner pericardium, we used to struggle to insert the implant. We used to have tough time. But then Gerald Frederick of Austria, he came to India in Dr. Gandhi's conference, and he demonstrated that deliberately he cuts the superior border, posterior border and inferior border, leaving anterior border intact. And he said this will help in insertion of the implant very easy. And after that, no turning back. That was maybe about 2 decades back. I started in 98, so for 2 years I was very particular that inner pericardium should not be cut. But after that things have changed. Now we start.
Pericardium, what are the complications you face?
Yeah, complication. I'll tell you, I'll just show you first here and then we'll talk about it. Now you see the inner pericardium.
Yes.
Okay? And inner pericardium you cut, but you should not cut the fascia over thyroid muscle. If you cut, there will be brisk bleeding. Whenever you cut a muscle, it bleeds. So we cut here, already partially cut, doesn't matter, and we cut here posteriorly, and then we cut here. it freely. Okay? Now, with this, what happened? See, this is going very easily. I make usually a template so that the template I insert to find out how much depth.
और इसमें 3 स्पीकर थे।
11. So the window is made. I'll measure the window. Let's see how much it is. It's about 5 by 13, but I want to increase little bit.
तो इसी डायमेंशन में बना सकते हैं।
Do you have any ready-made implant by Kurja or you are going to make it with Teflon block?
हो गया है।
See,
डायमेंशन ही
again tomorrow in my lecture I'll be telling you about ready-made implants. Those are TBFMI, Netreville prosthesis. All do with this, never do with hand. It will take you and cut your.
क्यों एक ही है ये एक ही है सब सारे कि अलग अलग है
आज का बनाया ना सर
यही है ना
यही पोडियम वाला होगा
वो पोडियम वाला यही है ना नहीं ऐसे वो पोडियम वाला वो उसमें चला रहा है तो
कहाँ चल रहा है
ये है ना बड्डे
पोडियम के यहाँ है पोडियम नहीं चल रहा है
वो पोडियम अच्छा ये तो क्या वो तो
20 साल का मार्केटिंग एक्सपेंस है तेरी बेवकूफ नहीं बना सकते
क्या
Though various implants have come in the market, I think most of the centers use silastic implant, and Brigadier Ramlingam has got that specific method to reduce the possible break in the implant that we'll see. Yeah. Yes, Brigadier.
So we used Netreville implants. 3 implants only I used. They are costly. One implant used to cost those days about 15 years back. It was about 3,500 like that, and you have to again cut to the size. Okay, and we didn't find it much useful. Then I switched back to the silicon block because that is very cheap. Out of one block of 15,000, you can treat about almost 25 to 30 patients.
Very long back, I used the Kurd titanium implant supplied by Kurd. It costed 18,000 rupees. I think 8 years back.
And there is no, and Netreville, sorry, Montgomery is very costly. So I don't use Montgomery. I have not used. It is about 75,000. Those days used to. I don't know how much it is now. But I have used plenty of TBFMI. We have published an article also about TBFMI. It costs about 17,000 nowadays. It comes in 2 sizes only, one for male and one for female. That I'll be talking to you, I'll be showing you how we do it also. Those who can afford, we can do with the Netreville, with the TBFMI by General Frederick. Okay, now the window is ready. If you want to see the window and
we are seeing very clearly.
Yeah, one second.
नहीं बचा था मतलब कुछ बचा नहीं था काम हम तो 15 रात में निपटा दिए थे सब पे
Can you see that?
मतलब 8:30-9 बजे एकदम झटके से
Is it clear?
Yeah, very clearly.
Okay, now we have done our job. It is
तो मैं सबसे पहले ऊपर पहुंचा जहाँ लैपटॉप रखा था मैंने चेयर पर वाली स्लाइड बनाई तब तक तुम्हारा फोन आ गया
by 14 millimeter. I think that is good enough. Let's now carve out. This portion is over. Now I am going for the implant carving. Suppose this is the implant. What we do? First, Our height is 5 millimeter. Remember, in my this thing I have made do it. Then it consumes time.
So this Teflon block is costing 15,000 silicon. Yes.
So now this I have taken out. Okay. Now try to understand why I am making this one. Our width of the implant is 13 millimeters, right? It is about 13 millimeters. So 13 plus 2 plus 2. 2 mm goes anteriorly and 2 mm goes posteriorly, so that it stays fixed tight. So 13 plus 2, 17. So our implant should be at least 17. So this is 17. Okay. Cut from here. So this is at 17 millimeter.
So we have to take 4 mm extra.
Now I have cut it. This is the implant now. It is raw still because I have to make 2 mm anteriorly and 2 mm posteriorly a wedge, which I have to remove. What is 2 mm? Again,
वो तो ऑटोमेटिक
2 mm is there.
ये सब ऑटोमेटिक जुड़ता है
सॉफ्ट कॉपी में तो निकलवा दे रहे हैं
So I think what it mentioned is one silicon block around 15,000 rupees, in which you can use the block for almost 25 to 30 patients.
So this is the ready-made block which we get from the market.
You get here in the market, silicon block. Cortex you can always use. It will be there in a small.
Can you see that?
Yes.
Yes. 2 mm anteriorly I have cut, and anteriorly and posteriorly. Now I have to cut this wedge. Tomorrow again in my video I will be showing you how to carve it from the silicon block.
Now the new block has come in the market. I was there last week in London for a course, and a balloon implant, a company I think in Germany. So they put in the implant, and how much you want to medialize, that much saline you inject in that balloon. And they have come in.
Sachin, I think you are talking about the UK one.
Walksway, yeah.
That is about 2.5 lakhs. I think I will never be able to use it on my patients. My patients will kill me. Anyway, UK is NHS. They can fund. They can get funds, but we can't get anything. Now, I'm just finishing 1 second. Now the anteriorly, you keep only 2 millimeter. Okay. And posteriorly you have to measure how much you want to keep. In this case we have this is about 7 millimeter. Okay, let's keep it at 7 millimeter. And I want to draw a line from here.
I think our friends from USA.
Yeah, can you see this?
Tell about the implant.
I have cut it. Now there is the final stage. Light gone, image gone. Yeah. Now I have to cut it. So what I do is, I cut it like this, and the mid portion has to be little longer. Why? Because mid portion of the cord is more important for vibration. So I have cut it. Now this is cut. Can you see this? Type A implant of Ishigi, and I have modified little bit to look like modified type B of Kaufman. Now you have to give 2-3 vertical cuts. Why you have to give this? I'll tell you. Because suppose you want to insert like this, you cannot insert. But if you give cut like this, so what happens? When you want to insert, this can go like this. This will bend. Okay? Right. When you do with silicone, can you see it is bending?
Yes, yes.
Okay. Now first I have to insert posteriorly. I think my implant is a little bigger, so let me cut a little bit off. My implant is slightly bigger. Let me trim it a little bit. One second, pardon me.
वाला है करप्ट स्टॉल पे मत देना मुझे भी करप्ट स्टॉल पे मत देना मुझे भी फुल स्टॉल पे मत देना.
Usually what I do instead of increasing the window, I do it on the implant itself. It becomes easier to cut the implant. Now I am going to put the implant, push it.
और क्या कुछ नहीं था ना इसका सिर्फ अकेले यही था स्टॉल पे
push it
या मैंने आपका
you are able to see. Okay, push it posteriorly first. First you insert posteriorly. Okay, it has gone in. Next is you have to bend and push it.
लंबा का लंबा
ये सही है.
Yeah. This is rubber, so that's why good. You have done perfectly well. So this goes, and now let's come here. Either other way. I am showing inside of glass. इधर अंदर आ जाओ. इधर आ जाओ भाई. इस तरफ सुनो. और brother.
दे दिया.
इधर आ जाओ.
हाँ बस हो गया.
उधर मेरा WhatsApp लास्ट वाला लैपटॉप है उसमें WhatsApp खुला है.
If you have endoscopy camera, I think we will be able to see better.
Endoscopy camera, I think, is it there? I think Dr. Rakesh is working on it. I can show. I am taking it out over there and I'll show. Okay?
Right.
Just hold a minute. Switch over to the. Can you please switch over to the other camera? You have I put up name. Yeah.
मेरा बोलना है 26 में आ गया.
ये प्रिंट करवा देगा.
प्रिंट कैसे?
Dr. Rakesh.
Dr. Rakesh, we are with you, I think.
Yeah, we are.
कहीं से करवा.
Can you tell us what you have done up till now? So now we are seeing endoscopic camera. Need little focus.
See, this is the cord.
Yeah.
Okay?
Yes.
Which I have medialized, I'll just show you. Can you see? It's moving. This is the one. Okay?
Yes.
And now I want to show you one more thing. See, from upper border of the medialized cord, I put an abdominal needle. Okay? And you see that this is on the upper border. Suppose I want to show you the midpoint. This is the midpoint what we had described.
We are not seeing it.
One second, yeah.
Now we can see.
Can you see?
Yes, yes.
This is the midpoint which I had marked, and through that I have put it. Okay?
Yes.
And this is the one. Okay? And here the upper border.
Yes.
And let's see where it is coming out. It is on the upper border of cord. Sorry. One second. Yeah. Right. Oh, okay. Yeah. Can you see that?
Yes.
It is on the upper border
of the cord in the ventricle.
So entire cord. This is on the upper border of implant. I put the needle, and it is coming on the upper border of the cord. So that means we have medialized the cord, right?
Yes.
Any questions so far?
Excellent, please.
Okay.
Yes, Brigadier. Fantastic.
To keep it
Thank
in
you.
position, the implant doesn't extrude.
You take the suture through the implant.
Thank you. I am now moving out. Dr.
Sir, do you take the suture?
Yes, you take it. Yours, huh? ऐसा देखिए उनके साथ इधर ही आ जाओ कम यार बेटा आप भी आ जाओ Thank you very much. Dr. Rakesh is there with us.
Brigadier, meanwhile, when we are connecting with Rakesh sir, can you tell us what a novice thyroplasty surgeon can create a complication while doing this?
जो बड़ा सा गेट
Hello.
लगा है
Hello.
Hi, good morning, Dr. Rakesh this side.
Okay, sir. We are seeing picture of Brigadier. Kindly switch on to Dr.
वहीं
Rakesh
नीचे ही
picture.
मिलो गार्ड खड़े होंगे वहाँ
So this was the
अच्छा तो मैं
cadaveric.
किसी
Audio
का
visual,
भेज
please.
रहा हूँ।
Yes. Now we are getting the picture.
Yeah. Can you get the
Yes. Please go ahead. Yes.
हाँ नीचे खड़ा है So this was cadaveric demonstration of tracheal resection or anastomosis. So by the time Dr. Ramalingam was demonstrating there, so what we have done that time, we have made an incision in a skin crease. So this is thyroid superior. Can you see that?
I think we should wait for the external camera.
Yeah,
because we are not getting the full picture.
This is left, this is right. So, आप यहाँ से आ जाओगे?
Sir, we are seeing the endoscopic picture.
Yeah, this is
get on to the external camera picture so that we can have it.
So white arm problem is it is magnified view, but the field is small.
If you little bit zoom out, I think we will be able to see the whole picture.
This is what the maximum height we can get. This rotating arm is smaller.
No, zoom out. If you can zoom out the camera.
No, zoom out, maximum zoom out.
Okay, maximum zoom out is there.
Yeah, so what we are doing, we are putting external camera, so that will be better.
I think that is right.
यहाँ से आ जाओ, यहाँ दिखाओ, हाँ, ऊपर जाएगा और हाँ, ये एरिया दिखाना है, यहाँ से यहाँ तक दिखाना है.
Oh, excellent. Now we can appreciate.
So,
little brightness has to be reduced in the center.
इसका लाइट कम कर सकते हैं.
So you can see clearly that you have given the incision into the crease
So
of
we
the
will decrease the light of white arm. Now you brightness बढ़ाइए. दिखाओ.
Now it is better. I think yes.
So now what we see is this is chin, this is superior, this is inferior. So this is suprasternal notch.
Yes.
This is thyroid prominence.
Right.
This is one skin crease. This is just at the level of cricoid. This is cricoid.
Right.
And then this is another crease. So we have made incision into crease from one sternocleidomastoid to the other sternocleidomastoid.
Right, sir.
Yeah. So now, once you do that, you raise the flare subplatismally. So this is platisma. So
Right.
we expose it till the thyroid notch. So this is thyroid notch.
Yes, sir.
Like this cadaver is a little stiff.
Yes.
So and these are the strap muscles, hyoid and sternothyroid and the sternohyoid muscle. So this is sternohyoid which is going up. Hello. This was sternothyroid. This is sternohyoid, and then this is the thyroid gland. Is it visible? No. थोड़ा सा आगे आके अंदर दिखा दो. रजिस्ट्रेशन काउंटर पे अब वो पीछे ही रखा है, आप ले लेना. ये दिख रहा है. Yes. So these are the thyroid. This is thyroid isthmus, which has been lifted up, cut and transfixed on either side. Okay. So after that, can you see this thin layer of fascia? This one.
आस्था को बता.
White arm खोलना जरा.
अच्छा वो उनका हुआ डेलीगेट्स का हुआ.
Now we can go again to white arm.
Yeah. So this layer, can you see that?
Yes.
White arm picture.
Yes.
So this is layer of the pretracheal fascia. So the principle of thyroid, this tracheal surgery is that you have to dissect right onto the trachea. So there should not be any soft tissue there. So the pretracheal facial layer was also dissected on either side. Okay. So what we do now is we will cut this open so that the exposure improves. Because it's very hard skin. So just cut it in the center. Yeah. We will be requiring blade, more blade.
हाँ कम
Give it
हाँ आस्था.
छोड़ दो.
हेलो. हेलो.
In place of 15 number, they can take bigger.
Vertical incision we use occasionally, especially when there is an extension into the mediastinal trachea is also involved. So if thoracotomy is to be done, then it's better to use. So stay in midline. Right. So now you can take retractors. So now
26-28
is it better?
Yes.
26-28
Okay. So
पेमेंट तुम कर दो
this is so any tracheal surgery you want to do, first you have to assess what is the problem. So what exactly where is the stenotic segment? Usually it is the post-intubation subglottis or the tracheal stenosis. So usually the subglottis and the upper trachea will be involved. Some of the cases on the isolated tracheal stenosis will be there. So if patient has tracheostomy, then you give anesthesia through the tracheostomy and you expose the stenotic area. You can confirm it by doing endoscopy, put your endoscope and mark it. So there are 5 lengths which are required from level of vocal cord up to carina, that is 1. Then from carina to the lower extent of the stenotic segment, that is 2nd. And then from vocal cord up to the upper limit of the stenotic segment. So that will tell how much you have the proximal segment away from the stenotic segment and what is the distal segment of the normal trachea you have. So roughly you can excise about half the length of the trachea, which is about 13 to 16 centimeter in the adult male. Okay, so you can safely excise about 5 to 6 centimeter. Regarding release, anything 2 centimeter or thereabout, you need not do any release surgery. Anything more than that, you have to do release. So release, how much you will get? One release is trachea, anterior and the posterior tracheal, so that will give you about 2 centimeter. Suprahyoid release you do, that gives around 2 centimeter. And by flexing neck, you will get further 2 centimeter. So you will get around 6 centimeters. So that is approximately half the length of the trachea. Anything beyond that, then you require the intrathoracic procedure where you can transplant the left main bronchus into the right main bronchus from carina. So then you can get 4 or 5 centimeter further more. So for an ENT surgeon, most of the cases will have the cervical tracheal or the subglottis tracheal stenosis, right?
Right.
So this is thyroid notch. This is cricothyroid muscle. Can you see those muscles on either side?
Yes.
This is cricoid. This is first ring, then second ring, third ring, fourth ring, right? So the important thing is in anatomy, all the blood supply of the trachea comes from the lateral side. So cervical trachea branches of the inferior thyroid artery, which goes down and up, and then they penetrate into the submucosa, and then they form the chicken wire kind of capillary network. So don't dissect laterally unless it is required. So if you are excising stenotic segment, there you can go all around, but don't go beyond 1 centimeter of either edge of your normal stenotic, normal tracheal or the subglottic lumen, because more you dissect laterally, you are compromising the vascularity of your trachea. So that will help in retaining the vascular part of the trachea, so the complication will not happen.
Right.
One more point is, when you are dissecting under the trachea, it is advisable to put the Reyes tube in the esophagus. So at the time of surgery, you can palpate whether the party wall between the Reyes tube and the anterior wall of the esophagus is intact.
Right.
Okay. So what I have done is I have tried to go back side. Okay. So
you do marking with the radioscope or with the flexible scope?
This artery is a normal curved artery. So usually what you use is Negus, right angle artery. So that is easy to take. So that we don't have. So I'm just trying with this. However, if there's a lot of fibrosis and you don't get the plane or you are having issues, so what I usually do practically is that you incise the trachea, the stenotic segment, right? So if you consider like first ring is normal, second and third ring, so you open the horizontally trachea, right? Then you take a skin hook, there we don't have, so let us have a small mosquito, put it in and confirm. So where is your stenotic segment? Suppose your outcome of resection anastomosis entirely depends how your two edges work after excision of the stenotic segment. So the remaining edges after excision has to be healthy in form of good cartilage support, normal mucosal lining and normal lumen. If those criteria are not met, then there will be subsequent restenosis and you will have problem. Okay, so the advantage of this is you can put a small endoscope and see, or you just keep opening till the time you get the normal tracheal wall. Okay.
So I want to ask one question. The cut should be made just above the tracheal cartilage, or it should be at the upper limit of the intertracheal cartilage tissue? What should, like if the stenotic segment was down, so you would be cutting right up the above the cartilage, tracheal cartilage, or you will take the lower tracheal tissue also?
So what the standard textbook teaches you, that once you assess where the upper and lower limit, doing endoscopy, so there you can cut whether upper or lower. I usually try to cut on the lower side, okay, because upper side you want to save as much normal cartilage is there, so that can be done. But usually, practically what you do, you cut at the stenotic segment. So that the advantage of cutting at stenotic segment is that you can hold that stenotic segment with the Ellis forceps. So that gives you good retraction and that will not damage your normal cartilages. So that is a practical thing. Okay, and once you open, then you can keep opening. So directly you know where is the normal volume. Okay, so go gradually. Okay, suppose I say this is finishing. There the stenotic segment is finishing, the proximal part. I will be requiring another blade. Yeah, 15 on there. So what you do is, don't go through and through. So inner part you cut and then you take the space suture from below, because if there is no tracheostomy, the anesthesia will be ventilating through this part. So when you cut this open, this part has to be pulled up and you have to create the neostoma if you want to put a Montgomery tube. If you don't want to do that, then what you do is lower segment where it is normal, you put the flexometallic endotracheal tube from the lower end. Okay? And once you cut this tend to sag into the thorax. So then your tube will be continuously coming out. So before you do that, you take suture from the trachea. From side you retract, yeah. try to take through cartilage and avoid going through the mucosa. So extra mucosal.
You are taking
through
prolene
cartilage.
suture.
So
you are taking
just apply
prolene.
the.
Hello.
Hello.
Sir, you are taking prolene suture to hold the trachea.
Suture, space suture, I usually use self. One can use prolene. So prolene advantage is obviously it is monofilament. The reaction will be less. The problem is any monofilament, the putting knot is difficult, and knot when you mate it, it becomes little thicker. So prolene or whatever your choice is. So either side you put so that this segment will not go in. Right?
Right.
So this is change, blade change. So what I am doing is I am not going through and through. Okay. So I am just, and then you open the lower edge. Because this part we have dissected, so this is okay. You remove it. So now you can see the posterior wall.
Yes.
Right. So I will remove those cartilages so that inside can be seen. They are quite stiff. Right. So now I can put my, see. So can you see the movement?
Yes.
Right. And you can even palpate. So there is not much of the soft tissue between your finger and the artery fossa. Same this side you go. Right. So now I can see my so I'll take ribbon gauze.
You have put it any rise tube in this cadaver?
This is too thick. Just retracted nicely. Go in. On the posterior wall. So this is what I was talking about, inside out incision, the dissection. Hello?
Yes, sir. We are with you.
So any question or comment till this part? Is it visible outside?
Yeah. Very.
What I'm cutting?
Have you put the Ray's tube in this patient? In this cadaver?
So you will just tilt it.
Hello, sir.
Hello?
Have you put any Ray's tube in this cadaver? Any Ray's tube?
Ray's tube? No. This is very hard. The two attendant came and they tried with their all might to extend neck. Nothing happens.
Oh.
So I've not put Ray's tube. If you want the technique, we can show onto that dissected larynx which are there outside.
Excuse me, sir. This is Harry from America. Beautiful dissection. Quick question. What are your contraindications to the surgery? When you see a patient and you're asked to treat someone with extensive stenosis, atrial collapse, do you have criteria which you decide whether someone is fit to have this resection? Hello?
Hello?
Hi, sorry. This is Harry from America. Beautiful dissection. I just wanted to ask, do you have a selection criteria for these patients? Are there certain patients that you think would not benefit from a tracheoresection? So, for example, in my hands,
your voice is echoing is too much here.
Sorry.
So
Okay, how about now? Can you hear me now? Is that better? No? Hello? Now?
Hello, yeah.
Can you hear that better? You can hear me okay? Maybe not.
Yeah. So,
Dr. Rakesh, you can hear from this mic properly.
Yeah.
Yeah, actually, Dr. Harry is asking if you have any selection criteria and what are your contraindications for going ahead with a tracheal dissection and anastomosis.
Okay. The selection criteria is that the stenotic not amenable with the conservative things like the stenotic segment which is larger than 2 centimeter. Okay, stenotic segment where the cartilaginous support has gone. Then stenotic segment which are involving the ideal cases are tracheal stenosis, isolated trachea. The stenosis which involve the lower subglottis tracheal, those also can be done. The other cases where you can do the resection anastomosis is the tumor which are infiltrating trachea, like the thyroid tumor which is involving the trachea. So there to take the margin, you have to excise the part of the trachea. And beside that, the another part was the contraindication. So contraindications are one is that the general condition of the patient, if they are not fit for general anesthesia, that is one. If it is too long a stenotic segment, suppose it is a say 7 centimeter, 8 centimeter, so then it becomes a contraindication unless you have a thoracic surgeon which can open the chest for you and then he can transplant the left main bronchus into the right main bronchus. Okay. Any case where you cannot bring it end to end, so those are the contraindications. Otherwise, most of the stenosis, benign stenosis, the resection anastomosis is the treatment of choice. Okay, so I will say if the general condition is not good like patient who doesn't have the good cough reflex, and if there are aspiration also happening, so there I would like to wait till the time the person doesn't aspirate or his cough reflex has come back. So any airway surgery I will not prefer to do when there is a poor chest condition or poor physical condition.
Thank you.
Right. So now the one part is that we'll hold this with Alice forceps. So now I'll be going and doing dissection anterior tracheal wall to release from the soft tissue out. So the plane is important. Unless you are well plane, don't try to force your finger there. So what we do is the sternotic, the area you can hold with Alice. So that will give you counter pressure. Okay. Reach into the right plane. Okay. So is it visible there? This one? I need camera to be shifted here, please. There. So, can you see these are tracheal rings and this is the plane?
Yes, sir.
Right?
Yes, sir. Very yes.
So, you hold it and then you put your finger, just dissect it, don't force it. If you are in the right plane, it is very easy to slide your finger between the trachea and the soft tissue. Okay, and you can easily go till carina. Go in. Ensure that you don't dissect too much laterally. So I have done that. I have reached carina. Right. So once you do that, then you go onto the posterior wall. So there you have to respect the posterior wall. Don't damage it with the LS or something. So just go there. There will be few bleeders. So don't be in a hurry to cauterize them. You wait and they settle. So if you are in a correct plane, the party wall you can easily separate from the membranous tracheal wall and the esophagus. Okay, so that will do anterior posterior dissection. So this will give you about 2 centimeter, right? So now at this stage, what you need to do is the membranous wall. Once the two edges, you ensure that everything is fine. Below it has good lumen with nice healthy mucosa line, and as well as upper part which is again normal. And then you have to start suturing. So suturing has to be started from the membranous wall. So what you do is you take extra mucosa, not outside. Okay, so those knots are at times difficult to put onto the posterior wall. So there you can take the full thickness including mucosa. So 4-5 sutures about 3 to 4 millimeter apart onto the membranous wall. So that will not create much of a problem because either you are using Vicryl 3040 or you are using PDS. I usually prefer PDS there, right? So before you do that, you ensure that when you put it to edges, edge to edge, so there not much of tension. This cadaver is very stiff, so I don't think you can bring it. I have removed only 2 rings, and you can see hardly it is getting pulled down. So even if we do release, will not get much. So one of the ways that we can stitch it here, okay, or if you want it, then we can do it there. What do you want? Ask them. So we will ask them. What I'm thinking is, one is that we put sutures here and show you. It is very stiff. It is difficult to move. And another option is that we take out that the trachea and the larynx, which is lying there already dissected out, and there we demonstrate how to do suturing. So then what do you want? Hello?
I think that will be better.
That will be better?
Second option
Right.
is better.
So this part is okay. Any question or any comment in this part? Exposure of the stenotic segment, excising that, keeping the stenotic segment till the end. So you will use it as a to hold it the Ellis and use it as counter traction. If there is a no tracheostomy, then your tube has to be till the stenotic segment, and once you cut it open, you can't ventilate, so you put your tube through the lower segment, okay, and then you start suturing onto the membranous wall and the lateral wall. Once that is done, then you bring the nasotracheal or the orotracheal tube, just pass it onto the lower end of the trachea, and then you complete the lateral and the anterior suturing. Right. If there is a tracheostomy and if you want to put a stent, then you can put a stent after you suture the membranous wall and 2 or 3 suture on either side, and then you put Montgomery, lock the upper end so that anesthetists can ventilate, and then you suture it over the upper end of the Montgomery tube, right?
Okay.
So we will go and do the suturing there.
Right, sir.
यहाँ पे ले आओ, इसको can we keep it on this? Can we keep it on this? So this step is important, that you have to dissect right onto the tracheal wall. Don't leave any soft tissue there. even the pretracheal fascia, if you can get the plane into the trachea and pretracheal fascia, so that is ideal. So this is much softer. Yeah. Take it off, let me see the picture. बहुत thick है थोड़ा सा जस्ट डेमोस्ट्रेट ना फोल्ड कर लो
So sir, distally we have to, the important point is that distally we have to dissect not in the 360 degree. We have to dissect only whatever the length is required.
Rakesh, there's an opening below, maybe 2
Yeah.
centimeters below. Why not use
So
that to demonstrate?
leave it. So till this part we have demonstrated there, so we just cut it open.
Dr. Rakesh, there's an opening below that anyway.
So this is cricoid, first ring, second ring, third ring, fourth ring. So thyroid has been cut and separated. So we'll cut this open, okay, and we take it as like we have excised the stenotic segment. So let us just go through and through. Because already we have exposed it, so I am just cutting over my gauze piece. Right. So now these are the two ends. Okay. So what you do is you dissect them anterior and posterior, so that to gain the length. Okay. So when you excise, you require the length, so that you will get by dissecting anterior wall and the membranous wall from the esophagus. And above there is no point in dissecting because hardly there is 2 centimeters, so you will not get much of the thing there. You can just release about say half a centimeter so that you can put suture through it. Right? So more than that is not required. So now the anesthesia is going through this, or if there is a stoma, you can put it endotracheal tube through that, and then you can peacefully work here. Right? So can you focus inside now? यहाँ आ जाओ. यहाँ पे यहाँ अंदर दिखाना. So can you see this one? So this is membranous wall, right? So this is membranous wall. This is the D-shaped cartilaginous ring, tracheal cartilaginous ring. This is membranous trachea, and this is lower end. This is cartilage ring, this is membranous wall. Okay, so then you see whether you can bring two edges end to end. You want more closer. Okay, if it is coming without tension, then you start suturing. So if there is a no tracheostoma, only you want to expect patient on table, or you want to put patient with endotracheal tube to the ICU. At this moment, before you start anastomosing, anesthesia tube is here. So first you suture the membranous wall. So give me suture. So it knocks outside. Take right angle or something so that, or this one. Just can you see that there? भी देखो
बेटा सर
अपना लाइट यहाँ से दो आओ, यहाँ से आओ, यहाँ आ जाओ. Just give us about 2 minutes so that we have proper light, and then we can have the good exposure. So this is the membranous wall of the lower end, and this is membranous wall of the upper end.
Yes, sir.
Take it as the stenotic segment has been excised. So what you do? So I usually take through and through for the posterior wall. Standard teaching, or the people do extra mucosa, that also can be done. Right? So you are going from inside out. And then so now you pre-place sutures, mosquito, scissors, right? So one can take Ellis forceps, okay? So keep putting those the artery forceps. From outside in, and this is from inside out. Mosquito. Okay.
वो आ गई ना मैडम, वो स्कैन करना है. अभी कितने मुझे बता देना ना, वहाँ पे ऐसा खाली होगा ना तो मैं यहाँ पे भेजूँगा.
One more suture, please.
हाँ ना, अभी है ना, अभी लोग हैं वहाँ पे ना, थोड़ी देर से भेजूँगा. बता देना मुझे फट से 5 मिनट पहले.
So for patient, you have to the distance between the two sutures should not be more than 3 or 4 millimeter. For here demonstration purpose, I'll just keep 3-4 sutures all around so that the time can be saved. Straightening curve. and the distance from the edge again has to be 3 or 4 millimeter on the membranous wall. When you come onto the cartilaginous ring, then it has to be one ring above and one ring below. Mosquito and then cartilage. So you put suture on the membranous wall and maybe 1 or 2 suture onto the lateral wall, and then you ligate. Ligation has to be, the first suture which was put has to be ligated first, and when you are ligating, the two edges has to be approximated. So that you can do by those stay suture on either side, so that the assistant pull those suture to approximate edges. So let us suture it. So I take 3 throws. So advantage of taking 3 is that it will not get loosened up. Okay, so just show me the edge inside, whether it is approximated or not. So now it is approximated. So give me smaller one. So it is critical when you cut suture that you should not cut the other suture which you have put it inside. Okay, so the knot goes extraluminally. Yes. So once that membranous wall and part of the lateral wall is sutured, just show it inside. Can you see now? Membranous wall is edge to edge. So what is important is this: there should not be any raw area which is left behind. Is it visible? Hello.
Hello. Yes, sir.
Right. So at this point, you have to ask the anesthetist to push the upper endotracheal tube, orotracheal tube, beneath the stenotic segment or your anastomotic line, so that cuff goes inside.
Yes,
okay. So now you have 2 edges. You have to complete the anastomosis. So give me again suture. So this suture has to be 1 ring below, 1 ring above. So you go in, okay, don't go through mucosa. Can you see there?
Yes, sir.
Right?
Yes.
Zoom करो उसको. Is it visible that extramucosally not has to come outside? Don't take mucosa, extramucosally. Okay, so one ring below, one ring above. Now put that mosquito. Cut it.
So suppose you don't have enough tracheal rings above. Suppose your upper end of the resection is just at the level of required.
Yeah, one more suture, that's it. So again you put those sutures extramucosally. Just for completion's sake, this will be my last suture. So approximately 12 to 14 sutures are required to
Dr.
do
Rakesh,
the
can you hear me?
watertight suturing, right? So you just finish this tightening, right?
Dr. Rakesh, can you hear us?
Yeah.
Sir, in case you don't have enough tracheal rings, say the upper end is at the cricoid, then how do you do it?
Sorry. Repeat
In
it
case,
again.
in case the upper end of the stenosis is at the level of cricoid. If the upper end of the stenosis is at the level of cricoid and you don't have tracheal rings.
Yeah. So what you do in those cases is that you have to take out the arch. Okay, that means the lower subglottic stenosis along with the tracheal one, right?
Okay.
So you can excise the arc. You preserve the lamina.
Okay.
And then you do tracheothyroid anastomosis.
Okay.
The issue is in those cases you have to put a stent.
Okay.
Right. If you don't put a stent, and these are the cases where it will be like re-stenosed. And I usually tend to put a stent for longer duration when this subglottis is also involved.
Which stent are you using, sir?
Yeah, and the issue comes the upper end of the T tube, the stent. It should not be hitting under surface of the cord, otherwise granulation will form.
Okay.
And if you cross the vocal cord, then you can't keep it open. Then you have to close the upper end.
Okay.
Right. So then patient can't breathe from above.
Okay.
Okay. To avoid aspiration. So that is much more difficult position than doing conventional tracheal anastomosis.
Okay,
Tracheal anastomosis, the success rate is more than 90%. If subglottis is involved, then it drops down to somewhere 80 to 85%. If the whole subglottis is involved, then I will say it will not be more than 70-80% success rate.
Okay.
So I think other side they are demonstrating, they are waiting for the next thing. So yeah, so I will ask the cameraman to shift to other side. Thank you very much.
Thank you, sir. Thank you, sir.
Any question? More questions?
No, sir. Perfectly clear.
Yeah. Thank you.
Thank you, sir. Bharti madam. Hello. Hello. Hello, Dr. Bharti.
Hello.
Hello, Dr. Bharti. I'm Dr. Dubey here.
Hello, sir.
How are
Actually,
you,
there's
madam?
slight change in the plan.
Okay.
Because of the time shortage, I'll be just demonstrating the tracheostomy.
Okay.
And then we'll be talking about the percutaneous dilatation tracheostoma, and then cricothyroidotomy. And then afterwards, I'll be dissecting the ANSA in another body. If at all the time permits, I'll show after 1 hour.
Okay.
The anastomosis between ANSA cervicalis and the recurrent laryngeal now.
And what about sliding tracheoplasty?
No.
No. Okay.
Trichotracheal resection will demonstrate later.
Right, madam.
So what is she planning? Yeah. So we all know actually this is for the postgraduates, and airway surgery conference cannot be done without knowing how to establish the airway. So there are two things how to establish the airway by the tracheotomy, or also now we call it as tracheostomy. There's a difference between tracheotomy and tracheostomy. Tracheotomy is just making an opening in the trachea. Tracheostomy is you make a channel between the skin and the trachea. You suture the skin, trachea to the skin, so that the channel is formed between the skin surface and the tracheal opening. And then in emergencies, now we know that the indications for tracheostomy is vast and it is changed. In our days when I and you started, sir, it was mainly because of the stridor. But these days the indications are wide because of the CCCU or ICU or all these areas where the trauma is there. Now the patient on ventilation, where they need the prolonged ventilation, they are going for tracheostomy.
True.
To establish a airway. So in that, when to do tracheostomy remains the thing, whether to do immediately or like 7 days or 14 days. There are so many studies which have shown if it has to be done on, like if the patient needs ventilation. In our college, we do, if at all the head injury is there, the second day only, because the neurosurgeon decides this patient will be there for more than 2 weeks on ventilator, you do. Otherwise, in the ICCU or ICU, it will be between 7 to 10 days, because so many studies have shown if at all you do tracheostomy within this period, 7 to 10 days, your duration of stay in the ICU is less, plus the analgesic dosage is less, all the medications will be less. So that it's a sort of, you're bringing the patient back to normalcy as early as possible. This is the goal of all our surgeons. So we need to do that. So now, because we have intensivist critical care people, so the regular tracheostomy, what we do is all taken away by them. They do percutaneous dilatation and tracheostomy. So they have a separate instrument for that. First I'll tell about our tracheostomy and then we'll go to theirs. So either it is emergency tracheostomy or elective. All these ICU patients and all, it's an elective tracheostomy. Only patient who comes with stridor, then we do the emergency tracheostomy. So in emergency tracheostomy, the incision what we give is very different from the elective tracheostomy. But always one principle to be followed is stay in the midline as far as possible, especially in children, because a little away, then you are on the carotids. In children, it's very difficult to differentiate between the tracheal wall and the carotid, because I've seen them. So you have to be very careful in children when you are doing tracheostomy. Always stay in the midline. First dictum is stay in the midline, and whenever we are doing emergency tracheostomy, our incision differs. The incision will be vertical incision. This is the cricoid cartilage, which we need. Any marker is there? Okay. This is the thyroid. We usually mark. This is the cricoid. This is the lower border of the cricoid. This is the first tracheal ring, second tracheal ring, third, fourth. So our tracheostomy should be somewhere between this area. Normally, between second and the fourth tracheal rings, our tracheostomy should be there. What are the other indications for high tracheostomy? If I know that the patient has come with stridor, I am going to do laryngectomy for him. Then I do high tracheostomy, because I want the lower tracheal rings to be there for the future tracheostoma. Okay. Then, what is the indication for low tracheostoma? The only indication for low is if there is a mass here. Usually it is the thyroid. thyroid mass, you cannot go there, then we do the low tracheostomy. And then the position of the patient, normally it should be the extension, but in emergency it's either you can't make the patient extended for a long. So all our preparation has to be done before we put the patient in the lying posture. That is, the sister should be ready, the tracheostomy tube should be ready, and then the surgeon should be ready, the light should be ready, and even the infiltration, if at all you are doing, because we have Thrimeters, we give a high flow oxygen with them, and then everything should be ready before we put the patient, even the infiltration into the area, if at all we are doing under local. And even a small lumen is there also. The anesthetist, we can ask the anesthetist to keep a small side tube and ventilate. Only thing is they should not paralyze the patient. That is the dictum we follow. Then the incision, if this is the suprasternal notch, if this is a cricoid, then vertical incision from the lower quarter of the cricoid cartilage, about 2 to 3 centimeter. We do like this, skin, subcutaneous tissue, and then we reflect, and then we go for the strap muscles. So if the strap muscles are separated in the midline, and then once we separate the strap muscles on either side, then we come across the thyroid isthmus. So here it is shrunken, that's why it is in the cricothyroid, the membrane region, cricotracheal region, but it will be here. And then what we do is, once we see the cricoid, thyroid, then we take a cricoid hook, and then the pretracheal fascia should be separated properly over the tracheal rings. Otherwise, the air escapes. If at all the size of the tube doesn't fit properly to the size of the tracheostoma we are making, then the air escapes and then the emphysema chances are high. So the pretracheal fascia should be open, and then if there are any veins here, you properly coagulate them, and then you retract the cricoid. Along with the cricoid, we will be retracting the thyroid isthmus also. Most of the cases, we don't cut the thyroid isthmus. Only if it is required, like if there is enlargement of the thyroid isthmus, we cut the thyroid and isthmus, and then we need to ligate properly. The suturing the isthmus should be done properly. And then we identify the rings, first, second, third, fourth. And I always make a joke flap. That is, I make a inferior base flap. So what I do is, I make first a horizontal incision here. Hold. Horizontal incision like this. Yeah. So this is the inferior base flap. Then I put a suture here and then fix to the skin, so that our insertion of the tube and the tube will not be misplaced in future. So this is what we do in adults. And then whereas in children, I do a vertical tracheostomy. That is the same second, third, fourth. Vertical incision I give. Maybe I'll go lower. Yeah. Before that, we put 2 stitches on either side. So, like this, 1 stitch here, 1 stitch here. This acts as a stay sutures, and then we introduce the tracheostoma to here. Whereas here, the joke flap in the adult, yeah. So we put the tracheostomy. Once we suture it, then if the patient is already on the tracheostomy, endotracheal tube, we ask them to deflate and then remove. If the patient is non-endotracheal tube, then before opening, we confirm it is in the trachea. How do we confirm it? We take the needle with the syringe, 4% xylocaine, and then we go inside, and then we aspirate. The air bubble will come, and then little anesthesia we again infiltrate, so that it will anesthetize our trachea, and immediately we make this. Once we open, the airway is open, the patient will be normalized, like he is able to breathe, then he will settle down, then we can do all this suturing and all. So this is a joke flap, this is in pediatrics vertical incision, and then what tube we use depends upon what is the indication for our surgery. If the indication is for ventilation, the patient has to be put on a ventilator, then it has to be a cuffed tracheostomy tube so that the cuff occludes and then the patient can be ventilated properly. If the patient is for like other patients like Strider, I will not put the cuff tracheostomy tube. It's a plain cortex tube I'll use for them. Whereas in other patients where the aspiration is a problem, then the cuff tracheostomy tube is there. We'll put cortex. Metallic tubes is out. We never use metallic. And then in patients where you want them to be weaned off in the decanulation, then the type of tracheostomy tube we use is both inner and outer tube is there. So the inner tube has one is the occluding and another with the speaking one. So it has a fenestration. So we put the inner tube with fenestration and then we block the tube so that normal part of the patient will be able to breathe. So that will be the one. And this is about the tracheostomy. Then in the in ICU, ICCU also, these things if they call, I usually do in ICU, ICCU also. But if the intensivists do, they do with their dilatational, percutaneous dilatational tracheostomy. They have the, before they were using Schlesinger, now they have the Sieglia. So I don't have that here. So what they do is, the only contraindication for that is, if the patient is very obese, then the thyroid is huge here, they cannot see the landmarks properly, they will not do. And the patient has coagulation problem, then they will ask us to do. And the patient is on more of, respiratory failure is there, then they want us to do because they can't keep the bronchoscopy too much there because all this percutaneous dilatational tracheostomy, they need to do with the bronchoscopy, video bronchoscopy, so that they'll be seeing inside. And then what they do is, this is the this is the first ring, second ring, either in between the first or the second ring or the second and the third. I usually advise them to do between second and third, so no chances of injury to the cricothyroid membrane and the cricoid cartilage. So here they pass that guide wire between the second and the third. They pass the guide wire and then the serial dilators are there. Yeah. So they dilate. And all this is done under the bronchoscopy vision. So they dilate and the endotracheal tube they'll pull till here, the bronchoscopy will be here inside, and then the tracheal dilatation they do, and then through the guide wire, once it reaches 7.5 or 8 millimeter depending upon the patient, then the tracheostomy tube will be inserted. But nowadays we have a blue rhino tube dilators, that is a graded one. In one dilator only, you have like a tapering one, tapers, then goes on increasing in size like this. So what they can do is, put the guide wire, then they insert like this, go, like how we have the esophageal old dilators. So it dilates to the extent what we want, and then they can put the tracheostomy tube. That is, but the incidence of complications are high with this. All this percutaneous dilatational tracheostomy. That is because whatever it is they are doing in the ICU, and they have the only video bronchoscopy has a vision. The complication rate is high as 16% in some of the studies. And the other one is, if the patient like just broad and you cannot do anything, you can always identify this cricothyroid membrane. This is the cricoid cartilage, this is the membrane. So just puncture the cricothyroid membrane, then open it and pass the tube here. Smallest endotracheal tube we can pass, and then we can take our time to establish a proper tracheostomy. Right. I think this, anything else you want me to show? I think in this.
Madam, what is the disadvantage if we don't excise the U flap like you shown? We can put a simple incision because head is extended. As soon as we give the intercartilaginous part incision.
One second. What is the?
Don't excise, only if you cut the intercartilaginous space, it will open and you can put a tube without cutting the cartilage or without making the flap.
Any question, I'm not understanding the question, sir. Here it is echoing this room.
Are you able to hear me?
Now, yeah, better.
Madam, I am asking why to make flap? Can you give only incision, horizontal incision, transverse incision, because head is already extended, so it will open up and then put a tube without making any.
Correct. That is, see, the horizontal incision in between the tracheal rings you can make. But the problem, what happens is, the maintenance of it will be a problem in most of the patients where the patient is fat, and then insertion, removal will be a problem. The only advantage with the joke flap is the introduction of the tube is very easy, the track is easily formed, and it's easy for anyone to maintain it. That's the only advantage of the joke flap over the intercartilaginous incision, sir.
And when you remove the tracheostomy tube, when you decannulate, you put the joke flap again, back, or you leave it like that?
No, once, that is when afterwards.
When you decannulate the patient.
Yeah, after the decannulation, yeah, that is the one disadvantage of the joke flap is the permanent, the tracheal closure is little problem in them. So what we do is we just release it and close it afterwards. If at all it doesn't close automatically.
Oh.
Some people also advise to remove the tracheal cartilage. 2, 3, 4 in the center. Minimal cartilage they remove, make an opening. But we are all airway surgeons. We need to minimize the excision of the tracheal rings. So we don't advise that, sir.
Right. Thank you, madam. Excellent.
Thank you. I'll see in one body. I'll be dissecting the ansa cervicalis and then the recurrent laryngeal now. If at all I can get it after the lunch, I'll show the anastomosis.
Thank you very much for nice demonstration party, madam. Thanks a lot.
Thank you, sir. This is okay. I'll just see in this. Can ask somebody to, and this can be off.
I request the chairpersons to please be on stage and receive memento. We will now begin with the video presentations. I request Dr. Bharat Panuvanti sir, Dr. Bharat sir,
पे था फोकस आउट वहाँ पे भी आप ही है क्या? वहाँ पे एक लड़का छोटा है अभी वो इधर उधर हुआ था तो मैं फोकस का प्रॉब्लम कर रहा हूँ जूम कर रहे थे अभी मैं यहीं बीच बीच में इम्पोर्टेंट लोग का फोटो फोन में लिया है क्लैरिटी पीछे से नहीं आ रहा है ठीक है तो देख लेना अभी वो है नहीं वो अभी खाना खाने के लिए गया है हाँ नेक्स्ट सेशन में है तो मैं कर दूँगा इसे कॉपी
हाँ हेलो बोलो हाँ बोल देता हूँ अभी तो मेरे को नहीं बोला उन्होंने कुछ भी पूछ लूँगा अभी पूछते हाँ मैं पूछ लेता हूँ हाँ ऋषभ जी वो थोड़ा वो उसका ऑर्गेनाइजिंग कमेटी का जो बना के भेजा है ना वो उसको सेम सीक्वेंस में ही डालना है मतलब जो ऊपर नाम लिख के मैंने भेजे थे वही सेम सीक्वेंस में ऊपर और वही फ़ोटो नीचे हाँ वो उसमें कहीं भी कुछ भी नाम लिखे हुए हैं और वो एक शुरू में जो सबसे शुरू में नाम लिखा हुआ है वो तीसरी लाइन में जाएगा और उसमें मेंशन किया हुआ है मैंने इसीलिए वो बना के ही भेजे थे नाम ताकि कन्फ्यूजन नहीं हो वो बार बार क्या मेरे को बोले तो वो क्या मज़ा नहीं आता उनको वैसे ही उनसे काम से बहुत परेशान है थोड़ा देखो ना उसको है ना उसको हाँ थोड़ा करवा दो उसको काफ़ी दिन से लगी हुई है ठीक अरे ये ओपन नहीं हो रहा है क्या है OBS चल रहा है ना तो ये फाइल अभी ओपन नहीं कर रहा है मतलब OBS की जो भी है
जिस पीसी को भी जहाँ से हार्ड डिस्क दिखते हैं वहाँ खोलिए ना
वही तो नहीं खुल रहा है यहाँ से दिखती है ना हार्ड डिस्क ये इसमें OBS खुला हुआ है, यहाँ से OBS खोलूँगा, OBS बंद करूँगा ना तो लाइव बंद हो जाएगा। दूसरे उसमें लगा दूँ, मेरे पास और भी तो लैपटॉप है। हाँ दे दीजिए ना, कार्ड रीडर है आपके पास? हाँ तो बस ठीक है, उधर लगा दो, उधर चलता रहेगा।
For the next session, I would like to invite Dr. Bharat Sir, Assistant Professor, Department of Otolaryngology and Head and Neck Surgery, Washington University. I request the chairperson for the session, Dr. Ravindra Bansal Sir. Dr. Vijendra Baser Sir. Dr. Shrikant Pathak Sir.
Hello? Oh, sorry about that. Okay. Really a pleasure and a privilege to be here. It's been wonderful hanging out with Dr. Gandhi, seeing the incredible practice he's been able to build and develop over the course of these years. And it's always nice as you know, an American surgeon to go internationally and see how things are done differently in other areas. I think we have this tendency to get siloed and develop an idiosyncratic practice based on our personal exposures, and it's really nice to sort of break out of that shell and see what other people are doing. So I want to thank Dr. Gandhi and the rest of the staff for having me here today. I'm going to talk to you guys a little bit about my approach to early laryngeal cancers. I know this is meant to be primarily a video-driven presentation. I do think in the interest of setting up my philosophy and my perspective as far as early laryngeal cancer goes, a little bit of background is important, so we'll talk a little bit up front before I delve into some videos. Just as a sort of gestalt, I think for me especially, early larynx cancer is something I hold near and dear to me. It was my primary interest in becoming a laryngeal surgeon. It's a really interesting disease process. It's one where survival is very well preserved, and there's relative clinical equipoise depending upon, independent of the treatment modality, which is either surgery or radiation, and it really gives us an opportunity to think in a more sophisticated fashion about functional implications, which can be tremendous for our patients, both pre and post resection. Over the course of the weekend, I have a few talks that I'm going to give, and I think collectively you guys might get some insight about how I think about early larynx cancer, some of the things me and my team are doing to help advance that surgical discipline, so to speak. So I hope you guys enjoy. Feel free to raise your hands and ask questions at any point during the presentation. I have some disclosures not really pertinent to today's talk. Just a brief roadmap. I will show a number of videos at the end using the ablative approach with the KTP laser. But before we do that, just to set the stage for the rest of the discussion, I'll talk to you about some of the elements of sort of the extant landscape in terms of early laryngeal cancer treatment. And we'll talk about some of the challenges of transoral laser microsurgery and why I think the KTP laser sort of helps in that respect. These are American statistics, so I apologize, but hopefully there's a relationship between what we see in the United States and what you guys see here in India. From an American perspective, we're seeing a gradual decrease in the incidence of laryngeal cancer. The majority of laryngeal cancers originate in the glottis, of which the vast majority are early, which is stage 1 and stage 2 disease. That, of course, is a colloquial designation, where the technical implications of that are for stage 1 and stage 2 glottic cancer especially. Its single modality treatment is all that needs to be considered for a curative intent. This is unpublished data, but data that we presented at the American Academy Conference a few years ago. We looked at the Massachusetts General Hospital Voice Center early glottic cancer experience over the course of about 20 years, from 2002 to 2020. What we found is that 27% of those patients were non-smokers, which is antithetical to the sort of historical conception about laryngeal carcinogenesis and risk factors thereof. We also found that that population of non-smokers was younger, which caused comparisons to the HPV-related oropharynx cancer population. Not exactly, but This is a paper we published a few years ago looking at what's called the National Cancer Database, which is a cross-sectional representation of new cancer diagnoses in America, representing about 70% of new cancer diagnoses. And what we found was that HPV-16 positivity, or P16 positivity, in laryngeal cancer patients was associated with a survival benefit that was tantamount to approximately 1 stage. We don't yet see the canonical molecular changes associated with HPV and larynx cancer that we do in the oropharynx, but it's an interesting correlation, that bit of a demographic shift in this patient population. If you look at the National Comprehensive Cancer Network guidelines, which you guys may be familiar with, that's sort of the body that provides guidelines as to how we should think about treating cancers in general. If you look at the guidelines for glottic and supraglottic cancers, as we all know, and what you'll see is that a single modality treatment is all that's necessary for stage 1 and stage 2 disease, as I previously mentioned. Given the fact that either of those are considered equivalent options, the expectation, right, would be that you would see relative equivalency in terms of how often each treatment modality is rendered. If you look at the body of literature, they're basically equivalent clinical and functional outcomes comparing radiation versus surgery, especially in the management of early glottic cancer. But if you look at treatment trends, it tells a completely different picture, right? So again, these are American statistics, and what I'm gathering is that this particular statistic may not apply to India. But if you look at all early larynx cancer all early larynx cancer patients between 2004 and 2019, and you narrow that down to glottic cancer, in America, around 80% of patients will get radiation as opposed to a transoral laser microsurgical resection. And if you exclude academic centers, it goes up to about 85%. If you look at supraglottic cancer, this is another paper I published looking at treatment trends in supraglottic cancer and the survival implications of TLM plus a neck dissection versus radiotherapy for stage 2 cancer specifically. If you look at T1 and T2 supraglottic cancers, 87% of those patients were treated with definitive RT, despite the fact that the statistics demonstrated in this paper suggest that there's a survival advantage associated with TLM and a neck dissection as opposed to radiotherapy. So it really begs the question, right? Why is radiation conveyed more commonly than surgery for early stage laryngeal cancer? And I promise this has a point, not just rambling about larynx cancer. You know, some of this is idiosyncratic. I think in America, radiation is just a lot more accessible than surgery. But I think the crux of all of this is that transoral laser microsurgery for early mid-fold lesions, chip shot. But if you look at the full spectrum of stage 1 and stage 2 disease, transoral laser microsurgery can be extraordinarily challenging. And there are a number of reasons for that we'll get into over the course of the talk and the rest of my talks over the course of the weekend. But I just wanted to frame the discussion with this really nice paper that was published a few years ago in Oral Oncology by Dr. Ferris. It was a meta-analysis looking at risk factors for radiation failure in early glottic cancer specifically. And what they found was that the two statistically significant features of a cancer that predicted radiation failure are anterior commissure involvement and tumor volume. And I think if you queried laryngeal surgeons or head and neck surgeons that did TLM surgery, they would tell you that anterior commissure involvement and large tumor volume are two characteristics that would cause them to think about radiation more seriously. And the point of me including this is not to disparage radiation. The point of me including this is that I think we have to take a much more sophisticated approach in the way that we think about laryngeal cancer and early laryngeal cancer specifically, and treat it as more of a personalized decision as opposed to the way that I think we tend to treat cancers in general, but particularly early vocal fold cancers, at least in America, and go beyond population level statistics and really understand what drives this disease process and what drives a higher probability of good functional outcomes with treatment. This is not a contest between surgery and radiation. Our radiation oncology colleagues are extraordinarily valuable, but we as laryngeal surgeons have unique insight both into laryngeal function, but also about laryngeal anatomy. And we have, I think, a unique ability to anticipate what the functional implications of treatment for laryngeal cancer might be. All right, so we can jump into the rest of the talk now. I think this is the meat of it. And I don't want to step on Dr. Gandhi's talk. I know he has a ton of wonderful information about the CO2 laser particularly, but just in consideration of sort of the historical basis for what we do now. Transoral laser microsurgery is something that evolved over time and has evolved over time, and a lot of the evolution has been driven by technical advancements, both in our ability to expose the larynx better and in, of course, laser technologies. But if you go back to the origin of transoral laser microsurgery, of course, it was the carbon dioxide laser that was paired with a micromanipulator and a microscope that really changed the way that we started to treat early laryngeal cancers. It was the origin of the contemporary cordotomy, which is the way a lot of people think about characterization of transoral laser microsurgery. The CO2 laser, of course, 10.6 micrometer wavelength. It's a non-selective laser, which means that the chromophore, as all lasers have chromophores, the chromophore for the CO2 laser is intracellular water, which is why it's not selective. It's prevalent throughout tissue. As I said, it originated via a line of sight mechanism. And there's some variability based on fluids, so tissue to fiber distance. But the depth of penetration is around 150 micrometers. And if you think about the microanatomy of the glottis, so to speak, the cumulative depth of epithelium plus superficial lamina propria is more than 150 micrometers. So using the CO2 laser, by virtue of the laser properties, really gives you the ability to preserve superficial lamina propria. And then we saw evolution of optical fibers, and that changed the way that the CO2 laser could be deployed. And if you think about the laryngeal anatomy, it's very complex and three-dimensional. The ability to now engage a laser fiber as opposed to simply a micromanipulator now gives a surgeon the opportunity to change fluence, and navigate the complex three-dimensional anatomy of the endolarynx as opposed to making presumptive cuts. All right, so narrow margin surgery, right? So that is the entire basis of transoral laser microsurgery, particularly for early vocal fold cancer. What does that mean? Basically what it means is that you're aiming for margins that are anything less than the standard 5 to 10 millimeters that's prescribed for the rest of the head and neck mucosal tract. And there are reasons that that's acceptable, right, for the glottis, which I think we all understand. The functional implications, even in small volume soft tissue deficits, can be very significant, right? As I mentioned before, superficial lamina propria is between 50 to 166 micrometers in total depth. So we're dealing with a very small portion of real estate, which means we have a responsibility as laryngeal oncologic surgeons to preserve as much tissue as possible. And that's what drives this approach, right? The narrow margin approach, so that we preserve as much normal mucosa and normal soft tissue as possible, so that laryngeal competency at the end of the surgery is better preserved. Recurrences are easily detectable, right? Because even with small volume disease, you can have voice change, and with regular endoscopy, we can find recurrences early and treat them. So the narrow margin approach, if it fails, the implications of that from a survival perspective are not significant, and that's borne out in the literature, right? If you look at studies exploring survival or predictors of survival with early glottic cancer, positive margins post-surgically aren't correlated with survival, right? And all of that justifies our sort of more conservative approach when it comes to endoscopic laryngeal cancer care. All right, so now to the ablative approach. What you'll notice is I have a picture that was published in a Steiner paper, which is not the ablative approach, but I did that very intentionally. If you think about what Wolfgang Steiner did for the development of this field, right? He sort of broke off from the canonical oncologic theory about doing an en bloc resection, right? And instead dividing the tumor so that you could better understand the relationship between the tumor and the normal glottic interface, okay? The purpose of that was so you could avoid making presumptive cuts and excavating more of the vocal fold than is necessary, understanding the fact that tumor geography can be quite heterogeneous. So if you're able to appreciate the depth of the tumor at its center, as opposed to making assumptions based on peripheral morphology, right, then you can theoretically better preserve normal glottic tissue. That is basically what the ablative approach is, right? The ablative approach is using a laser, instead of cutting through the tumor, the ablative approach allows us to vaporize, or more aptly carbonize the tissue, or carbonize the tumor until we start to see evidence of the normal glottis underneath. So the ablative approach allows for what's called ultra-narrow margin surgery, where we make basically no assumptions about where the tumor is, and on a per micrometer basis, right, we're able to see normal tissue underneath the tumor. So the whole point of the ablative approach, theoretically, is to further maximize preservation of the normal underlying soft tissue. There's this concept of selective photothermolysis, or photoangiolysis, that's all contingent on the work of Judah Folkman. He published in the New England Journal of Medicine in 1971 about this concept of tumor angiogenesis, which I think we all kind of understand, at least implicitly now, right? Tumors, once they reach a critical threshold, can no longer rely on inosculation to survive, and they get new blood vessel formation, right, to allow the tumors to grow and thrive. Judah Folkman's perspective was based on this idea that you could target tumor angiogenic factors to target tumor tissue more specifically, right? We use this concept as surgeons to target tumor tissues more selectively from a surgical perspective, right? That's the entire concept of photoangiolysis, is deploying a laser of which the chromophore is hemoglobin, right? And with a higher concentration of hemoglobin in blood vessels and tumors, what we're able to do is concentrate heat from the laser mainly to the confines of the tumor, preserving the normal adjacent vocal fold as much as possible. So that's photoangiolysis. So the laser matters to some extent. This is a slide I created years ago when I first came out of fellowship. I think the laser probably matters less now than I used to think that it did back then. I still think it matters, but it's at least important to understand the differences when we're talking about an ablative approach versus the standard CO2 laser cordectomy. So a selective or ablative laser, as I mentioned before, targets something specific like hemoglobin. So between the blue light, the PDL, and the KTP laser, the chromophore was oxyhemoglobin, and that corresponds to the wavelength of the laser that's being used. The wavelength of the KTP laser, which I think everybody here is probably familiar with, is 532 nanometers. The blue light is 445 nanometers, so that falls within the wavelength of oxyhemoglobin. All right. Cutting lasers like CO2 and thulium target water. Talked about photothermolysis. If we think about what we're accomplishing with the laser, it's of course to remove the tumor. I mentioned before, of course, that our entire goal with narrow margin or ultra narrow margin surgery is to preserve as much of the normal underlying glottic soft tissue as possible. And one way that we can maximize the probability of that is leveraging these very specific biophysical properties of the laser. So pulse width and thermal relaxation time are characteristics of lasers. The pulse width is a description of the time period over which a laser pulse is delivered. And the thermal relaxation time is the time it takes for the soft tissue in response to that laser to decrease in temperature by 50%. What you want is the pulse width and the thermal relaxation time to be as approximate as possible so that the tissue that you're lasering has the opportunity to cool down so that you minimize the probability of stacked collateral heat injury. All right? So that's what you get with the potassium titanal phosphate laser, the KTP laser. This is a really cool study that was published by my mentor, Dr. Zeitels, a number of years back, comparing the 3 different standard ablative lasers that are used in common practice or historically in ENT. The PDL, the pulse dye laser, the KTP, and now the blue diode laser, which is gaining more popularity nowadays. So this is a chorial allantoic chick membrane. So what we're able to see are the first, second, and third order vessels in the yolk. And, oops, I'm having technical issues. So this works. Okay, this one works. So what you see here is the blue light laser being fired. And what you see is preferential distribution of the energy within these very, very small third order vessels, right? So the reason that's favorable, right, is because if you look at the very delicate soft tissue adjacent to it, there's not any real evidence of thermal injury, right? So what we're able to do again is confine the energy to the inside of the vessels, giving us the theoretical advantage of preserving as much normal tissue as possible. Okay. So this ultra narrow margin technique using the KTP laser is the thing that I do, right? And it'll be the topic of conversation for the next few slides with the videos that I show you. This was the initial publication by Dr. Zeitels, who innovated this technique, trained me on this technique using the KTP laser for early glottic cancers. Basically, the point of me including the slide is to show that the ultra-narrow margin technique for early vocal fold cancers is associated with equivalent disease control and laryngeal preservation rates as a more standard CO2 laser cordectomy approach. Okay. Before I jump into the talk, and I know that there are going to be a couple talks down the line talking about elements of laryngeal exposure, I do think it's important that I mention some of the tenets of my philosophy preoperatively when it comes to treatment of these patients. I think outside of everything that we talked about, the critical thing for us to consider when we're deciding whether or not someone is a candidate for an endoscopic resection is their head and neck anatomy, everything outside of the larynx. And this is a standard approach every time I see someone in clinic. The anatomic features that we want to more explicitly measure as opposed to more implicitly think about are a few things, right? Mouth opening, you need mouth opening in order to be able to stick the scope in and leverage the scope into the endolarynx. One of the more critical anatomic features is the thyromental distance, so measuring from with the head slightly extended, going from the mentum down to the thyroid notch. Aiming for at least 4 finger breadths means that you have a longer distance between the tip of the oral cavity and the entrance of the larynx. And there's this misconception about, maybe you guys have heard about this concept called the anterior larynx. There's no such thing as an anterior larynx. What there is a shorter distance between start of the mouth and the top of the larynx, so that if there's a short thyromental distance, your laryngoscope is more likely to enter the posterior larynx. So it's not actually an anterior larynx, it's just a posterior exposure. But that is probably the most critical of all the head and neck anatomic metrics that I look at in the clinic before taking someone to the operating room. And then tori, mandibular tori, these benign growths in the mandible that will change the amount of space that you have to displace the tongue in order to advance the laryngoscope to the inside of the throat. And then the other thing that I measure a little bit more implicitly is submandibular volume. How big is the tongue? How compliant is the submandibular compartment? Again, how much room is there for us to push the tongue away so we can advance the laryngoscope into the larynx to expose the entire circumference of it, okay? And again, I've talked about some of this, again, implicitly, but you know, the questions that we have to ask ourselves before taking someone to the operating room and taking into account some of these other granular considerations about what laryngoscope to use and what laser to use is it appropriate to operate? And the overarching question is, can you reasonably expect to clear margins, right? Can you expose the larynx, one? And is the pattern of disease such that you can reasonably expect to clear it, right? Without causing an unnecessary poor functional outcome. And I don't want to get too much into this because this is more about the gestalt of surgical decision making, but yeah. And don't be scared by the size of a tumor. This is a perfect case here. Someone that got an endoscopic vertical partial laryngectomy with me. Large tumor with transglottic extent going down to the subglottis. The important thing to consider is that that vocal fold is mobile, which stipulates that you can preserve at least part of, if not all of the muscle. That's the most important consideration, right? So just because a tumor is exophytic and looks scary doesn't automatically disqualify it from surgical consideration. And just to drive that point home, this is a paper I published, again, a few years ago, looking at the implications of surgical failure with the primary TLM approach. So we looked at 550 patients with an early vocal fold cancer. About 17% of those patients failed a transoral laser microsurgery. And those patients ultimately needed either radiation, chemoradiotherapy, or a more significant open, partial, or total laryngectomy. And just looking at that subset of patients, there was no difference in 5-year or 10-year overall or cancer-specific survival, which stipulates that even if you fail with TLM, there's, at least on a population level, no harm that's being conveyed from a survival perspective. So again, we have this sort of freedom as laryngeal surgeons to think about transoral laser microsurgery a little bit more carefully. All right, so now for the fun stuff. This is our first case. So 65-year-old gentleman, extensive smoke tobacco history use, clinically staged as a stage 2, left glottic with marginal incursion into the subglottis, which you'll see. And he sought me out for endoscopic resection after being recommended radiotherapy in the community. I use what's called the universal modular glottoscope system for my laryngeal exposure, and that's paired with what's called the suspension gallows. If you look at the pictures on the left, that's a Dito laryngoscope on the top, and at the bottom is the universal modular glottoscope. There's a significant difference in the size of and the shape of the distal aperture. The distal aperture is triangular to match the conformation, the triangular conformation of the glottis. Okay. It's also bigger at the distal aperture, which really gives you the ability to force what's called internal distension and push away the vestibular folds in order to maximize exposure of the superior and lateral surface of the vocal folds. Also, because of its pointed anterior conformation, what it gives you is a great view of the superior surface of the anterior commissure, distending away the inferior petiole so you can get this broad exposure of the glottis. That paired with that device that you see there on the right, which is suspension gallows, to pull up the scope against the mandible, as opposed to the standard approach, which just cantilevers against the maxilla, right? Really takes advantage of the fact that the mandible is suspended to the head by soft tissue. So to maximize exposure of the inside of the voice box, if you pull up against the mandible, you really force that anterior excursion to get a view of the a better view of the front of the larynx. All right, let's get started. This is how my screens show up in the operating. I think the top left is. This is how this is what I see in the operating room. I have a trifecta screen. I'm not going to get too much into the imaging portion of this because I have a whole talk about advanced imaging for laryngeal cancer. I always get a multimodal view of the tumor. So I started off with a 70-degree endoscope and I switched to this flexible bronchoscope. I'm employing mucosal surface imaging again, which I'll talk to you about a little bit later this weekend. So now we see that massive left glottic tumor, okay? Bit of blood there, took some biopsies initially. Important with the KTP laser to start with a bloodless field. As I mentioned before, the KTP laser is attracted to oxyhemoglobin, all right? So if there's blood in the field, the blood will pick up the energy and it'll be a much more inefficient resection. This is how they all start with an ablative resection. I'm using a 400 or a 600 micrometer KTP laser fiber. Bigger tumors, I'll use a 600 KTP laser fiber. I'll start off with pulse mode typically, unless there's a large portion that I can go in quasi-continuous and simply chop off. In this case, I'm going in pulse mode. This is going in hyperdrive, hyperspeed here. But it's a very gradual process of ablating through tumor, carbonizing tumor, right? Until you start to see evidence of more normal underlying glottic mucosa. So this is a very different approach to a CO2 laser-based approach where you look for a plane to start the dissection. In this case, what we're doing is ablating through all visible tumor until we unearth evidence of normal soft tissue somewhere in the submucosal compartment, right, at the base of the tumor. Here I'm using saline injection to medially rotate the tumor to better expose the lateral extent of the tumor and the lateral margin of the resection, and also to delineate the presence of superficial laminar propria that's adjacent to the tumor closer to the ventricular mucosa. Okay. And then I continue with the resection. It's important to treat this dynamically, constantly looking, seeing, rotating the vocal fold. In this case, there's a large submucosal infraglottic component. Unfortunately, my camera doesn't have a filter, so what you're seeing there is me going on continuous wave to take care of the inframedial component of the tumor until we see a much more normal border. If you can tell, most of the underlying vocal fold soft tissue is basically effectively preserved, right? With most of the tumor gone. We've unearthed normal submucosal tissue, right? We're starting to get near muscle. And this is me taking the deep margin along the anterior posterior length of the vocal fold. when you have a large tumor that involves the lateral glottis, it's important to expose the ventricular mucosa. Sometimes that's difficult to do depending upon the anatomy of the patient, especially with this scope is angled differently, so the anterior portion is angled deeper. So if you really want to advance the scope and see the most lateral border of the glottis, sometimes what I'll do is I'll ablate the medial edge of the vestibular fold so I have a line of sight view to the ventricular mucosa, right? And allows me to treat the entire lateral surface of the vocal fold. And that's the case at the end. That's me with a 70-degree scope. What I'm pointing out there is the infrapedial dissection. I think that's a underappreciated portion of the anatomy. If you have a tumor that goes from one side to the other, you don't want to miss a tumor that's nestled underneath the inferior pedial connection, right, on the superior surface of the anterior commissure. So I'm always very careful about exposing that area and making sure that there's no tumor there. Next case is a transglottic tumor. Had incremental hypomobility, but still mobility enough that I felt a confidence that I'd be able to preserve enough of the underlying muscle to make the case worth it for him. Again, quite a large tumor effacing the entire left hemilarynx, with more sessile disease effacing the entire right glottis. It's amazing how different the endoscopic view will look compared to what it looks like in the operating room. Again, a very similar approach here. Very gradually going through tumor. What you see there, I've exposed a normal underlying submucosa, and that creates a nice plane for the inframedial dissection there. Sometimes this can be like watching paint dry for the residents, although most of the time it's my residents doing the surgery. Again, so inframedial resection you can do with continuous wave once you've really defined the plane of normal vocal fold adjacent to it. That's me treating the right side. Again, with the KTP laser, what you're able to accomplish is a superficial resection in a way that's hard to do sometimes with presumptive cuts made with the standard CO2 laser. I take my patients back in all cases of stage 2 disease in 12 weeks after the initial surgery for biopsies. I purposefully included this picture as opposed to the one where it's nice and clean, just to indicate that the initial postoperative visit can still look like there's cancer. Keratosis doesn't mean cancer. You have a much better understanding of the footprint of disease in the operating room. All this came back as granulation when I took them back for the second look. This, I think, is a situation where the KTP laser really has an incremental advantage. All right, so we're looking at sessile disease. This is a patient that was sent to me after 3 failed resections. This is a much scarier kind of cancer to me than the standard exophytic tumor. When I look at this, I see keratosis here, and I see evidence of cancer here at the front left. It's a little bit subtle, especially with this view, but you see the erythroplakia with that very characteristic vascular stippling that's associated with non-benign disease. The other part of this that's a little bit scarier is sessile disease that's going into the subglottis. Okay, this can be quite a challenge to treat. With the KTP laser, especially for sessile disease, you really have the ability to titrate the dissection and the resection to preserve as much of that normal vibratory mucosa as possible. I'm going to skip through this again. I'll talk about confocal laser microscopy later. So again, 400 micrometer KTP laser fiber. What I've done there is decouple the epithelium from the underlying basement membrane in regions of superficial disease. And what you can do in those situations for intraepithelial disease is really nicely, cleanly peel off that ablated mucosa. Again, a very incremental process. This patient had a normal voice, as you might be able to expect, and I considered it a responsibility to keep him with that in the course of doing this resection. Again, the more bulky disease is in the subglottis, and you could go so far as to say that this is primary subglottic disease with glottic extent. Very difficult to tell. Again, like watching paint dry. I'm sorry. This is a subepithelial saline infusion, which a lot of people do. Again, just to delineate how much of the superficial lamina propria we're able to preserve. Obviously, in this case, given how well that infused, portends a very good voice outcome post-operatively. This is me resecting that front left vocal fold, and same thing. Beautiful preservation of the superficial lamina propria with a near-perfect voice at the end. So just a few take-home points. Always be considerate of the head and neck anatomy. Look at the uninvolved larynx. That's just as important as looking at the involved larynx. It's relatively easy to reconstruct soft tissue deficits. If you have a normal vibratory hemilarynx, that again portends a much better outcome. You have to be extraordinarily thoughtful of the full landscape of the endolaryngeal anatomy. Pay attention to the posterior commissure, pay attention to the infrapedial mucosa, the ventricular mucosa. These are all regions where you can leave disease behind, especially in more diffuse disease. The laser matters, to be sure, but I think it matters a little bit less than all of the above things. But I would say that from the perspective of when you might consider an ablative laser, especially if you're used to using a CO2 laser, it's in cases where there's more sessile disease. I think it really gives you the ability to preserve as much of that normal mucosa as possible. Thank you.
Sorry, yeah. Then after 6 to 12 weeks, take a margin and prove patient is now disease free.
So that's exactly my approach. So it's usually really only for stage 2 disease, where I just have this intrinsic suspicion about the possibility of residual microscopic disease. But absolutely, I wait 12 weeks just to make sure that the mucosa is fully healed. Then I take all my stage 2 disease back for biopsies.
Absolutely, this is another case of subglottic extension. Has he gone for radiation, or you were able to live that?
So that was the problem with him. Is his glottis was treated, the subglottic disease was never identified, and that I think is a challenge, especially in situations where one, exposure is suboptimal. Because if you don't have exposure of the anterior commissure there, you can see the focus of subglottic disease was anterior subglottis. So that was never identified. He was taken to the operating room for laser resection 3 separate times. But yeah.
I want to know how do you decide KTP or CO2 laser?
It's easy for me. I only use KTP. I think that there's this false dichotomy in our field about using the KTP laser versus the CO2 laser. Some of that is propagated by the people that train us. I think you can use the KTP laser similar to a CO2 laser, and I think you can use a CO2 laser similar to a KTP laser. I think that in situations where you're meant to make a decision, if you're someone that uses both, I think that if you're in a situation where using a CO2 laser is difficult because it's sessile disease, I think that's where a KTP laser really has a prominent advantage. Because you can get great functional outcomes, as Dr. Gandhi routinely does, using the CO2 laser. But I think for more sessile disease, using the KTP to ablate, especially in situations where you can see the hypervascularity, I mean, the outcome there, with proven preservation of the superficial lamina propria, I think it's night and day.
And practically speaking, when you on endoscopy, you see margins around the growth, anterior, lateral, posterior, inferior, I mean the undersurface of the vocal cord. Maybe CO2 would be the choice of treatment, because you can get through at least 1 millimeter of margin all around the tumor. If growth like this, in which it's a site, Sessile in the sense involving the superior and the entire surface of the vocal cord. It's very difficult to find the margin and cut. So you have to ablate or vaporize them. Then I think KTP would be the of choice. Yeah, superficial disease KTP is the best choice.
So with the KTP, if you go to quasi-continuous wave mode, you can cut. And so I use KTP, as I'm sure many people here, for everything. I don't use CO2 for anything. Cancer, stenosis, it's all the same. So if I'm anticipating making cuts with the KTP laser, I'll use the smaller 400 micrometer KTP laser fiber. And I'll go up to 5 or 6 watts continuous wave mode. You do get a little bit more char with that than with the CO2 laser, but it's just as an effective cutting mechanism as a CO2 laser is. So, and that's what I think that as long as you understand the anatomy, it doesn't matter what laser you use.
A very interesting perspective. I just want to ask, what is your long-term disease control rate in this type of cases?
I haven't looked at my personal data. I will tell you that I have a very unique practice that Harry can attest to, where I probably take on more endoscopic, weird, advanced cases than the average laryngeal surgeon. That being said, I think more of my cases are T2s than T1s, but my recurrence rate is just gestalt, probably 10%.
And how do you decide when you have to stop? And if you would have had a narrowband imaging, would your plan shifted more towards CO2 laser in this type of cases, where you can actually have a fair amount of idea?
So I don't use narrowband imaging, and I have an entire talk about this, so you'll hear more about my approach tomorrow. I use a different imaging modality, but for me, it's not really a CO2 laser is never a consideration. For me, if I see if I treat disease, I get a positive margin, and I take them back, and my expectation is that I can re-resect without causing too much of a functional detriment, and I get positive margins again. That to me that's a decisive surgical failure. Those patients are getting radiation every time. Because if in my hands I'm getting positive margins 2 times in a row, that means that surgery is not possible. There's diffusion of microscopic disease that I can't reasonably see even with adjunctive methods. That radiation as a more non-selective approach is the only method. And that's how I decide really. Or if I have to chunk out a large portion of muscle and it becomes apparent to me mid-resection, then I'll stop.
Do you use CT scan or some imaging before doing it?
I routinely do CTs, neck and chest, not because I'm worried about metastatic disease, but to look for a second primary. The neck is functionally useless, but I do it anyways. I've never gotten useful information from a CT scan for early larynx cancer. In fact, most of the time they don't see it. Yeah, I mean, I think you can tell everything that you need to know about disease on the basis of a stroboscopy. If you're interested in assessing depth of tumor, you use the mobility of the vocal fold as your explicit mechanism. If it's fixed, in my hands, in my mind, that's a reason to forego an endoscopic approach altogether. If there's reduced mobility, then you know that there's likely some underlying muscle involvement. And I don't know what additional information you'll get from a CT scan. Because if there's some preservation of mobility of the vocal fold, then by definition there isn't diffuse paraglottic involvement. So it's T2 disease, so what are you getting? And these cancers don't metastasize to regional lymph nodes. The CT scan of the chest is just to look for a second primary. But
So these data are only for vocal cord lesions, which we are discussing.
I'm sorry?
Supraglottic
Oh, supraglottics I get. Supraglottics I get imaging routinely. That's a different disease.
This is only glottic we are discussing.
Yeah, I mean, I treat supraglottic cancers with KTP laser too, but in the interest of time and confining it, like philosophically, I think it's a lot easier to just talk about glottic disease. But yeah, so if it's supraglottic disease, PET scans. And if it's stage 2, then if we're going for surgery or getting a neck dissection, Dr. Jayarajan and I don't know if you're talking about this. I think you do mention it in one of your talks. But we started doing sentinel lymph node biopsies for stage 2 supraglottic cancers. Same day approach, exposing the larynx, injecting the lymphocyte. And instead of sending them for a nuke med scan, Dr. Jayarajan would come in and just scan the neck with a probe. And is an alternative to a full-on selective bilateral neck dissection that we started exploring. But yeah, supraglottic stage 2s, TLM with neck dissection. Thanks, guys.
sir. I now invite Dr. Harishankar Jayarajan, sir, to enlighten us on transoral robotic surgery for oropharyngeal pathology.
Thanks, guys. It's always hard to follow her up. We're going to get pretty videos from me today. So first of all, while we're getting this loaded, thank you very much, Dr. Gandhi. I was very lucky with Dr. Gandhi to spend some time with him at Q&A and see his amazing practice, and we're very grateful to be here for this meeting. I'm thrilled to be here. And once it loads, my talk today, I want to try 15 minutes to just give you a brief overview of how I approach what am I going to do? Showing you? Oh, there you go. So yeah, today I want to, in the next few minutes, really just try and give an overview of my approach to oropharyngeal cancers, particularly as it pertains to transoral robotic surgery. My disclosures are that I'm an intuitive proctor, which basically means I'm very fortunate to be able to fly around the world and help people build robotic programs, particularly SP programs. And I'm also a head and neck surgeon at UAB Hospital in Birmingham, Alabama. So just to get to the meat and potatoes of the talk, what are we trying to really achieve with transoral robotic surgery? Most of you here would know the classic treatment paradigm for the management of oropharyngeal cancer really focuses on a non-surgical approach, primary radiation and chemoradiation therapy. And that's been around, that was the thinking for many, many, many years, even when I was a junior resident. It wasn't because of superior oncologic outcomes, it was because the significant functional detriment that follows a radical surgery like this is a significant detriment to the patient. It often is associated with non-healing of the mandibulotomy side, complex free-flap reconstruction, a long surgery on tracheostomy and prolonged oral diversion, and if the patient has any significant medical comorbidities, the next thing they're facing is a significant risk of inpatient mortality. And so, because of that, treatment for many, many years focused on a non-surgical approach, with the idea being to save surgery and salvage. But that also is not a great option, because if they weren't good candidates before, after surgery, they're even worse candidates, and the risk of wound problems afterwards is significantly increased. So, with the increasing appreciation of dichotomous outcomes when you compare HPV-driven and HPV-independent oropharyngeal cancers, surgeons around the world began to realize that we have to be able to offer patients something as an alternative to primary chemoradiation therapy, especially when we knew that HPV-driven tumors are relatively tumor agnostic. It doesn't matter how you treat them, whether you treat them with primary chemoradiation or surgery, the oncologic outcomes, predominantly treatment outcomes, are equivocal. So the goal now is shifted, particularly with HPV-driven tumors. We're not looking at trying to improve their survival, we're trying to make sure that the life that we give them is worth living. Predominantly looking at functional outcomes related to swallowing surgeries, related to post-operative swallowing. And so that led to the advent of transoral robotic surgery, as you see there. And that's really the goal, particularly as it pertains to oropharyngeal cancer. It's a little different for other subsites, but today we're just going to talk about oropharyngeal cancer. So, this is the system that I predominantly use at UAB. I have been trained in all the multi-port systems, but this is the system that I use now. This is the single port unit from Da Vinci. Compared to the multi-port system, I would argue that the single port is really the first surgical robot that's optimized for single orifice surgery, such as transoral robotic surgery. It has it's got many advantages, and again, I'll sort of expand on that in another talk for the sake of time. But the main advantage of the single port, in my mind, is the collinear deployment of a flexible camera with multiple flexible, multi-jointed arms that can triangulate to the focal point of the camera itself. It significantly reduces the intraoperative footprint, the perioperative footprint, expedites the efficiency of the case, and it certainly allows me to access sites beyond the oropharynx, and again, that's a topic of discussion for another day. But here you can see the robot in my operating room. I usually do the surgery by myself with a fellow, and I have a single bedside assistant there. This is really all I have from that table. You can see here that I'm only using 2 arms. So as I said before, the single port robot allows you to use 3 flexible arms. But for the oropharynx, I really don't see any significant advantage to that. Otherwise, I employ 2 suction systems. One is for a flexible suction catheter that's passed through the nose, and it predominantly acts as a smoke evacuator. And my bedside assistant usually has a suction monopolar just to assist me with any excess smoke evacuation and any hemostasis that I require, but it's usually pretty uncommon that I need to do that. Otherwise, the instrumentation is pretty straightforward. As we alluded to before, no matter how good your system is, if you don't have good retraction, you will not get good enough access and will not get enough visualization to do anything safely. And so the optimized access and retraction is really essential for minimally invasive surgery like transoral robotic surgery. There are a number of retractors on the market. This is the one that I have. This is the FKW retractor that was initially released by Olympus. I was very fortunate to get as many sets as I could because earlier this year, earlier in 2025, most of you that do robotic surgery would know that Olympus stopped making the FKW retracting system. So I luckily have about 4 sets now. You can see here, this is the retracting frame that opens the mouth, and these are the selection of blades that you have. To be honest, I pretty much just use these 2 blades. That's all I use. I don't use any of the other blades. These 2 are more than enough for me to get the exposure that I need for the vast majority of cases, even beyond the oropharynx. Like I said, however, now if someone's trying to start an SP program, you need to find another alternative retracting system. There are a couple on the market, but to me, this is the best one on the market. This is the last 2.0 retractor that is being marketed by Sutter. You can see that the frame is very similar to that of the FKW, and this is their patented blade selection, which is generally similar to the FK system. And in the last 3 months, the company actually bought the patent on the pharyngeal blades designed by Weinstein and O'Malley, and so that's now available as well. So pretty much it has the entire range of equipment that the FKW retractor had. So, how do I select patients for tours? I think that's really important. I think it's, doing the surgery is actually relatively straightforward, and it's embarrassingly simple. When you watch the videos, it looks embarrassingly easy. What is really poignant when you're doing tours, offering minimally invasive surgical alternative to standard chemoradiation therapy, is you have to be judicious about how you pick the cases and how you explain it to the patient, so the patient understands the expected prognostic outcome. So I'd like to divide my cases into 3 types, and I'll show you videos of each of those. In general, I consider this as early, advanced, and salvage patients. Those are the 3 categories that I divide my patients up into. Early cases are what we call slam dunk cases. These are the ones T1, T2 tumors, minimal to no neck disease. Even radiation oncologists would attest to the fact that in these patients, if you get a margin negative resection using minimally invasive techniques, whether that be transoral robotic resection or transoral laser, their outcomes are going to be great. Functional outcomes are going to be better than standard radiation, and you still leave radiation in your back pocket. Otherwise, the oncologic outcomes are equivocal. So this is a slam dunk for me. The next category is that of salvage cases. So salvage patients are those patients that have previously had head and neck radiation for whatever cause, and it means that these patients are unable to be irradiated in their current setting. So you only really have one alternative, and that is a radical open surgery. Being a head and neck reconstructive surgeon certainly helped me to develop this practice. When I first turned up to UAB, 75% of my practice was salvage. When I first turned up to UAB, robotic surgery had sort of declined, and no one was sending me their early oropharyngeal cases. So 75% of my practice was salvage, because as I'll highlight later, the evidence clearly shows that if you can get a margin negative resection in an appropriately selected salvage case, not only is the clear margin outcomes much better, but the patient obviously has a much shorter inpatient stay and has much better functional outcomes and significantly reduced perioperative morbidity and mortality. Being a reconstructive surgeon, it also allowed me the flexibility that if I was in the operating room and I realized intraoperatively that the case could not be safely performed robotically, I then converted to an open case and did the free body reconstruction myself. So I think that it's really, really important. Salvage surgery, salvage tours is a really underappreciated technique because it offers patients so much. Because a lot of these patients are not fit enough to have an open salvage resection with a free body. And finally, we talk about the advanced cases. The advanced cases are really where the debate is between, especially in treatment-naive patients, the argument between primary chemoradiation and or primary surgical treatment, and I'll sort of delve into that a little bit in a bit. So, to start off, this is my approach to early disease. This is a right-sided T1 or T2 tonsil primary with no clinical neck disease. Here you can see I'm using the single port robot, using the bipolar glomerulus in my left hand, the monopole scissors in my right. I'm cutting through the supratonsillar fossa, trying to minimize my extent into the soft palate. Once I cross the constrictor, enter the parapharyngeal space, and then continue my dissection inferiorly along the pterygomandibular artery to the GT sulcus. Once you're in the palate, it's really, really important to really make sure that you don't sty on your constrictor cut. When my fellows operate, and certainly in my earlier days when I operate, that is where I would lose my margin on the anterior lateral part of the tonsil by just not being cautious enough in identifying the constrictor and going after to it. As we dissect through the parapharyngeal space, you can see that it's relatively safe. There's no real major vasculature that you find here. You'll find some peripharyngeal veins, but these are easily addressed with the assisting bipolar cautery. It's not until you get to styloglossus that you then start to see major vasculature, posterior lateral cyclosis. So until then, I'm relatively comfortable, and I'll move pretty quickly through the case. As you continue dissection inferiorly, you'll start dividing the fibers of stylopharyngeus as it interdigitates with the pharyngeal constrictor. And this is often when you'll find the glossopharyngeal nerve, which will come into view just in a little while. We're still just dissecting through styloglossus there. And then as I divide that, you'll find the glossopharyngeal nerve as you divide the stylopharyngeal fibers. It's really, really important, like I said, in these early cases, to minimize the mucosal extent of your dissection. And so, like you saw before, I tried as much as possible to minimize my lateral incursion. And here you'll also see that I'm actually preserving most of the posterior pillar, particularly its insertion to the lateral pharyngeal wall at the level of the velopharyngeal inlet. You can take it, but I found anecdotally that if you leave it, the perioperative BPI is significantly reduced, and their long-term swallow outcomes are also significantly better. In general, these patients get what we talked about before, single modality therapy. I know that there's been a number of studies that looked at transoral surgery for early oropharyngeal tumors, but a nice study out of UCSF found that in general, one of the big advantages in my mind that I quote my patients when I'm treating early disease is that it is the only way to truly understand the aggressiveness of the disease. While imaging modality and clinical assessment are great, we all know that it's not perfect. Only through surgical resection can you examine the disease histologically and truly understand the disease burden. This retrospective study out of UCSF showed what we all kind of know, in that once you do these cases and remove the tumor and you do the neck dissection, all these patients in my hand get a neck dissection, that there's a significant alteration in the pathological input. What this translated to in their hands was a 27% change in treatment outcomes. So basically, people that went in thinking they were getting single modality treatment were upstaged, largely based on the nodal disease. 47% were upstaged because of the nodal disease, unexpected ENE, and about 17% were upstaged because of aggressive features found on the primary. Now, you could argue, does that really change the outcomes? Well, in my mind, that if I was if it was me, I would want to know exactly the extent of the disease. So these patients are advised preoperatively that there is a good chance they may need adjuvant radiation, albeit at a reduced dose, if this is found. So the next case we're going to show is that of a slightly bigger tumor. This guy was an advanced patient because he had multiple lymphocytes surgical lymph nodes. He had a slightly bigger primary on the inferior aspect of the right tonsil. Those of you who are relatively shrewd will see that I switched from a single port system to the XI system. This is probably because it's one of my earlier cases and this is what I had available at the time. Otherwise, the dissection is very similar, except in this situation, you can see that I've extended my incision across the GT sulcus to extend into the ipsilateral hemitongue base. I'm still trying to preserve as much of the soft palate as possible, and you can see I'm making a concerted effort to preserve the posterior pillar, especially at the level of the velum, to avoid that postoperative EPI. Otherwise, the resection is the same, cutting squarely through the constrictor into the parapharyngeal space, making sure to not skyward the constrictor cut. The other thing I didn't mention before is the second of the styloglossus. I know a lot of my partners that don't resect styloglossus as part of their resection. The problem I have with that is that we know there's a significant percentage of the population that have adhesions, a natural adhesion between the superior middle constrictor. And if you have that, even if the tumor is not reaching through the constrictor, histologically that's going to come back as a positive margin, which is going to drive this patient towards chemoradiation in an adjuvant setting. So for that reason, I always take styloglossus with me. The only time I don't, obviously, is if I've done a mucosectomy and found an intratonsillar tumor, then I'll leave styloglossus. Otherwise, every other primary tonsil case, I take styloglossus and leave it clasped into the constrictor to make sure I don't have an exposed adhesive to the constrictor. The other thing you'll notice is when I'm doing this kind of dissection, particularly for tumors where I have to cross the GT sulcus, I try and leave the GT sulcus section till right at the end. As I noted previously, you don't see a lot of significant vasculature, medial, anteromedial to the styloglossus. Where you tend to get your vessels coming in is through that corner at the level of the GT sulcus. It's usually a branch, either a tonsil branch of the facial or a tonsil branch of the lingual. And the easiest way to address that safely is preemptively. So I'll often resect a lot of the tongue base of medial to lateral. I'll dissect from the oropharynx down from the soft palate down to mobilize as much of that tumor, so I'm able to attract the tumor and identify the vessel preemptively, clearly delineating it before getting optimal control with the microclip. And you can see, it should be coming up relatively soon, I expose the vessel of my bedside assistant, puts 2 clips on it. All these patients, especially these patients getting a neck dissection, if I do find this, if I do a case where I have to ligate an artery in the mouth, I will always perform a transcervical arterial ligation as part of my neck dissection. We know that it doesn't change the incidence of postoperative bleeds, but it does significantly alter the incidence or the risk of catastrophic bleeds. And I can tell you right now, in my 6 years of practice, I've only ever had 1 patient turn up with a catastrophic bleed doing this. And interestingly, it was because I clipped the lingual off, tied the lingual in the neck, but the distal lingual has reconstituted by the distal IMAX. So on the angiogram, you can see the clips, and then you can see tuberty flow reconstituting the distal lingual with that IMAX. It did lead to a discussion as to whether or not we should start ligating the external carotid. 1 case out of 6 years to me wasn't enough to do that, so I told the tumor boy, I told the tumor boy I wasn't going to change my practice for that 1 case, but it is an important consideration. So I still tell my patients, any bleeding at all, don't mess around, always come back, and the residents know to treat it with care. Otherwise, when we look at advanced stage disease, there are hard stops with how you do it. For me, my hard stop for a transoral approach to a locally advanced tumor essentially comes down to any involvement of the bone, especially if the periosteal is removed. If there's more than a 50% involvement of the tongue base, and if there's extensive soft palate involvement, those patients I feel are better off either treated with primary chemo radiation or an open surgical approach. I just don't think that they do well with TORS because you can't reconstruct that wound. And finally, salvage tumors. So this is a right-sided inferiorly based tonsil tumor / GT sulcus tumor. This was essentially treatment failure. This patient never really responded to post-treatment. We had it 3 months, showed increased uptake, and then eventually came in 6 months, where a biopsy confirmed the presence of a tumor. With salvage surgery, you can see the planes are generally not as clean. You can still find your anatomy, but it's not as easy to move. The tissues are much more fibrotic. And so I feel like it's really, really important to make sure you have a wide field to be able to see what you're doing. I still try and minimize the amount of palatal dissection. You can see here, I try to. Oftentimes, because of the fibrosis, that wound always gets a little bit bigger. But otherwise, it's the same kind of dissection. You sort of have a wide field of dissection. Try and leave the GT sulcus area till last, because you know that's where the vessels are going to be coming in if there is a vessel involved. And otherwise, try and identify the deep anatomy, particularly styloglossus, because that's what's going to tell you where your proximity to the carotid. The only time that I had become close to a carotid injury was in a salvage case where I couldn't identify the last 5 of the styloglossus, and I thought I had some left, and I'd already gone through it and came onto the internal carotid artery. With regards to transoral robotic surgery being a viable alternative to open pharyngeal resection, you can see here there's been multiple studies, and even this, the latest one is an internationally multi-center study, which clearly showed a number of things. 1, TORS salvage is safe if done appropriately and if selected appropriately. It actually has better perioperative mortality and morbidity rates. The complication rates overall are better, but also it had a much higher, much better rate of positive margins, and the rate of was like 30% in open versus 25% in robotic surgery. So overall, the outcomes are much, much better. The real question is, what are the swallow outcomes like in these patients if you don't reconstruct them, particularly for the bigger resections, which involve more in the tongue base, and are as yet unpublished, but anecdotal data shows that at 6 months, when I compared my open pharyngeal resections that are recon and my salvage TORS, at 6 months, the pig dependency rate and the oral diversion rate was exactly the same between both cohorts. So it made no difference. It just takes a long time for that wound to contract, and that's what you have to get them through. So all of my salvage TORS real salvage tools, get a G2, because that wound will not contract for at least 4 months. And that is the end of my talk. I think it's time to start.
Thank you, sir. Now, moving forward to a video presentation on trachopharyngeal balloon dilation by Dr. David Lauser.
I have a few introductory slides followed by a short video. What are the indications for this procedure? It is usually performed for dysphagia with associated cricopharyngeal dysfunction, and cricopharyngeal dysfunction should be demonstrated by FEES, video fluoroscopic swallowing studies, or manometry. The most common indication in my practice is fibrosis after radiation for nasopharyngeal carcinoma. Let's look at some initial considerations. The first of these is, do we carry out the procedure under local or general anesthesia? And the second consideration is, do we include botulinum toxin injection to relax the cricopharyngeal sphincter? The procedure can be carried out under local anesthesia, although I prefer to administer light intravenous sedation, usually with an anesthetist present. If the cause of the cricopharyngeal dysfunction is neurological versus fibrosis, then cricopharyngeal botulinum toxin injection can be combined with the dilatation. If botulinum toxin is injected, the procedure is usually carried out under general anesthesia so that the botulinum toxin can be injected accurately into the posterior aspect of the cricopharyngeal sphincter. How do we counsel the patient preoperatively? Firstly, we need to inform them that swallowing improvement may be limited. This is because cricopharyngeal dysfunction is often part of severe global dysphagia. Cricopharyngeal dilatation is therefore just part of the overall swallowing rehabilitation strategy. Secondly, if botulinum toxin is administered, specific risks may include neck weakness and bilateral vocal fold paralysis. Bilateral vocal fold paralysis can be mitigated by injecting the cricopharyngeal sphincter posteriorly and avoiding the anterior part of the sphincter. This picture illustrates how bilateral vocal fold paralysis can be prevented during botulinum toxin injection of the cricopharyngeal sphincter. This is done by keeping the injections in the posterior aspect of the sphincter, illustrated by the 3 stars, in order to avoid Botox leaking into the laryngeal abductor muscles. We usually inject a total of 40 to 60 units of Botox. What equipment is needed for outpatient cricopharyngeal dilatation? Firstly, we need a transnasal endoscope with a therapeutic channel and the ability to suction. Secondly, we need a camera system for visualization. And thirdly, we need an airway balloon. I have used the Boston Scientific CRE 20 millimeter diameter balloon to carry out this procedure. This is a picture of 3 different flexible nasendoscopes. The therapeutic endoscope can be differentiated by the presence of an instrument channel indicated by the red arrow and a suction port indicated by the blue arrow. This is a picture of the Boston Scientific CRE balloon that I have used for cricopharyngeal dilatation. The diameter goes up to 20 millimeters and is 5.5 centimeters in length. The guide wire has a diameter of less than a millimeter and is able to fit through the instrument channel in the nasal endoscope. The balloon, however, requires a 2.8 millimeter endoscope working channel, and the balloon is too wide to fit through the channel. I will explain the implications of this when I show you the video. There are, of course, other balloons that can be used in addition to the one that I have shown you here. So let's move on now with the procedure. How do we prepare the patient? The patient is seated or semi-recumbent, and this can be on an inclinable trolley. We spray the patient's nose and throat with a decongestant and local anesthetic spray, for example, cofenalcane. I am now going to show you a video demonstrating endoscopic guided cricopharyngeal dilatation. This patient has undergone radiotherapy for nasopharyngeal cancer and has severe dysphagia. There is a lot of saliva pooling in the pharynx, and this needs to be suctioned away in order to get a clear field of view. After this, the guide wire is inserted through the instrument channel in the nasal endoscope into the esophagus. Once it is inserted, the nasendoscope is removed and the balloon catheter is then threaded or railroaded over the guide wire. This technique allows accurate placement and prevents injury to surrounding structures. The balloon is placed with the purple marker indicating its proximal end just above the cricopharynx, and the balloon is then inflated to 2 centimeters for 1 minute. This procedure is repeated 3 times, after which the balloon, wire, and endoscope are all removed and the procedure is completed. Thank you very much for your attention, and I hope you found this presentation interesting.
I now request Dr. Ravindra Bansal sir, please present memento to our speakers, Dr. Bharat sir, Dr. Harishankar sir.
Very lens
Request Dr. Vikas Gupta sir. I request Dr. Nitin Srivastava sir, please come on stage and present memento, Dr. Ravindra Bansal sir. the next session, I would like to invite chairpersons, Dr. Shalini Jaria ma'am, Head and Professor, Department of ENT, People's Medical College, Dr. Smita Soni ma'am, Professor and Head of the Department of GMC, Bhopal, Dr. Aparna Chavan ma'am, Professor and Head of the Department, ENT and Head and Neck Surgery, AIMS, Bhopal. I now request Dr. Shantanu Panja sir, please be on stage and enlighten us on torch reconstructive techniques.
Premises very well, with his wonderful videos of transfer robotics. We need to understand that why is this paradigm shift? You know, earlier if you go back to history, you would see that oropharyngeal cancers used to be operated. After that, there was a phase when it was, you know, the radiation oncologists took over and it was heavily irradiated and the surgeons lost their area of surgery. Now again, there is a renewed interest with the advent of transferal robotic surgery and evolution of transferal techniques, because it's simple. Earlier, the surgery used to have a lot of morbidity. Today's technological advancement has given us an edge where you can take out tumor without an external cut. You don't have to split open the mandible. So, you know, I still remember during my residency, I had a patient with a western malignancy who was operated. He had mandibulotomy, plating, and you know, tracheostomy, Ryan's tube. Patient stayed in hospital for innumerable period of time, aspiration, so on and so forth. So surgeons told, okay, enough. But now the story is entirely different. So we have talked about resection. I would like to shed a little bit of light on reconstruction. A very important point was touched upon by Bharat about the exposure, you know, access to the area where you are going to operate. And I think it is the single most important determining factor about the success of your surgery. In fact, tomorrow I'll be having a talk on the art of exposure in your operating room, how you do it, what are the tips, tricks and techniques. And I hope it is going to help the youngsters who you know, want to do surgeries. So, you know, transferal robotic surgery, we know it has emerged, you know, safely to resect larger complex oropharyngeal tumors. It also allows the reconstructive surgeons to reconstruct. It has a lot of distinct advantages and offers a less morbid surgical code, but definitely it has its own set of challenges. You see, if you look at the anatomy of oropharynx, it's a closed space. So both physical access and visualization of the oropharyngeal anatomy is severely restricted. Next, the contouring of the flap, whatever you create, and the inset is again very difficult. It is financially more expensive. It takes additional time. You have to train your staff. You have to yourself gain an experience. And the setup, the entire setup of robotic surgery that you do is very sensitive to small changes. And you have to adjust and readjust many times. And there is definitely a steep learning curve. So, for example, a very straightforward, simple case of tonsillar malignancy. Do we need to reconstruct this type of cases? No, we don't, because secondary healing is very good. And what I use is I put a fibrin glue on the bed at the end of the surgery. You can see these clips. Harry was talking about the styloglossus and the stylopharyngeus. You know, the place where I trained, Professor Kim used to put clips along the styloglossus and stylopharyngeus if it was you know, present, because sometimes there are small bleeders and small feeders which in the post-operative period might trouble you. So this is a check so that it doesn't happen. So this type of lesions, they heal very well. These are simple lesions. For example, this case, a polymorphous adenocarcinoma of oropharynx. This is a radio-resistant, chemoresistant tumor, predominantly arising from the minor salivary glands. And you know, it's fairly advanced because it's involving the tonsil, the base tongue, the tonsillolingual sulcus, entire area. This is a patient just 7 days after the surgery. You can see there is no tracheostomy, there is no Rein's tube at all. Fantastic outcome. I will not go through the entire surgery, but just to show you the extent. We start from you know, the top of the tonsil, we go along the tonsillolingual sulcus, dissect. You can see the hemalock, the clips, because you have to dissect out the vessels. I dissect out the vessels. There are two ways of tackling. Either you can use your forceps, and they can act as a bipolar. You know, both your legs and your hand has to work in unison. Or you can clip after dissecting out the vessel. I always use a hemalock, the whitish one, because it has a clip which clips at the end, so it doesn't open up. So that's a very useful one. So once we dissect out the entire tumor, you can see there is a wide bed, and such an extensive area of defect is there. But again, do we need a reconstruction in such a case? Number one, it is not a salvage case, it's a fresh case. And usually the pharyngeal mucosa, the base tongue mucosa, they are vascular and they heal pretty well. So in this situation also, we didn't opt for any kind of reconstruction. And I always use, as I told you, a fibrin glue, and they secondarily heal very well. It's important that to understand that I always do my surgeries which are frozen guided. So I always check my margins, and only when I'm satisfied that my margins are adequate, then only I close my procedure. So this is the same patient after 18 months. I just want you to see how nice the mucosa is. Moist, very well healed when we go into the throat. This is the nasopharynx when we are going inside. You can see there is no defect. The palatal movement is fantastic. The mucosal healing is superb. The pharyngeal healing is superb. It's moist, nice mucosa like you have in any normal human being. The laryngeal movement, there's no aspiration, nothing. So even in this type of defect, you know, you can get away. So what are the situations where you actually need? So if there is a velopharyngeal insufficiency, if there is a extensive defect where there is a carotid exposure, or if it is a salvage case where there is a carotid exposure, this type of situation. And the workhorse, like you say, the workhorse of a head and neck is PMMC, pectoralis major myocutaneous. So for oropharyngeal defect reconstruction, this is the flap which is the workhorse, the Bozola flap. It is a sensate flap, it is a versatile flap, and it can be used in different areas. So I will show you one of the most difficult things to counter, that is a velopharyngeal insufficiency. It is a soft palate tumor. So you can see, firstly I want to, do you have a pointer? Okay. Okay. This flap is actually, this flap is supplied by the internal maxillary artery branches and the fascial artery branches. It's on the cheek, and this is the tumor after resection. You can see it was eroding the palate, almost going into the uvula, and this is the margin which you have to take. And this is the margin of the flap. And most important, you have to mark the parotid duct opening. This is very important. Your margin should, the marking should be below the parotid duct opening. You cannot damage it when you are working. So we start dissecting. Harry is very lucky to have a single port. I don't have. We have a 4th generation. So we work with this. So you keep resecting. The trickiest part of this resection is towards the side of the nasopharynx, because that's a blind area. You cannot see that. Okay, so you have to be very careful that you don't enter the tumor while you are resecting. Okay, so I always use a Merosil small, because it acts like a sponge. I can squeeze it, I can sometimes dissect it, I can remove the char, I can soak the, suck out the blood from the field and make it dry. So small, your own intervention and innovation which you can try, which makes your life easy. So the idea is to work all around the tumor and then come to the center. So we keep on dissecting. I will go a little fast on the resection part, and slowly you dissect out the entire thing. And this is a very tricky area, the TL sulcus. You can see the margin all around the tumor. This is what is needed. And slowly, you should not rush. Go step by step. Whenever resection is very important, because you have to have a R0 resection if you want to give result to the patient. So, once you take out, this is the entire tumor which is taken out, and this is the defect, resultant defect that you have. Now we create the flap. So again, always remember that it's a very delicate handling of tissue, because whatever you are doing on the console gets a lot amplified in the human body. This is something which you realize as a surgeon after doing quite a few number of cases. Otherwise, what is our tendency? We try to grab it like a needle holder or like a forceps, and we put too much pressure, but that is not how it should be. So it's very important that you raise the flap without buttonholing properly. It is a myomucosal flap, so you have to take the entire muscle bed along with the mucosa, and you can see the fat creeping out from the deeper plane. I'll show you how we use the fat actually. So we keep on dissecting, go up to the pedicle. You should not damage the pedicle. Don't make it too thin also, because you know the principle of facial plastic surgery, what should be the length and the width axis. That principle should be maintained everywhere. Now we start suturing. So use the vicryl and suture it to the edge of the defect. So we keep suturing it. Okay, so you see almost like uvula has been created. So now we dissect out the fat, the buccal fat pad. Again, a very gentle teasing out of the buccal fat pad, and the trickiest step is to suture through the fat with the robot. Okay, always a chance of tearing through the flap, which you should not. The vascularity needs to be maintained. And the buccal defect that is there, I usually reconstruct with the buccal fat pad. So again, very delicate handling, because fat is something you can understand how difficult it is to. Always remember, when you run your needle, it should be along the axis, no shearing action of the needle. That's very important. Basics, fundamentals of surgery are always the same. Okay, so this is the buccal fat pad which you give and cover the entire defect. Okay. So now this is what we have done inside the OR. So we are as good as our results. So let us see. This is 4-week post-ops. The same patient, look at the structural outcome. We will go from the nasal side first. And you can see almost like when you do a UP3, something like that. But when you go from the oral side, you will see patient. The flap has plugged the defect. So there is no velocity, and you can see still the vital sutures. Buccal fat pad has very nicely taken up. Already the reddish mucosa has started forming. So the palatal movement is there. It has plugged the defect, and there is no velopharyngeal incompetence. How do we understand there is no velopharyngeal incompetence? Now, we should make the patient talk. So there is no nasal intonation, no tracheostomy, no right tube. You can see the cosmetic effect. Such a big defect, if you do by open surgery, you can understand. And no speech alteration, a superior quality of life. So this is what you can achieve. Finally, you can also do a free flap only for two indications: when carotid sheath is exposed, or surgical fistula created, or it's a salvage case. So take home message is, it has its own advantages and disadvantages over conventional surgery. It is difficult, there is a learning curve. No, not every case requires reconstruction. For larger lesions or when the carotid sheath is exposed, surgical fistula, velopharyngeal compromise is anticipated, and vascularized soft tissue reconstruction in this case is the better option. And free flap specifically recommended for post-irradiated cases when carotid exposure is expected. So with that, I would like to conclude. Thank you so much.
Thank you, sir, for an enriching video presentation. I now invite Dr. Brigadier Ramalingam, sir, for his presentation on modification of type 3 thyroplasty for puberphonia.
Good afternoon, ladies and gentlemen. At the outset, I must thank Professor Vikas Gupta and his team for inviting me to this talk. Actually, initially it was type 3 Thyroplasty for adductor spasmodic dystonia, but that was wrongly made. The correct one is actually our innovation for type 3 for puberphonia and pitch realignment. Now, if we go, see, this is type 3 Thyroplasty, originally described by Ishiki. This is restriction of the anterior commissure, so that the cord shortens and mass increases and pitch lowers. So with that, that was initially it was designed for puberphonia as well as pitch lowering. So what we have done is we used to do this earlier, like both the sides of midline of ala are cut and they are elevated. Then it is pushed posteriorly and sutured over it. This was the original technique. So this is the way what the patient presented. No sound here.
It's a big downer, and I think
Sorry, I want to play it again. This fellow is about 6 feet 4 inches chap who was studying in BCom. He came to us. He had taken adequate speech therapy. He was very demoralized. Very handsome guy. He was afraid to go to the stage for theatre or something. And girls used to tease him because of his voice. So he came to us in a very depressed situation. So we did the same. One is actually his one.
My name is Benepreet.
So
I got me applying and was operated on 26, so my vocal was operation. I feel much better now with a good manly voice. I'm very comfortable with it.
Participates in, used to participate in debate, and buy one get one free. He brings his sister for nose correction. I said this is also good, not bad. Now then what happened? We started inserting the salastic sheet in between before tying, so that when you are tying tightly, it cuts through the cartilage. To prevent that, we started putting salastic sheet. But now we have modified that into this particular way. Just have a look at it. Once we have elevated the strap muscles are elevated on either side. This is the midline. And about 4 to 5 millimeter away, we give a vertical cut so that the entire anterior capsular area is, this area is completely free. So here is about 5 millimeter on either side we have taken. It should be absolutely equal on either side. Otherwise your vocal cords will be, the levels will vary and you won't get a good result. So once we have done that, then we are marking it. As I told you during the cadaver demonstration, I use cautery to mark the line of incision. Once I have done, then you must take care not to injure the inner pericardium. So now it is free. Now this, once you push this anterior segment, then his voice improves. What we have done is, instead of that, I used titanium mini plates. These are very accurate and very nice, and it stays very sturdily. And over that, first we take the suture, it is the thioprolin, and this is tied over the titanium mini plate. Let's have a look. Like this, we have done. And again, both upper and lower titanium plates, it should be very, very equal. Otherwise, again, there will be a problem. And both should be tied simultaneously. Let's have a look at it. Now, I want to show this for you. You can tie it nicely till the time his voice becomes all right. And once that is done, we are testing the voice, and then the wound is closed in layers. Now, this is how the patient.
मेरा नाम साहिल शर्मा है मैं यहाँ स्पीच थेरेपी के लिए आया था मेरी आवाज़
He had done 6 months of speech therapy, but he was not happy.
I have pipophonia तो उसके रिगार्डिंग मैंने सर से बात करी थी एंड अब मेरा सर्जरी होने वाली है काफ़ी 1 हफ्ते के अंदर मेरी सर्जरी है.
This is the laryngeal cord, you can see, and this is the post of voice.
My name is Sahil Sharma. I had MBCA from Silver College. I had a problem of pneumonia. My doctor advised me to take Thyroplasty, and after the Thyroplasty, happy.
And this is the shortened cord. Now, this is very interesting. He is a 42-year-old Afghani patient came to us with this voice. So, we decided to do surgery on him and did Thyroplasty. Now, when he rang up his wife from India, his wife refused to talk to him. He said, "You are imposter. You are not my husband." Then he has to tell his brother to explain that he is the real one. This is he is actually he is sub-inspector of Meerut Police, but he was not happy with his voice. He wanted to get it changed. Because he wanted some weight in his voice to carry out his duties as sub-inspector of police. And you know UP police. And this is afterwards.
मेरा नाम दीपेश टिंडोतिया है मैं मध्य प्रदेश का निवासी हूँ
very happy.
फिलहाल मैं मेरठ में हूँ पुलिस में मेरी जॉब मेरा नाम
Now, there is a very interesting story about this episode.
मेरा नाम असीम भल्ला है.
Anything wrong with the voice? Nothing wrong.
मेरे को
He is
सारी
6 footer Sardar from Amritsar.
था और
Only Karsarga.
couple months
He wanted his voice a
पहले
little heavy.
मैंने
So
एक
in
speech
this
therapy
case,
ली
changing of pitch
जिस
starts
कारण मेरी
today.
वॉइस लो होगी लेकिन
We said no so many times, but he, for 1 week, he kept on coming to my OPD. Then finally we had to do.
मेरा नाम असीम भल्ला है मैं पंजाब से आया हूँ
So we were very happy. He said, now I got a commanding voice. सरदारों वाली voice आपने दिया. It was really great.
और उसके बाद
Now.
Hello sir, my name is Nitika Aswani. I am from Agra. I have a problem of
He's from Agra.
pneumonia. Currently I am seeking treatment of
What do you think we
Dr.
should do?
W.B.S. Ramalingam sir. And he has recommended me to
So in this case, we didn't jump the gun. We didn't do anything. I sent him to my speech therapist.
Hello, my name is Nitika Aswani. I've had a problem of pneumonia since last 5 years, which was
So
instantly
every
diagnosed by
pneumonia doesn't require therapy. You must send for
the
speech therapist.
situation
At
very
least for 3
clearly
months.
and
After
discussed
that,
the
only you
treatment
stop.
plan. He referred. Hello.
Any questions?
Sir, just I want to ask one thing.
Yeah.
Sir, just like in rhinoplasty, there is so many. You have to match the expectation versus reality. So you have similar kind of thing like we see in the Sardarji.
Yeah, I told him, your voice is very good. You can, no, he wanted, I said, sorry, Amitabh Bachchan's voice will not fit you. But I can lower your pitch to such an extent that you will be proud of your voice. He said, will you give guarantee? I said, no guarantee. You have to be very careful. You have to take a video consent. You asked Dr. Sachin, one fellow came from Australia, New Zealander. He came once, we said, no, nothing big. Again he came back. I went from Delhi to Pune to tackle him. We took video consent, we did one side. I removed a strip of cartilage, that is also described by Dr. Ishiki. We removed. But he came back, he said, my strain is gone. I said, I'm very happy. After 3 months again he comes back. He says, no, my girlfriend is not happy. She says that your voice has not changed. I said, yeah, you are 5 feet 4 inches, 6 inches. You don't expect Morgan Freeman voice. But he wanted to change. So we had to do the change, and during that time I tripped in the OT and fell down and fractured my patella. Standing on one leg I did the operation. So for his voice correction, now I am still having my knee pain. Thank you.
So sometimes they say don't suture it, just push it inside and release it.
How will it stay, ma'am?
That is the thing.
It is not
Like it
possible.
corrects something, and then there is
It is
something.
not possible.
But people keep on talking like this, that you just
No.
push it inside.
Either they are lying or they are hypocrites. I can't say.
They are doing. The second thing, does any patient complain of difficulty in breathing or something like that because of this?
No.
No.
See, we are just pushing the anticapsule area. And just 4 mm or 5 mm. We decide and then go about it. And at the end of the surgery, we are doing video laryngoscopy. I am not sure where I have to edit. So we do that and we see that everything is fine. And he receives 3 shots of steroid in the next 24 hours.
Okay.
And patient before going, he undergoes another video laryngoscopy before we discharge.
Right.
So far we have not
Theoretically, it is just there.
No, it's not possible.
Right.
Thank you, sir. That was an interesting presentation indeed. I now invite Dr. Sanjay Gandhi, sir. Sorry. I now invite Dr. Sachin Gandhi, sir, for his presentation on benign lesions of vocal cord.
Okay, I think we'll see the clips. I will explain you the key points, what you have to do, observe in these particular cases. So actually, anterior glottic web, it could be congenital, it could be acquired, basically because of external traumas or the internal traumas you do with cordotomies. Okay. Now, how to deal with them and what are the methods which can be used and get a successful outcome. So, this one case is a thin web. Let's start with the clip and then we'll see. See, now see the stroboscope. Voice please, audio. Okay, this is the same actually, I got to know Paul Castellano's, the same article which was published here. So now this is a thin web. What you mean by thin web is when you are able to see through the web the tracheal rings. So that is a thin web. If it is a thin web, then you can very well use scissors or cold steel instruments. So I have used a cold steel instrument, scissors. I have cut out the web and then I have put in a key. So remember, thin web can very well be managed with whatever instruments you have. Then you can, I mean, if it is a quite a thin web, you may not put a keel also, but in adults you can go ahead and put in a key. Now this second case. Now you see, this is a web. Okay, so here actually it is a thick part. So maybe I have used the AccuBlade or the CO2 laser to release the wave, and then I will put a keel into the raw area. So this is a CO2 AccuBlade, 2 millimeter is the length, and once you go anteriorly, the web is released. Now, in case of laryngeal webs, you have to use a false cord retractor. So give pressure on both the vocal cords. So when you cut, actually it opens up. Number 2, you have to always protect the subglottis from your laser strikes. So this is a curved forceps which I am using, and then I am protecting the subglottis from the laser strikes. Now, how much anterior you have to go? You have to go till the pericardium. I mean, not the pericardium. There is no pericardium, but not near the cartilage. You don't have to expose the cartilage. Okay, it should be only on the membranous part of the vocal cord. Because if you expose the cartilage, that is again the chances of refibrosis are quite high. So check the alignment to the subglottic mucosa. Now this keel I am putting with Lichtenberger's needle. Now I was fortunate enough for Lichtenberger to come to my clinic in Pune, and he got one set with him. So I used that set. Still I am using, but it is not available with the company. It is manufactured by Storz, but it is no more manufacturing. Some people from Mumbai are manufacturing it. Kalilkar, Santosh, sir, you can inquire with them. But this is the Lichtenberger's needle, which you put in the keel with the subglottis and between the false and true vocal cords. Okay. So these are the and this is the, if you don't have Lichtenberger's needle, then there are other methods very well you can use in your clinic. Now everybody has access to the institutes, and these laparoscopic people, they are using the intracats. Number 16 intracat, they are a little longer that you can use and do the surgery. I mean, I have done this maybe 50 days back. See, I have released the keel here, the web here with the laser. Now this is the needle. I have passed through into the subglottis. Then I have thread proline from outside to the lumen. Now I will take this thread outside the endoscope and apply a mosquito to it. See this false cord retractor. Remember, this has to be there.
ये प्रोलीन है.
And now this is the another needle just superior to the true vocal folds. Then you have to pass the keel down, take the thread and just needle it through the intracat and take it out and have subcutaneous stitches there. Okay, so this can be very well done. Needles are easily, you can pass them because you are working in the midline. You can always palpate the midline. Okay, so you can just see the needle from inside with the endoscope and then pass it. Now internal laryngoscope. Number one, you have to be aware of this condition. When you see swelling within the larynx, don't term it as a false cord edema. Okay, there is a entity known as internal laryngoscale, and you will see soft roundish lesion within the larynx, and then you have to do imaging to know it's only internal part which is giving symptoms to the patient, and there is no any external element to it. If it is only internal, then you can very well resect with the laser, and this clip I am going to show you. See this bulge here. This is the internal laryngoscale. See the cord, opposite cord is here, and this is the bulge here. This is the internal laryngoscale. The child doesn't have dysphonia as his presenting complaint, but respiratory distress. That's why he would need surgical intervention. This is the imaging which is showing intact cartilage, and there is no element outside. See, this is a true cord. This is a cyst. I mean, the laryngoscale is the cricothyroid, the membrane which really bulges into the ventricle, the ventricular prolapse type of thing. So you should have a good exposure, lateral exposure of the cyst, because if you want to go and remove it completely to avoid any recurrence, then you should reach the thyroid cartilage, visualize the thyroid cartilage, and excises from the thyroid cartilage. So what first thing you have to do is excise the false vocal cord or the ventricular band. Then you start dissecting. So basically now I have dissected the ventricular band. This is a cyst. Now I am separating it laterally from the thyroid cartilage, and this is a probe with which I am able to palpate the thyroid cartilage. You can just check that you have reached the lateral extent. This is a cyst. Now this is the Oswald-Hunton metal endotracheal tube to use the laser in a small child. This is the end point of the surgery. So I mean, just to keep in mind, you have to go laterally up to the thyroid cartilage and excise it. And for good exposure, you have to excise the ventricular band of the false vocal cord. Then you will have a good exposure of the cyst itself, medial to lateral. Now laryngeal cleft. Actually, when I started my practice, I started seeing the children. I was not aware of such an entity. A lot of institutes, many of the institutes now have NICU with them, NICU and PICU, and you just get a reference, cough after swallowing or dysphagia in a small of the child. And you just on child, you get these references, and you just give standard anti-reflux and endoscopy, and you just don't find anything major. And when I did flexible endoscopy of one of the child, then I found the child is aspirating. I could not find, so I did the CT scan and all imaging, and there was no TO fistula or any other thing. Then I realized, I studied, I consulted one pediatric surgeon in Pune at that particular time, and then he said there is something like laryngeal cleft, that is basically interarytenoid cleft to start with, which can go down through the cricoid cartilage, through the
type 1 and maybe some type 2, they are only interarytenoid clefts, mucosal clefts. They are generally treated conservatively, that is just give a positioning, maybe nasogastric tube, and as the age goes on and these children overcome their swallowing difficulties. Maybe type 2, type 1 few cases, type 2 few cases. What you can do, as we suture any cuts, skin cuts, just make both the mucosal surfaces raw and take the incision, take the sutures. Even if they are type 1 clefts and you have to do correction, just make them raw, keep some gel foam and just allow them to heal. So that will close the cleft. You can take sutures also till type 2 cleft. They would definitely need external exposure and surgery. Type 3 external exposure. As you go down into the bronchi, they are very difficult to manage, need external surgery, but the prognosis is poor, and you have to have a discussion with the parents if they want to go away with the child or just give away all the possible treatment. I mean, one of my friend, Dr. Vijay Shekaran from Australia, he is doing some specialized work in these clefts. Sometime we'll have time to hear from him. We'll see few clips. I don't know, these people may be also doing, but we'll hear from them if they are here. Now these children, they have breathlessness also. Why? I will tell you. Because of the cleft, there is aspiration. Now, to overcome the aspiration, there is always the cricopharyngeal mucosa which prolapses in between the cleft. See, this is the cleft. So there is aspiration. So body tries to compensate that aspiration. So this child came with tracheostomy as well as rise tube feeding. Now again, principle is the same. Put in the false cord retractor, open up the cleft. Then you can, this prolapsed mucosa, you can release it with either KTP or laser and with the help of scissors also. So it itself would make a raw area, and then you can take sutures anterior to posterior. Anterior to posterior. No. He's a tracheostomy, he's under general anesthesia. He's very, it's not as easy. Laryngeal suturing is the best of the skill in the world. Yeah, that's my experience. See, number one message I want to pass on is you are going to get references for neonatals and pediatric age group. Just keep this as a differential diagnosis, and when you are passing the flexible endoscopy, see to interarytenoid area as maybe cause of aspiration the child is having. You see this tracheostomy, the child has come. Now, see, I am taking cuts over the aryepiglottic folds like we do in laryngomalacia. Why? Because I want to minimize the pressure on the posterior glottis. So these sutures would not give away. So I take cuts on the aryepiglottic folds bilaterally. This is the examination under GA. This is just the case a few years back. See, this lady came with history of corrosive poisoning. Now the relatives say it's accidental. Now this is the picture. The epiglottis, see this is the epiglottis. It is adhered to the areoparetic folds and then the pharyngoparetic folds. This is below, so these are pharyngoparetic folds. Here you can see the true vocal cord and laterally the piriform fossa, they are not visualized. And the patient overcame with the peg and everything. Luckily respiration was quite okay because the vocal cords were mobile. Now see, all these are very important. Number one, vocal cords mobile. Vocal cords mobile. What does that mean? That means has not been to the arytenoids and Number two, I asked the history to the patient, to the relatives, and they said, sir, it's not intentional, it is accidental, because actually she never drank that corrosive poison, but when she opened up, the gas which came up, actually that has caused all the burns. So that maybe I had something in my mind, maybe this, because it was not ingested, maybe the entire alimentary tract may not have been stenosed. Maybe it's superficial. So I said, okay, what I can do? See, so actually the referred surgeon, I sent these images. I will cut one this horizontal cut here, one this horizontal cut here, then expose the piriform fossae. This is the cricopharynx behind, and I will check if there is some opening there, which I can refer to gastroenterologists, do multiple dilations and whatnot. They said, okay, no, whatever you can, because the lady 43 years old. So this is the first surgery. This is a KTP laser. I am using those filters actually to my endoscope. So the microscope also. So, just fast forward it. Now this is the piriform fossa which I can see. I can see the mucosa which was normal of the piriform fossa, but I was not able to see anything through and through. Okay. And I released some amount of epiglottis from the pharyngoparetic folds. So patient was, I just sent the patients back. Then I said, okay, because I see the piriform fossae were not fibrosed, maybe this is superficial. So we can try one more session and see if I can open up the cricopharynx, which I have not done, because in these cases don't do everything together, because you are using a fiber transmissible laser. All fiber transmissible lasers, diode, KTP, blue laser, these are more of a ablative lasers or vaporizing lasers. They are going to vaporize the tissue, not cut the tissue. And as you, because they are using for vaporization, there is lot of thermal damage around. This lot of thermal damage around, the patients are prone to develop refibrosis. So you have to do in steps. Don't do everything together, because the refibrosis will be then everything back together. So now the second stage. So this is a piriform fossa. These are mucosis. You can see the mucosal lining quite intact, but not through and through. And this is the cricopharyngeal bands. So what I could see is the arytenoid mucosa. It's quite free. Actually, I will show you now. These are the bands in the cricopharynx. So this is the arytenoid. See, arytenoid. The mucosa is quite good, but not through and through. These are the bands in the cricopharynx. Now what really I want to let you know, you see these are the bands here. But they are separate from this arytenoid mucosa. So when you are cutting these bands, you have to see to it you are not giving any thermal damage or any injury to the arytenoid here, because it will cause fibrosis within the gut. Okay, so I have done that. Actually, editing was not done. So what I have done is I have kept one probe with this band and arytenoid to protect arytenoid from getting any thermal damage, and then I have released these fibrous bands, and what I was able to see is the lumen and the post-stroboscopy shows vocal cords. This is a balloon dilation of the so now see, this is the normal mucosa, this is the and this arytenoid, interarytenoid mucosa are intact, so that is very important. So you have to see this is quite intact. So you have to protect this interarytenoid area, otherwise you will land up in bilateral vocal cord fixation. And then few cordotomies. 10% discount. This is the one. Type 2 cordotomy, again CO2 laser. I mean tomorrow this is going to come in our discussion, but this is type 2 cordotomy. Just see the CO2 laser excision. This is 1 millimeter margin. 1 millimeter margin. And the type of laser you use is described. Okay, we'll see two patients here. So why the lasers from companies like Luminous, how they are separate from other? Because of the physics they use, and which causes minimal charring of the tissue. Minimal charring means minimal surrounding tissue trauma, thermal damage. That's why there is a good voice recovery and good phonosurgical outcome. And why I say this is type 2 cordotomy? Because I have removed superficial and deep layer of lamina propria and some part superficial of the vocalis muscle. See, I have entered the vocalis muscle, but the bulk of the vocalis muscle is intact. Okay, so this is a type 2 cordotomy. So this is as clear dissection as possible. So that's why this is actually a cordotomy I have done. Actually, there is some images for early diagnosis. This patient was operated by me, type 5A cordotomy. That means the growth here in the atrial commissure. This was in 21. I operated him. He came back with this hoarseness of voice and showed these granulations over the edge of the vocal cord. So we did NPI. Actually, the images would be there somewhere. Tomorrow I will show you the NPI. And that NPI told us that these granulations are maybe pathological, and you should dissect this definitely. This is just show you type 5A cordotomy. So hydro-dissection to start with. Again, to preserve the mucosa, to reduce the thermal damage, because CO2 laser is absorbed by water. So you inject water and CO2 laser would be absorbed, so there would not be any peripheral tissue damage, thermal damage. You can see this. I mark the incision first, so I mark on both the vocal cords. All the margins have to be with 1 millimeter, at least 1 millimeter margin, intact clinical margin, and then you start excising. So this should be as, because cartilage doesn't have any water. So when the laser strikes it, it gives like a. And then and with this you can send it for margin. That's how it differs from KTP. Because KTP is vaporizing, it's difficult to have margins all along the tissue, all along the specimen. Whereas in CO2, because it's a cutting, you can have margins all along the specimen. And when you again examine with 0 and 70 degrees, your excision is complete. Okay. Thank you.
Sir, I have one question. It's just regarding laryngeal flex. Can we just diagnose this radiologically?
See, it's a dynamic. Radiologically, yes, radiology is a differential diagnosis. Maybe they will be able to locate that. But I think they would require sequential yeah, but if it is going down to the cricoid and trachea and trachea, then yes, nasogastric feeding for 3 weeks.
Madam, what is the difference between the secular cyst and internal laryngosis? Is there any difference?
Yes, there is a difference actually. Laryngosil does have 2 components. The origin is different. Okay, and the secular cyst mainly is from the it's a ventricular tumor. Ventricular tumor.
So how we can differentiate?
Yeah.
With radiologically or by examination?
Radiologically. Nothing actually. You have to just go and check the laterally the thyroid artery. That's the extent. That's you are going to miss. If anything, any recurrence happens, that's going to happen from that side.
The treatment is same for the both, for the secular cyst and internal laryngosis.
Yeah, the treatment is same, but secular cysts are big. They are in the anterior commissure, more of the anterior half of the body. But the treatment is same.
Thank you, sir.
Thank you all the speakers for excellent presentation, excellent videos.
Thank you, sir, for your valuable insights. Before proceeding further, I request Dr. Smita Soni ma'am to please present memento to Dr. Shantanu sir. request Dr. Yamini Gupta ma'am to please present memento to Dr. Smita Soni ma'am. May I request Dr. Kavita Sachdeva ma'am to please present memento to Dr. Shalini Jadia ma'am and Dr. Aparna Chavan ma'am.
Dr. Suma is here. Suma Matthews. Come, Suma, run! Run! Thanks to Vikas, we are exploring you.
We'll resume the session after a short tea break. Kindly pardon me, we'll continue with our session. Meanwhile, you can come and have a quick tea.
ये मुझे नहीं पता था जी तो आपको पता कौन है सोनू सोनू क्यों सोनू कैसे हो गया? संभव असंभव कार्य कैसे संभव हो गया? चलो और क्या? हाँ जी मैडम। यस, बोलिए, कहिएगा कहिएगा क्या चीज़ है नई आपके पास आज के दिन? ठीक है, ठीक है, ठीक है, ओके। इसको करो यार पैकअप। हाँ, अरे भैया कहाँ हैं? हाँ यार देखो कहीं सीट वीट पे ना डले हो, कहीं सो गए हो। स्टॉप कर दो, बंद ना करो, अंदर रिकॉर्डिंग चल रही है यार। चलने दो, तो कोई दिक्कत। हो गया, पूरी डॉक्टर भाग गई, एक बच्ची है बस। अभी है थोड़ी देर बैग में में पैक कर रही हैं। इवेंट 3 दिन का है, आज का ख़त्म हो गया। कल 2-3 हॉल में है, कल 3 हॉल में रहेगा, दो में रहेगा, कल 2 हॉल में इवेंट रहेगा। आज मैंने पता क्या देखा, वो जो पुरानी लाशें रहती ना, देहदान, हमने तो मैं रात में एक स्नैप दिया, देहदान सर, हम मोचरी में घुस गए थे कल। फिर क्या वहाँ देखी मैंने, लाशें डली थी वहाँ रखी थी बढ़िया। हाँ, तो आज क्या हुआ, दिल्ली एम्स जो एक बहुत डॉक्टर थे प्रसिद्ध, वहाँ से लाइव करवाया था हम लोगों ने, यहाँ दिखवाया था इन लोगों को। तो वहाँ ये हम लोग का एक यूट्यूब चैनल जो है ना, उसमें डायरेक्ट लाइव परफॉर्मेंस करवाया था, तो हम लोगों ने यहाँ उसको दिखवाया था। और यहाँ वो इन लोग की गैदरिंग करवाई थी डॉक्टर्स की। और मोचरी में यहाँ भी नीचे ऑपरेशन करा था कुछ बच्चों ने, तो वो भी दिखाया था यहाँ। यस, ये वाला
यही है ना?
देन
है सबके एक जैसे ही।
हाँ,
लेकिन मैंने उस पर नाम लिख लिया था,
पाठक
ऊपर लिख दिया।
रख लो, इसको स्टॉप कर दो। भूपेंद्र भैया को फ़ोन लगाओ, कहना उठो यार, हाँ लगाओ बार बार, कहना हो गया, कहना आ जाओ। क्या कह रही? सोई देंगे, कल भी है, परसों भी है। यस, परसों है दोपहर तक। दोपहर तक है परसों। एक मिनट,
अब जाने का बोल ही दिया ना भैया ने।
क्या बोला है?
वो बोल रही वैशाली सबको जाने का बोल दिया 6 बजे तक।
6 बजे तक तो चले जाओगे, पैकअप तो कर लो।
वही पैक करके।
और ये
ये क्या करना भाई?
तो लगा लिया कैमरा है। नहीं तो भूपेंद्र भैया हैं कहाँ? फ़ोन नहीं उठा रहे क्या? बाहर कहाँ है?
अरे ये साफ किसने कर दिया? क्या हो गया मैम? मुझे नहीं लग रही मैं डस्टिंग करके चला गया ना। अभी बचा है ना सेशन?
एक बज रहा है।
बस पैक
सुबह भी आया है। सुबह भेज देना 7:30 बजे से।
आपका कॉलेज बहुत अच्छा है, लेक्चर हॉल्स आर अमेजिंग। मतलब कोई इंतजाम मेरे को ऐसा लग रहा है इंतजाम तो बहुत किया है पर हॉल तो मिल गया है बहुत। इंस्टीट्यूट में ही करना चाहिए हमेशा। यहाँ पे पकड़ लो ना सबको, कैमरामैन को ही बुला लो। फोटो खिंचवाते रहना चाहिए, देखो समझ में आता है क्या बोल रही है। माय गुडनेस,
कल मैं सुबह आ जाऊंगा।
इतनी खुशी मेरे बगल में खड़ी होगी, इसलिए मैं क्या खड़ा करती हूँ।
इसके बाद कुछ तो एक दो टॉक है, टेक टॉक पसंद को टाइप करना है, इसमें मैनेजमेंट ऑफ डिफिकल्ट केसेस इन एयरवे ऑब्स्ट्रक्शंस, ओपन हार्ट
यार सुनो, तुम और स्माइलिंग कर रहे हो, फिर से लो भैया। अब मैं देख रही हूँ कि मेरी फोटो बहुत अब आप आगे बढ़ो।
छोटा सा उसी का बनाया हुआ है, ऐसा होता नहीं है बस, लेकिन फिर भी अपना बैकअप के लिए होता नहीं है बस, लेकिन आपको एक डर खत्म करने के लिए बैकअप रख के चलना जरूरी है। हाँ सही मीटिंग है, हाँ मीटिंग है। अब इसके मेंबर है नहीं, सेशन ब्रेक हुआ है। हाँ
तुम्हारा ऊपर वाला सेटअप।
हाँ नहीं ओटी बात कर रहे बस डिस्पेजिया वाला बस हमको बताइए बस क्या उसमें मशीन कर देगी पहले तो फीस ही कर रहा हूँ मैं
अभी तो एक मैं ग्रुप में डालता हूँ मैं तो एक दिन का डिस्पेजिया अपडेट
सब अच्छा बहुत बढ़िया
उसके बाद केवल डिस्पेजिया
है ना ठीक है
ये बता कंप्यूटर की हुआ है ना वो तार वाला निकाल के अपने बच्चों के लिए आजकल डिजिटल क्लासेस एक बड़ी प्रॉब्लम देना नहीं माइक्रोस्कोप मैं लगा था कंप्यूटर नए पेशेंट ने 50 पुराने मिला के लाइट 55 पेशेंट टाइप करता हूँ लगातार स्क्रीन पर देख रहा हूँ ये बॉडी डिसेक्ट आई से ज़्यादा हो गया अब मैं उसका काम करूँगा मैं स्टार्ट से थोड़ा देखिए ऊपर नहीं ग्राफ में उठाता है देखो सूचर तो जो मुझे काम नहीं आता था ना बस ज़्यादा कराना है सिखाने मुझे सूचर तो पर सूचर तो लगाते ही जिंदगी में नहीं लगाया सूचर तो भैया बंसल आएगा तो बंसल लगाएगा जो बंसल नहीं होता मेरा स्टाफ उसको लगाया बड़े दिमाग खराब होता है यार आगे का तो मैं कर देता हूँ पीछे क्यों लगा रहा है और बहुत बढ़िया लगाता है वो वो बहुत मजा आता है किस तरह होता है फॉरवर्ड बॉडी हमें दिखने ना चाहिए करना पड़ेगा फिर भी चला ली घंटे वो ऐसी मशीन निकली नहीं फिर मैं तो बुलाया इसको बंद कर बहुत से हमें ना गाँव में ट्यूबवेल निकालते हैं, कैसे निकालते हैं, कैसे और ट्यूबवेल क्या एंगल बना के अंदर डाल के हुक बना के ऐसे।
Proceeding further, I now invite Dr. M.D. Bharti ma'am for an open discussion on management of difficult cases in airway.
ऐसा करता नहीं ना काम के ऊपर मैं उसको सिखाते ही रहता हूँ, जैसे पढ़ता है पढ़ता है पढ़ता उनको भी पढ़ाता हूँ, वो सीख जाएंगे तो मेरा काम आसान है। अब जैसे डिस्टर्बेंस समझना सीख गया समझो, जब मैं नींद भी लगाता हूँ ना तो अक्सर डिस्टर्बेंस आ रहा है, और इतना नहीं समझते कि लेफ्ट है कि राइट है, उनको बताता हूँ कि तुम ग्राफ ऊपर जाएगा नीचे राइट हो गया नीचे आ रहा है, जब ये आज सीख जाएगा तुमको आगे बताओ।
Okay, good afternoon everyone. Before we start this, so I have actually many cases, but before they assemble, there's one patient of HIV positive patient, not this, the other one. He has stridor for which tracheostomy was done, and then he was referred to us. He has both the vocal cords fixed in midline, almost midline. And before that nothing, we could not pass the scope only, and the CECT showed that entire cricoid cartilage is eaten up. It's sort of diseased and fibrosed, and it is occupying the subglottic lumen. Below that it's normal. So how to go about that case before I come to this? Entire cricoid cartilage is fibrosed, it's diseased, fibrosed. We did biopsy, we sent for CBNAC, nothing came. It's just coming as chronic inflammatory. Autoimmune disorder also, we worked out ANCA, everything is negative. And the CD4 count is 0. It is not, is not having active HIV. No, everything is normal. We ruled out everything, all the entire system we worked out. That also, we thought IgG4 disease, so that also we have worked out. No, that also negative.
Sir, for mic on, please, sir. Talk on mic.
In the scan, entire cricoid cartilage is diseased, fibrosed. The lumen is totally.
I had 2 cases of weakness with limited subglottic presentation. Same.
Yeah, we have, but those we got the positive results so that we could treat with steroids, and our immunologist took over. But here everything is negative.
You've given steroids, right?
TB? Nothing. CBNAC, we sent the tissue, everything we have done. Except chronic inflammatory, even for immunohistochemistry also we sent. Nothing is coming positive in them.
Because recently I saw she was also, even the pulmonologist was telling that you don't have TB, you go to it and get your surgery done. I was concerned about it, and she got her all the TB tests done on her own, and then went to the pulmonologist and showed it was positive, and on treatment she is fine.
Fixed in parameter. We just forcibly we have to pass through, because the cricoid is there, fully occupying the subglottic region.
Extended cricotracheal dissection as anastomosis with expansion laryngoplasty.
Sachin, you know what? Without knowing the cause, we cannot do it.
Yeah,
Why I'm
that's
telling?
why.
I've got 2
That's
cases
why.
right now. Since last 2 weeks, last 1 month, they are eating my brains. One is with Behçet syndrome. He has got complete, esophageal, cricopharyngeal stenosis and bilateral cord palsy, along with part of soft palate cord. Now he says do something. I said I can't do anything till the time your disease is cured or something. Then another one is plasma cell mucositis. This one again, he has got subglottic stenosis and everything, but he has multiple other problems. He had undergone lobectomy, and the pulmonary function is very bad. I said, I can't do anything. You have to live with it, because the moment we touch it, the patient is not going to come out of it. So you have to be careful. These two cases are eye-openers for me, that every case is not that you will put your knife. Sometimes you have to leave it.
Yeah, I think keeping in mind patient is HIV positive and everything, best thing is tracheostomy.
It can happen.
Yeah, he is with tracheostomy, and the other alternative is laryngectomy. That's
you
all.
said ki the CD4 count is 0. And
0 now, sir.
Yeah, so maybe because they are going to ask, they are going to go from shop to shop because they would want to recharacterize. I think this is the thing which I can think of.
Before, yeah, they have treated and now it's negative. Yes.
One patient was who had basically pemphigus. He used to get recurrent number of ulcerations. The ulcers all disappeared. Then his sugars were under control. And eventually he landed up with severe stenosis like maybe sending us for antiretroviral antibodies. He might have had ulcerations earlier when his HIV was active. Antiretroviral antibodies might. Anti-retroviral antibodies.
Anti-retroviral antibodies. Okay. I'll talk to the patient.
Also, ma'am, this class of IgG4 deficient disease, this is also quite these days being discovered in various ENT sites, and we recently have had a lot of connective tissue disorders being diagnosed on that basis, and some of them are steroid responsive and some of them are not responsive, so that again becomes a clinical question. But yes, I will also agree with the fact till the time we know the diagnosis clearly, resection is a heavy morbidity and potential mortality exercise to be done on such individuals. It might worsen and take them out of a situation where we cannot salvage them back.
So leave it with the tracheostomy and follow him up.
Because fistulas and all will eventually form and will be totally life-threatening after that.
Thank you. Actually, this is a 34-year-old male came to EMD with noisy breathing and hoarseness of 16 days duration. Actually, he had undergone bifrontal craniotomy for epidural hematoma for fall from the first floor on 29th January 2024. Hospital administered for seizure disorder and breathlessness 21st/3/24. Intubated on 21st for 15 days. And is on treatment for the seizures. Emergency tracheostomy was done in view of stridor under LA on 8/4/25. So posterior glottic area was affected and subglottic, and below that the airway was normal. Concentric irregular asymmetrical or subglottic region with 16 mm with maximum thickness of 6.4 mm on the right side mid body. There's actually it shows that the cricoid cartilage was deceased, the arytenoid was calcified, and there was a cricothyroid fixation, and on the right side there's abnormal dilatation of the supraglottic lumen measuring 10 mm in maximum medial lateral dimension. Calcification, arytenoid and cricoid. Yeah.
How much duration, ma'am? Intubation time?
15 days. That's all. But he had a fall also before that. So he said that he had injured the neck also at that time. So how to go about this patient?
What is the aspiration status, ma'am?
No, no aspiration. No aspiration. He is taking oral.
So we can say that at least it's a functional larynx for us. It's able to prevent.
Yeah, dynamic larynx is there.
And, well, the mucosa doesn't look very bad. From the inside, but this is age would be
35 years.
35.
Actually, he had MRSA infection. Then we treated him for 3 weeks.
Glottic mucosa is not.
Yeah. Except for that, the other area looks normal.
Certainly not a one-stage procedure. I think that is not possible in this case.
Because both arytenoid are calcified, the cricoid is calcified, cricothyroid fixation is there on one side.
Dr. Paul Castellanos has devised one flap, post-cricoid advancement flap. We can do that. What we do in that is we release all this thing, the post-glottic fibrotic bands, and then release the cricoid joint as well. In fact, most of the times they start functioning as well. Okay, and bring the flap from the post-cricoid region, drip it over this thing, and switch it. Yeah, we have a good paper on that.
Endoscopic or
endoscopic? Endoscopic, microscopic.
Okay.
I have a paper. I'll share it with you.
But I think, ma'am, some distraction is also required in the posterior plate of the cricoid. I would not mind. I have done a few cases of costal cartilage interposition in a 35-year-old. I mean, it's going towards a little bit of adulthood more than what you would do. Sandhu and all, they say that cartilages do not work in adults, but we have seen a good distraction processes through a laryngo fissure in an adult. A railroad technique that has shown result. I've done in 25-year-old female. She didn't have that bad mucosa. This person has a bad mucosa. So in fact, in such a case, I would still do that more than this thing. Give a good distraction, and it should. If the larynx is not dysfunctional, then keeping without a stent, without a laryngeal stent, but with a tracheostomy for some days and then decannulating could help such a person.
Dr. Manju, the problem is if at all we the moment we touch the cricoretinoid, if it becomes, adynamic, that's the one thing. Or it's okay to.
I mean, we are not damaging. We are not cutting the cricoid. We are only releasing those fibrotic bands in between the arytenoids, and release it, balloon dilate it so that it spreads out, and then bring the flap and drip it over the naked mucosa.
I think that is for posterior glottic stenosis. What you are saying, classical posterior. This is cricoid subglottic stenosis as well. You can release, but the whole ring has become narrow. So anteriorly is still better. Yeah?
Anteriorly it's better. Only the posterior. But Manish, if at all you do only posterior, I also thought that posterior split and then bring some material there.
No, you can't do, ma'am. You have to split the anterior, then do the posterior.
Yeah. But the problem, my colleague was telling, madam, now at least it is dynamic. That is no aspiration. If at all you move apart, if the cricoretinoid now both are here, so maybe it's not having aspiration, but it might become.
So, ma'am, that's one thing. If this person has neurological aspiration by any chance due to the hematoma, then it's a big disaster.
Okay.
But if the person doesn't have a neurological,
No, he doesn't have.
then ma'am, you do whatever in the larynx. I think he'll not aspirate that much. Yeah, distraction never causes aspiration. Till the time he is, yeah, that'll. I mean, unless we like really take it far off and don't let the vocal cord cover, we will always be short of that thing. I mean, our problem is actually dilating it, not over dilating it. It will never happen. It never over widens.
You separated for roughly around 3 to 4 millimeters. Now aspiration is rarely an issue.
Okay.
But then if you go beyond 7 millimeters, it's said that you can start having aspiration in these cases. So that's the 3 to 7 millimeter usually is the.
We keep that. Okay. Thank you. I'll update in the next Laryngology Summit.
I shared it in the faculty group. This paper. Can go to it.
वो लैपटॉप उनके उसमें हार्ड डिस्क है क्यों इसमें वीडियो में इनपुट का है साउंड का डायरेक्ट इनपुट है बड़ा कहाँ लिखूंगे ये ना कैसे कर रहा है बट वो साफ थोड़ी अच्छा थोड़ी आएगा बहुत खराब उनका लैपटॉप भी लगा ही दो ना लैपटॉप हाँ हो ही जाएगा काम इसमें कर दो ना लैपटॉप नहीं तो इसमें उनका लैपटॉप होगा ना सर का हाँ तो उधर ही कॉपी लगा देते ना उसी में तो वहीं में इतना स्टोरेज देखता स्टोरेज भर जाएगा लैपटॉप का इससे इसमें ज़्यादा है ना कितना का है 1 TB का कितना एक
one interesting case I'm discussing. Those who know Manish and all, you are barred from participating in it.
2 में भी नहीं होगा मेरे क्यों भैया 2 हॉल का 3 दिन का 2 दिन का 2 टीवी में हो जाएगा 2 टीवी हाँ 2 टीवी एक टीवी में एक इसको देखना आप ये रख ही लो आप तो इसमें डेटा डाल देना ना मुझे फोटो भी दे दो
My name is Sabra. I'm having this osmosis problem for the last 6 months. In the morning, for 15-20 minutes, I can speak.
इसमें properly जमा के.
But in the evening, when I start my work, after a couple of hours, if I speak continuously for 1 hour, 2 hours, my voice doesn't come out in a good.
He's from Bangalore. He went to 4 or 5 laryngologists in Bangalore, then came to me. I was also perplexed. Look at the video laryngoscopy. Now, any of you can throw a light. What can be the cause? Bharti ma'am has already seen last time, I think. Yeah. Anybody guess? I was also. It took almost 2 hours for me to figure out. I kept on repeating this video laryngoscopy time and again. Started thinking what it is.
Something is projecting. Something is projecting anteriorly.
Sorry?
Something is projecting anteriorly.
Okay, we'll play again. What can be? Right. Sorry? That's a good question. But you would have had more severe dysphonia. And he is telling that morning is fine and it deteriorates in the evening. Sorry? That should be also, yes, you are right, but no other thing. He has already undergone to 4 or 5 ENT specialists in Bangalore, I am telling you.
Money.
Okay, now what am I doing?
6 months. While speaking, I'm finding it difficult in the evening times, but in the morning it's easier for me to speak. My name is Sampath. I'm having this problem for the last 6 months. In the morning, my voice is perfectly fine.
What am I
15,
doing?
20 minutes.
His voice improved.
Later in the evening, I'm unable to speak because of my work.
No, again, no.
I'm having this problem for the last 6
Watch
months.
carefully.
While speaking, I'm finding it difficult in the evening times, where in the morning it's easier for me to speak.
Yes, Dr. Soma.
My name is Sampath.
Yes, you are right. It is unilateral superlaryngeal nerve palsy isolated.
Was perfectly fine for 15
So I am doing one side cricothyroid approximation. Right? So we did modified type 4 thyroplasty on his left side, and look at the arytenoid, what it was before and what it is now. So you can make out. Now his voice afterwards.
My name is Sampath, born and brought up in Bangalore. I was having this hospice problem for the last 6 months. In the morning I was able to speak for 15-20 minutes very fine, but in the evening.
And this is his voice after 4-5 days.
जो मेरी आवाज़ पहले जो थी, जो हॉर्सनेस उसमें लग रही थी, ऑपरेशन होने के बाद 2-3 दिन के रेस्ट के बाद अभी आवाज़ एकदम परफेक्ट लग रही है मुझे।
My suggestion is,
हिचकिचाहट नहीं हो
don't
रही
give
है,
up.
सामने वाला भी समझ
Keep
पा
on
रहा है कि
seeing
मैं क्या बात
the
कर
video
रहा हूँ।
again and again, something out of place. And like somebody said, the arytenoid was not proper on left side. That gave me a clue that why it is like this. Then I pressed the left cricothyroid approximation, and his voice improved immediately. Sorry? Unilateral monoparesis can be due to viral also.
Sir?
Sorry? No aspiration
Sir,
won't
why
happen.
is what, sir? Sir, उसकी आवाज़ सुबह सही क्यों होती है और शाम को खराब क्यों हो जाती है?
See, that is the beauty of superlaryngeal, isolated superlaryngeal palsy. It comes like that only. They keep on talking, then it starts becoming fatigued. So, yeah.
Two things, practically I want to add. This type of arytenoid dislocation or say arytenoid not in proper position, it is many times we see regularly with absolutely normal voice.
Yeah, absolutely. You are absolutely right. But when you have a person with symptoms, you have to start thinking why it is. And then you have to find a solution. He has come all the way from Bangalore. So I had to give him some this thing. So I wanted to find out first why. He had undergone speech therapy also. In spite of that, he didn't improve when he came to us. So we did it. And his voice improved. Now also he keeps ringing me up now and then. This was 2 years back I did. So sometimes what I am telling is, laryngology is a very nice subject where when the patient used to come, when he comes with some voice problem, don't just neglect and don't just send for speech therapy. First, you have to find out what it is, what is the cause, and then you send. I have a patient, I must have shown you, tomorrow I will show you. She had undergone purely a case of abductor spasmodic dysphonia. I gave Botox, improved very much after 2 weeks. Then after 6 months she came, I gave Botox again, both sides 10 units each. She did not improve. I kept on thinking what I will do. Then I read somewhere, I did the posterior cricoarytenoid muscle spot welding type with diode laser. Didn't improve. Then I called my speech therapist, who was my student, and I was her PhD guide. So I sent to her. Within 2 weeks, this lady comes back with normal voice. I'll be sharing tomorrow. So this is possible. Don't give up hopes. And she was almost crying, 33 years old. She was from Tanzania. And I gave her hope. I said, okay, let's see. Just listen to me, go and get the treatment. She became all right. So sometimes, and Botox resistance is known. Initially it may work, second time it may not work. It is known. There are literature. I went through lots of literature to find out a solution. So this is what it is. Thank you very much.
Actually, my presentation, basically, I'm going to show the clip. Just to take it to the lighter note, this case, particular case, now, when the patient is in Bangalore or Delhi, don't need to waste so many months for the treatment, just to send the patient to Dinar Malik.
Bas, such a Gandhi will cure.
To Raj Lakshmi, and for what? Where is Raj Lakshmi? Yeah, what you will do?
Sir, I'll show you.
What's the diagnosis for this patient? Will not take 2 hours for diagnosis. Why?
Laryngeal EMG will do.
Yes, laryngeal EMG. And that's the my actually discussion is on that itself. But we are started with the laryngeal EMG, and laryngeal EMG is just a wonderful tool. And it's very easy to check. Before
He didn't go to you, he came to me. That's the catch point.
That's why.
Why should I send to my rival Satyam Gandhi?
That's why.
Friends.
That's why I'm announcing on the screen.
No, I have sent in. One patient, different humors to me. One patient came from user commander, retired commander from Goa. And everybody had given up the case and said there is nothing wrong, nothing wrong, nothing wrong. But he sent me the video. I suspected there is a small cyst, intracaudal cyst. He went to Pune, again Bharati Vidyapith, and there they actually said, no, there is nothing wrong, go for speech therapy. He said since last 2 years I have been running from one speech therapist to another speech therapist. I said, I see intracaudal cyst, please go to Dr. Sachin Gandhi, who is the best laryngologist, go to him. Because he didn't want to come to me because of distance. So he went to him, he operated, he became all right, then he sends me thanks. I said, okay, you don't listen to me. Sometimes I send cases to him also. Thank you.
I'm worried, not worried about the patient, what he will say if I fail. I'm worried about brigadier. I mean, this is just supposed to. You can hear the voice. This patient came after thyroidectomy, thyroidectomy with now see, there is a right vocal cord palsy, but the voice seems to be quite okay. It's not hoarse because the vocal cord is median to paramedian position. But patient says she has a fatigue. She can't speak loudly, and by evening she says, I don't want to talk more. Number 2, she has got mild aspiration. And number 3, she says she has one episode of loud snoring while she goes through sleep. Maybe every 3rd or 4th day. So can we explain this on this scope? So hoarseness and everything we have already explained, because the vocal cords are approximating quite nicely because of the fixity or immobility is in the paramedian position. So the approximation is quite good. So maybe voice is good enough. But why there is a vocal fatigue? Because the muscle is paralyzed or having less of the activity. Why aspiration? Again because of recurrent laryngeal nerve palsy, superior laryngeal palsy. And why snoring? Because of this arytenoid prolapse. This prolapse is happening. Okay. Now, what you will do?
Hello.
Yes.
Hello. Hello.
Now, arytenoid erection.
वहीं हूँ एम्स में
Because you are dealing with arytenoid also.
कंफर्म नहीं है भाई 8 साढ़े 8
Then her snoring or respiratory obstruction will not be taken care of. So that prolapsed arytenoid has to be taken care of.
देख लेंगे
Okay. So thyroplasty with arytenoid erection or only arytenoid erection may be. Yeah. Now just because the patient has snoring, immediately one of the just remove this prolapsed arytenoid. So my first expression or first thing I told to him, please don't, because this is compensatory. This is compensatory to the swallowing, the aspiration patient has. So don't remove this. Number one, usually the aspiration and superior laryngeal nerve recovery happens in 6 to 12 weeks. Generally, I have seen all in accidental trauma or most thyroidectomy. So you just wait for 6 weeks to 12 weeks. Generally, the aspiration is taken care of. When the aspiration is taken care of, you can do either arytenoid or what I did really was after the aspiration was taken care of, I did arytenotomy, partial arytenotomy with fat augmentation. Fat augmentation
में आपको डाउन करना पड़ेगा इसमें एक ही फुट है जब आप हार्ड इसमें एक ही हार्ड वर्क करोगे दूसरा
what really I want to what to say, the points I want to raise is larynx has got three functions: oration, swallowing, and
अरे ये तो 60 जीबी बस 3 कार्ड फिर भी
बस आवाज नहीं आ रहा पीछे सर क्या आपकी आवाज नहीं आ रही पीछे सर
sorry sir. Hello. Yeah. So basically these three functions and they are intermingled. So while correcting the other function, you just remember why it has happened and how to protect, I mean, take care of all these three functions while treating these patients. And again, what really helps us is laryngeal EMG. There is a talk by I think Rajlakshmi tomorrow on laryngeal EMG, and there are three types of potentials we see, and that will predict what are the chances of recovery, and then you can continue with voice therapy and all other exercises. Okay. There is another clip actually. This patient was sent to me by own. This is a pre-operative scopy. Generally, big thyroids, the general surgeons send them to me for pre-operative stroboscopy just to see the airway and the vocal cord function. And see now, same thing. This picture is, I think she was immediately referred because of the breathlessness the next day. She was admitted to ICU, intubated, and in CFT you just remove the tube, check thyroidoscopic retrostomal extension. Maybe I have injured both the vocal cords, both the nerves. So you do whatever you want to do because she is breathless and I have to intubate. Otherwise, I will do tracheostomy. You will see afterwards. So I took her to the operation theatre, remove the endotracheal tube.
Sir, mic.
Remove the endotracheal tube and check the vocal cord mobility. The vocal cord mobility was there. It was present. It was not real. So I said, maybe it's edema to the recurrent laryngeal nerves, maybe which has given her some part of this compromise. So we'll wait with steroids and everything. Now this patient is not breathless, but she is aspirating because there is some phonatory gap. There is abduction, is not happening. This is after 6 weeks on follow-up. She is on voice therapy. Now my question is, what would happen the next? What you should counsel to the patient. The first shows good mobility. Now the vocal cord movement, the adduction is there, but abduction is restricted. But there is some phonatory gap for the patient who does not have respiratory distress as such, but aspiration is because of the aspiration is because of the phonatory gap actually. Patient is aspirating through that open incompetence. Yeah. So how you are going to go ahead with this patient? Yeah.
These can be very challenging cases. Typically, what I'll do in the clinic is a trial saline injection with Reconstruction, just to see if they become dyspneic with a little bit of support. And if they tolerate it just fine, then I'll inject one side, and even that's not enough to indicate the aspiration.
Yes, I think the patient is on swallowing therapy right now and voice therapy. But again, Raj Lakshmi, laryngeal EMG would tell us what are the chances of recovery depending on the pattern we find on laryngeal EMG. That is number one. Accordingly, you have to counsel the patient, because patient is going to ask, sir, ab kab ye hoga sir? Already 6 weeks have gone. Voice is quite hoarse because there is incompetence in the larynx. My experience is now 6 weeks down the line, these vocal cords are going to come in the medial position. The patient is going to land up in respiratory distress. That's how the maybe nerve palsy works. That's my opinion. So you should continue with the swallowing therapy, voice therapy, and this type of counseling depending on your laryngeal EMG.
Just want to add on this type of cases. In 2 of my cases, I do for MNG, for multinodular goiter, I do under microscope. This recurrent, and now I have preserved everything. Still, those 2 of the patient landed up in bilateral recurrent nerve palsy or paralysis, whatever. Maybe not due to edema, maybe due to stretching while we are taking out the things. They are stressed, and one patient was in mild stridor. On giving steroid within 5 to 6 days, I keep on hospitalizing, the stridor decreases. Then again, one swelling therapy which helps in all these things is supraglottic swelling. 2 things. One is it is taking the pre-deglutitive, intra-deglutitive, and post-deglutitive. Second thing, like in palsy, we want to move those things. Then in supraglottis, when he coughs out after swallowing, these things put pressure on recurrent laryngeal nerve, and recurrent laryngeal nerve, in my practice or whatever small experience I have, it is the nerve which forgives you most of the times. Even if you have stressed, even if you have cut one side, then many other times due to dyskinesis, synkinesis, somewhat it comes in midline and it forgives you, so the patient is better on his voice and all those things. So in these cases, rather than going directly to the injection, laryngoplasty and all those things, we should wait for few weeks. And in solo practice, when we are not in a big setup, it is very difficult that I have not cut the nerves, but still you are having a stridor, you are landing in a stridor, and I have to do tracheostomy and all those things. It is a big headache. In these cases, in my small experience, just waiting for even 7 days recovers the patient if you have not cut it bilaterally. Just wait, just give steroid, just give calcium channel blockers so that the nerve recovers early.
Yeah, this is very important. Just wait and watch, and especially when it's not a referred case, it's the case you have operated. Then these are young females, thyroid, these are young females, the family and everything is involved. I think this is just one case. This is actually a swelling here, supraglottic swelling. Now patient's vocal cords are mobile. Again the same as I have explained the last case to you. But there is a swelling here. Patient is breathless on exertion. Now again what you will do? I mean, I already given you the hints in my last corrosive poisoning discussion. You have to locate the lesion and where you are going to through the excision, which area it's going to get involved. That is very important. So remember, this is a swelling in the interarytenoid area. Okay, both the vocal cords are mobile. That means the swelling is not infiltrating it as the arytenoids are mobile. But when you are going to excise this, when you are going to remove this swelling, the interarytenoid mucosa would form a raw surface, and there is a good chance of patient forming stenosis because of your surgery. Okay, so this is a young patient. So you should be very careful. Where is the swelling? What's going to happen? Patient is now quite good. She has a good voice. Young female again. Okay, so then with keeping all this mind, we have excised. Now this is the raw area here, and then what I have done is taken sutures to approximate the interarytenoid mucosa. This is the post-operative stroboscopy. This is, as I have told you, to take the knots and suture in the larynx is the most difficult task. So I am using the laryngeal clips instead of tying a knot. But yeah, so this is very important to locate where you are operating and what you are going to do because of your surgery. It should not be iatrogenic complication. Thank you.
Sir, in the fourth, sixth slide, you have applied a Lva clip, which you have not shown. So we have projected this slide. So the last slide is the Lva clip.
No, actually, I have taken a suture, but it's very difficult to tie a knot because you have to have.
So not for Lva clip.
Yeah, just get the two strips together, and instead of a knot, just keep a clip there. Yes, these laryngeal clips are like you use in laparoscopy. So they are bioabsorbable, biodegradable, and there is no problem. Usually the patients cup it out.
I now request Dr. Aparna ma'am to present memento to Dr. Bharti ma'am.
All LVA members, please stay behind for the general body meeting.
All LVA members, please stay back for the general body meeting. Please come forward.
Okay, okay.
Thank you all for coming to the meeting. First of all, from the LBA, we would like to thank and congratulate Vikas Gupta for having conducted such a wonderful conference. Thank you, sir. And thank you and congratulations, Dr. PVLN Murthy for initiating travel fellowship. He has donated 5 lakhs for the he's transferring 5 lakhs for initiating travel fellowship. Thank you. So this travel fellowship will be awarded at the LBA annual conference. It will be of 2 to 3 weeks duration, and anybody who is less than 5 years from post PG can apply for this. The couple of locations they can choose from, and 15,000 rupees will be awarded for the fellowship. And we have to this thing. Airway statement account. 3 fellowships. 2 fellowships per year, depending on the finances. yearly account statement, Dr. Convention.
Come tomorrow, but that audited account I'll circulate among the community members of the CPA. Now what we have done, roughly, there is a membership fee which is there, and we have not made any fund of the membership fee because we are spending membership fee mainly on the regular. And now it's another point of discussion, and there are other funds which are for donations, award papers, quiz, and this Laryngeal fellowships. These are the different. They have got individual donations and support for these things. They have different accounts. Like we have got a strong account in which finance has been kept, and we work on the interest of that. And osmolalation and decanulation. Mr. Oswal has donated around 15 lakhs. This was around 15 years back, and we are working on interest from that, funding the air travel of these two orations. Then laryngeal quiz has been, we have created a laryngeal quiz on Arun Goel. Dr. Arun Goel was an excellent and core member of our Laryngeal group from Delhi. So one is sad demise. His wife has donated 2.5 lakhs, and the members have donated 25,000 each. So we have made a 5 lakh rupees fund, and we are giving Laryngeal quiz prizes on that account. This could be the new account which we have created. So on that interest will support the fellowship. Now because we are spending all the